Few people are still having their last bits of coffee, and we can wait for 2-3 minutes, and meanwhile you can settle down. Okay, so I've got a go-ahead from Dr. Chaudhary. So the first session, we have NAFLD potpourri, and in this we are going to have a very interesting debate, and also we would have a very brainstorming lecture by Dr. Saraswat. So for this session, I would like to invite our chairpersons, Dr. A.T. Mohan, Dr. B.V. Tantri, Dr. Dinesh Gupta, Dr. Rohit Gupta, and Dr. Praveen Sharma. I would request all the chairpersons to come to the dais, and I would request the chairpersons to introduce our moderators, who would be Dr. Ramesh Ruprai and Dr. S.K. Tyagi, and also to introduce our first speaker, that would be Dr. Vivek Saraswat. Call the moderators.
Good morning. We'd like to call the moderators for this session, Professor Ramesh Ruprai and Dr. S.K. Tyagi. The first speaker for this session is Professor Vivek Saraswat. Professor Saraswat is a former head, Department of Gastroenterology, SGPGI. Currently, he is working in Jaipur. Professor Saraswat, please.
Good morning, ladies and gentlemen. Thank you, chairpersons. And at the outset, I'd like to thank Professor Chaudhary for this invitation and to this prestigious meeting. So, in the next few minutes, I've been tasked with the task of speaking to you about liver and cardiac reserve in fatty liver disease. I bring you greetings from Jaipur. Now, basically, what do you mean by, let's talk about liver first and about functional liver reserve. This concept has basically come into literature from oncologic liver surgery for liver cancers, HCC, and other tumors. And it refers to the ability of the remnant liver to maintain adequate hepatic function in the post-operative period. Lately, this has also been extended from oncologic surgery to interventions like non-surgical ablative procedures for HCC, but the oncologic context remains. However, in patients with fatty liver disease, that's not exactly what we mean, but impaired liver reserve here would probably refer to the inability of the fatty liver to tolerate acute insults. So, what would this be due to? This inability to tolerate insults could be due to, following surgery, inadequate liver remnant, or precipitation of liver injury, as I will mention in my subsequent slides, as well as the possibility of impaired regeneration of the liver. And the settings in which one would look at impaired liver reserve is in patients who have undergone liver transplantation, when the graft has been fatty. So what are the outcomes when there is a steatotic graft after liver resection? And also recovery from ACLF. The development and the course of ACLF in people with fatty liver disease would give us an idea about the impaired reserve that would exist in these patients. So how does one identify impaired liver reserve? In the oncology context, you have a variety of biochemical tests, the Child-Pugh score, the MELD score, the ALBI, the albumin bilirubin score that one uses, as well as imaging methods like the ICG clearance, the LIMAX test, which uses the clearance of C13 methyl phenacetin, as well as imaging tests using mebrofenin for the biliary tree and acylo-glycoprotein analogs like technetium labeled galactosyl human albumin. And finally, liver stiffness are some of the methods that have been used to assess impaired functional reserve. And which component of liver reserve is assessed and which are the applications is something that is shown here. However, I'll not be talking about this at length because we are not talking of the oncologic perspective of assessing liver functional reserve. But yes, objective methods are available to determine this liver reserve. So is liver reserve impaired in fatty liver disease? The early experience with the impact of hepatic steatosis in grafts in liver transplant was suggested that those who had severe steatosis, that is more than 60% steatotic cells, had a very high risk of primary non-function following liver transplant, and their use of such organs was contraindicated. However, those with milder degrees of steatosis or intermediate degrees of steatosis, mild was similar to no steatosis, while intermediate there was variable results. Similarly, when liver resection was undertaken for moderate to severe liver steatosis, in the early experience reported in 2001 and 2004, there was an increased post-operative mortality in moderate to severe steatosis to the tune of 14% versus 2%. Similarly, the other review also emphasized the high incidence of primary non-function and the reluctance of steatotic grafts being used in living donor liver transplantation, as well as even the results of surgery for NASH initial results were not as encouraging as they were for other indications. So this was a 2012 review in which outcome of using severely steatotic liver grafts with mixed microvesicular steatosis, both were present, showed that there were very high rates of primary non-function as well as suboptimal results in terms of patient and graft survival. And this again reinforced the idea that steatotic grafts do not do well. Recent meta-analysis of 19 DDLT series up till 2017, in which outcomes in patients who have grafts with no steatosis versus mild, moderate or severe steatosis were compared. And again, the incidence of primary non-function and early allograft dysfunction was found to be higher in those with moderate to severe steatosis. And the mechanism suggested was that such patients with high steatosis levels had an increased susceptibility to ischemia, reperfusion, injury in steatotic livers rather than impaired regeneration, and that if the cold ischemia time could be limited, then these grafts could still be used in selected patients. So these slides show that in patients who have no steatosis versus mild steatosis, there was hardly any difference in terms of outcome, but there was significant difference in the primary non-function rates when moderate and severe steatosis was present in the graft. Similarly, for early allograft dysfunction, not much difference with mild steatosis, but significant difference was present when there were moderate or higher levels of steatosis were present. So again, these series noted that there was no significant, while PNF and EAD were more common, the graft survival as well as 1 and 3 year patient survivals were no different if precautions had been taken in reducing the cold ischemia time. Data on living donor liver transplants in this situation is relatively limited. However, a recent study has shown that when this is purely microvesicular steatosis, then the outcome even in LDLT may not be too bad. And in this study from Korea, Han et al., in which 71 donor-recipient pairs undergoing LDLT were compared, and pure microvesicular steatosis only was included, which was quite significant, up to 50% in some of the patients. The results showed that the donor outcomes in terms of ALT elevation as well as in terms of post-operative complications were no different between mild, no steatosis and presence of microvesicular steatosis. And similarly, in recipients There was no significant difference between recipient and graft survival rates, as well as post-operative ALT elevations, and graft regeneration at 2 weeks was similar despite the presence of microvesicular steatosis, and major complications including graft dysfunction and ICU stay and hospital stays were no different, suggesting that at least the presence of pure microvesicular steatosis does not impair outcomes, and what we know is basically refers mainly to predominant macrovesicular vesicular steatosis or mixed forms of steatosis. So overall, livers with moderate and severe steatosis have higher primary non-function and early allograft dysfunction in DDLT series, whereas this supports the concept that possibly the liver reserve may be impaired in these individuals, whereas microvesicular steatosis has no adverse effect on outcomes and DDLT data are relatively scarce. Now, moving on to looking at the outcomes of liver resection surgery in patients with NAFLD, increased complications after hepatectomy for moderate to severe steatosis, that is more than 30% liver steatosis, was reported in an early series in 2007, in which in 14 of 58 patients who had more than 30% steatosis and had more than a 3-segment liver resection showed a significant increase in complications like blood loss, transfusion rates, ICU stay, as well as overall and major complication rates. While a more recent 2020 review of a large database from the US, in which propensity matched case control, a series of as many as 863 patients in each arm were compared, showed a greater incidence, significantly greater incidence of serious morbidity, post-operative biliary procedures, organ infections and pulmonary complications, as well as post-operative deaths due to cardiac problems, pulmonary embolism in these patients, suggesting that poor outcomes in patients with steatotic livers and impaired liver reserve was present in the patient undergoing surgery. Looking at what is happening in patients with fatty liver disease, NAFLD, developing ACLF, centers, this is a Paul Tuluvat study from the US, who have found that there is an increasing incidence of NASH cirrhosis leading to ACLF, accounting for a 63% increase in the admission rates for this indication in the period under review, and 28-day and 90-day mortality in patients with NASH cirrhosis who develop ACLF was higher, significantly higher. These patients were more prone to circulatory failure, emphasizing the presence of cardiac disease, cardiovascular disease in this subset. And however, an early liver transplant recommendation is made for such individuals, since the outcomes after liver transplant were no different than for other indications. If you look at the mortality rates overall for ACLF, according to the Easel-Cliff and according to the APASL criteria that are shown here, 28 days and 90 days, mortality in the NAFLD cohort by the Easel-Cliff as well as with the APASL criteria was significantly higher at 28 days as well as 90 days in this analysis. So, to summarize, impaired liver reserve, that is the inability to tolerate acute insults, seems to be present in patients with fatty liver disease, as is shown by evidence of poor outcomes of liver transplant who receive in cadaveric setting a moderate to severe steatotic graft, as well as patients undergoing liver resections, and in patients with NASH cirrhosis who develop ACLF. Now, moving on to a look at cardiac reserve in non-alcoholic fatty liver disease. This is an area with a vast amount of literature, and it is very difficult to give you a complete overview. So I'll stick to the entity of heart failure with preserved ejection fraction, which seems to be more commonly seen in the NAFLD patients. There is a bidirectional relationship between heart failure and liver disease, both of which are common causes of morbidity and mortality. And this may be present in up to 2/3 of patients with NAFLD who develop disease present to the clinic. Now, sorry for the busy slide, but this basically summarizes data on the epidemiology of cardiovascular disease. And if you look at the hazard ratios, you find that the hazard ratios for cardiovascular disease in NAFLD patients is significantly increased, ranging from the median of about 2.26. Particularly if you look at the entity of heart failure with the preserved ejection fraction in NAFLD, The pathophysiologic processes are understandable. They are what one sees in NAFLD, that is the presence of obesity and impaired increased insulin resistance, sedentary habit, etc., leading to an increased fat load in the liver and subsequently effect on the myocardial lipid toxicity and increased inflammatory mediators. There are a variety of comorbidities that are seen in NAFLD, that are seen in people with cardiac disease, as well as this overlapping set of morbidities that are seen in patients with both problems, and all of this leads to increase in the endothelial dysfunction, cardiac hypertrophy, myocardial fibrosis and arrhythmias, as well as increased cardiac output and left ventricular filling problems, resulting in high in heart failure with preserved ejection fraction. Now, this has been this kind of heart failure has distinct phenotypes, and three major phenotypes have been the obstructive, metabolic, and advanced liver disease have been proposed in these patients. These are easy to understand. As the liver progresses from normal to a fat-laden to an inflamed and then a cirrhotic liver, there's a progressive increase in resistance to blood flow through the sinusoidal bed, which leads to the impairment of venous return to the heart and limiting preload reserve and predisposing to the development of heart failure with preserved ejection fraction. Whereas the presence of inflammation, which is seen in the metabolic syndrome in patients as well as in patients with cardiovascular disease, is possibly responsible for the metabolic phenotype that one sees of heart failure with preserved ejection fraction. Whereas in advanced liver disease, again, as the liver becomes cirrhotic, the shunt fraction increases, resulting in increased spontaneous portosystemic and arterial venous shunting, resulting in high cardiac outputs, contributed with a pre-existing high preload reserve failure due to sinusoidal obstruction. All of this leads to an augmentation of cardiac output responses being impaired in patients with NAFLD. So in the obstructive type, normally one finds high to normal cardiac output at rest with impaired cardiac output whenever there is augmentation required for increased activity, and various activities that are effective for cardiac and NAFLD and cardiovascular disease are effective in this scenario. Whereas with advanced liver failure and cirrhosis with increased blood flow and decreased systemic vascular resistance are contribute to the high cardiac output at rest. Yes, last couple of slides, with impaired cardiac motility and augmentation. So in summary, the heart failure with a preserved ejection fraction has distinct phenotypes in patients with NAFLD. However, more data and more studies are required to better characterize, to get better screening tools, and see who will benefit from screening for this condition, as well as developing better treatments for this condition. Before I end, I'd like to invite all of you to an INAZL single theme meeting that we are organizing at Jaipur in the coming weeks of April on nutrition and chronic liver disease. Thank you very much for your attention.
That was a really beautiful presentation, Professor Saraswat. So that means fatty liver with impaired cardiac and liver reserve must be contributing to impaired performance score or impaired quality of life in patients suffering from fatty liver. And in spite of we making so much hue and cry about fatty liver, people are still very casual about it. They still think that fatty liver is a normal process of there's normal variation. So we must, this is another point we can stress while convincing them for lifestyle modification and for accepting the treatment, that these factors, this disease impairs the quality of life just at fatty liver stage only without significant fibrosis.
Dr. Saraswat, very nice talk.
Thank you.
I just wanted to ask you, is the amount of fat which impairs the reserve, or is it the inflammation or the fibrosis associated with fat?
I think the data that we have, and that's what I've spoken about, is basically deals with the quantity of fat, particularly macrovesicular steatosis that is present in the liver, that seems to impair the cardiac reserve most. Of course, patients with NASH who have inflammation have a further worsening. I have not been able to quote all the literature, but the poor outcomes are more exaggerated in the subset with NASH with inflammation, and of course in as you saw with the ACLF data, once cirrhosis has developed, then again, compared to cirrhosis and ACLF with other etiologies of cirrhosis, patients with due to NASH, NAFLD seem to fare worse.
Any other questions, please?
Shall we move on? Is there no
Ask one question.
Last-
It's not clear to me this concept of cardiac failure with preserved ejection fraction. Cardiac output tends to be high in these people, but what exactly is a cardiac failure then?
I think there's significant diastolic dysfunction that has been reported in these people, and cardiac symptoms of shortness of breath and inability to really exert. See, the cardiac output doesn't increase as the activity increases, so that is supposed to increase. That limits the ability for these people to exert. Florid failure with...
A reduction in the cardiac reserve.
Yeah.
That's your definition of cardiac failure.
I mean, I didn't really talk about cardiac failure here so much as that there is this impaired reserve limits their ability to exert and to talk about.
Reserve,
Yes.
in this context, the
That was what
definition
the
of cardiac
topic.
failure is an impaired reserve.
So the construct of of heart failure with preserved ejection fraction is probably in advance on this. And yes, Arun is standing up, so maybe you can clarify this a bit better, please.
Yeah, so the issue is that you get ventricular remodeling, so it does not relax during diastole, so you have impaired filling. So the contractile, the ejection fraction is still normal,
Okay.
but it is a fraction of a smaller amount because you haven't filled your ventricle. So you are unable to perfuse your body, thus heart failure. And you also have increased lung water because of that. Because if you increase your preload too much and you have diastolic dysfunction, you'll get severe edema and you'll have a congested liver because your heart cannot really fill and pump it along.
Right.
I think
I'm sorry to raise this controversy, but your cardiac output is actually on the higher side. So
Don't confuse cirrhosis with HFpEF. HFpEF is an entire entity by itself and can occur before cirrhosis, it can occur after cirrhosis. And the NASH hemodynamics are very different in cirrhosis than your alcohol and Hep C that you're used to. So these guys all have stiff ventricles, much more so than they have ventricular remodeling of both the right and left ventricle.
I mean,
you know,
yeah, the increased cardiac output is something that you see once ACLF has developed. So it is common to various entities of ACLF and as well as in this
so
etiology.
HFpEF is you no longer have pure HFpEF when you have advanced decompensated cirrhosis, because then all the cirrhotic physiology kicks in on top of your HFpEF. So HFpEF is an independent multi-etiology entity, you know,
Right,
which has
huffing and puffing.
heterogeneous causes. But the key physiologic abnormality is impaired diastolic filling.
I think this conversation can carry on because no clarity, to me it appears is going to appear.
last
So
question.
very short question.
Yeah. We have seen LV diastolic dysfunction, even grade 2 LV diastolic dysfunction in patients with NAFLD, no cirrhosis, advanced fibrosis, and it goes up, and the percentage goes up as the fibrosis advances. When you send to the cardiologist, they are not very enthusiastic in treating it. So is SGLT2 inhibitors way out for us?
Yes, I think one of the entities that he mentioned, SGLT2 inhibitors help
I
for
think there's
NASH
a
as well
talk
as in
on
the
that
cardiac
today.
reserve. Yeah.
I think there's a talk on that today, and
Right.
that might be able to answer.
Okay.
Saraswat, thank you very much.
you.
I think
Thank
every
you.
deliberation that we have must relate to a very simple question and must relate to the advantage of the patient whom we are seeing. Most of the time, the patient questions at the end of the consultation is, how much percentage of my liver is working? And that precisely is the question that the cardiologists are able to answer, that the pulmonologists are able to answer, that the nephrologists are able to answer, but not us. I think it's time that we developed a model where we can actually put it in simple terms as to how much the liver is functioning,
Agreed.
which we as yet have not been able to do so. Thank you very much. I think with this thought, we'll move on to the next
Thank
topic.
you, Vivek. I think Vivek got into a trap. I sent a draft of the program, and he decided to change one topic. And then I said, okay, yeah, you might as well give the talk yourself. And Vivek, thanks a lot. You worked very hard. lot of data, and thanks for doing it. I just interjected here only to tell you that we have two very important moderators today. It took a lot of wooing to get S.K. Tyagi here, and of course Ramesh Rupra is my dear old friend. For many of you who don't know...
Even I'm your dear old friend.
Yeah.
I mean, you can eliminate the old part of it. I'm your dear young friend. You can call Rupra old, but you know...
I just wanted that the morning after yesterday's dinner should be a little more lively, so I think I couldn't think of anybody better than S.K. Tyagi to infuse a little bit of adrenaline into it. By the way, for those of you who don't know, he's acted in a movie. It's a Bollywood movie. And it's been released or it's scheduled for release?
This month or early next month.
So a big round of applause. Please go and see the movie.
You see,
sorry?
You see, I think your introduction should never include this. For last 35 years, nobody has clapped for anything I've talked. The moment you talk about acting in a movie, everybody claps. So, you know, it just seems that those 20 minutes of being on screen have been worth much more than being 40 years on a stage.
But you know, you always like the accolades, and that's why you actually went for the movie.
Yes.
And he's, by the way, acting, I believe, as a police officer?
As a retired IG in the movie, who is the mentor of the negative character.
Oh, great, yes. So wonderful. Welcome here. And now over to you people for a fiery debate. This debate would be very interesting from a very practical point of view. Over to both of you.
So we have a very interesting talk, and everybody thinks that putting down the weight is very good for obese, and Dr. Anil Arora is no less to give for this particular point, that and he has been persuading this idea that weight loss is very important, and he has himself dropped down a lot of weight. So he's a heavyweight speaker, so let us listen to him, his points about obesity and how to reduce it.
And speaking against Arora is not really an easy task, but that has been very valiantly taken up by Krishnadas Devdas, and I'm sure he'll be able to deal with not just the topic, which seems to be heavily balanced against him, but also against Anil, who believes in himself much more what the audience might believe in the topic. So Anil, please go ahead and give your point of view, which will be adequately contradicted by the next person.
Thank you, Dr. Tyagi and Dr. Rai. First of all, in spite of the fact that the second ODI between Australia and India has been washed out because of the rain, I must congratulate Arun Sanyal for scoring his 6th today because of his 6th conclave, and hoping that Dr. GC's Hope Foundation is going to put it into the sky, the Surya Kumar Yadav's aim of treating NASH. With that introduction, first of all, when the topic was allotted to me, I was flummoxed as to what is the debate. What else do you treat in a person who is obese and NASH? But still, since the time was 10 minutes, I have to spend some purposeful time there. The moment you have obesity, you have a lot of fat in the subcutaneous and visceral tissues. Excess amount of the fat will lead to alteration in the phenotypic expression of the fat, leading to release of pro-inflammatory cytokines and decrease in the adiponectin, which, coupled with the fact that you have lot of ingestion of the fat in obese people, coupled with de novo lipogenesis. So you have a lot of incoming fat in the liver, that coupled with altered pro-inflammatory cytokines lead to a cascades of the event which we have been hearing for almost decades, shifting from normal liver to fatty liver to cirrhosis of the liver and finally hepatocellular carcinoma. What happens in patient with NAFLD? Which particular patient is likely to have more fat? Look at these patients. Obesity is the main driver for development of NAFLD, especially those who are destined to undergo surgery. 92% of those with obesity requiring surgery will have fat. In fact, for all the patients, if you look at development of NAFLD, obesity is the major contributor to development of the fat. The more obese you are, the more likely that you will have fatty liver disease, and more obese you are, more likely that you will have an advanced fibrosis, as has been very well shown in this diagram. Not only that, as Dr. Vivek very elegantly showed, that there is a excellent multi-directional, not only bi-directional, multi-directional relationship between the cardiovascular disease, diabetes, obesity, and FLD. And mind you, when patient comes to you in your clinic, you treat the patient in whole, that is a Hippocrates oath. You do not just keep on looking at the minuscule component of NASH, look at the patient in toto. And this patient with metabolic syndrome, obesity, and NAFLD has plenty of problems which are intertwined. Obesity per se will lead to high mortality both in the young individuals as well as in people who are old. There will be higher risk of mortality in young individuals, and as the age advances, the mere fact that you have obesity, you have higher risk of dying of cardiovascular disease. Even in those who have NAFLD with obesity, we should be very clear that you never die of liver disease if you have NASH. The major contributors to death in patients with the NAFLD is the cardiovascular disease and non-liver cancer. So why is it that we are focusing and have a laser focused attention on NAFLD and the liver disease when patients with NASH are dying of the disease entities other than the NASH, because the major contributors are different. And then there is an excellent intertwining relationship between obesity and NAFLD. In fact, if you look at the way the disease processes occurred after the green evolution and green revolution, over a period of time, both of them have emerged together. NAFLD will occur if there is a obesity, and if you have obesity, you are likely to have obesity. So they are intertwined. They are two different faces of the same coins. So why differentiate between the two? And I'm sure this slide has been shown to us umpteen times, and we remember it by heart. But if you split the component, and it's very clearly shown, the more of weight loss you have, the better will be the improvement in the different component of the liver disease. You can improve inflammation, ballooning degeneration, deposition of the fat, but what matters is the resolution of the fibrosis. The highest resolution of the fibrosis will occur if you have the excellent weight loss of more than 10%. So I do not understand why this debate at all. If you are obese, if you have NASH, why not treat obesity? If you treat obesity, you will be taking care of almost everything. Look at this ASLD guidelines for non-pharmacological management of NASH. First and foremost is weight loss. Weight loss is akin to loss of weight in patients with obesity, exercise and bariatric surgery. In fact, there have been increasing data to show that as a primary treatment of NASH in patients who do not have advanced cirrhosis, bariatric surgery may be one of the best way of treating NASH as of today. And if you treat obesity, or if you tend to have more and more weight loss, look at the incremental advantage to your patient. You are treating his diabetes, his hypertension, his dyslipidemia, NAFLD, and if you are able to achieve a sustainable weight loss of more than 10 to 15%, you are going to improve NASH. Not only that you are improving NASH, you are also decreasing his mortality related to diabetes and cardiovascular mortality. How do we achieve a weight loss in a patient who has excellent evidence of inflammation in the liver as well as deposition of the fat in the liver? Medication have its own limitation. Bariatric surgery gives you the best way of losing weight, and I'll show you how weight loss will improve almost all components of fatty liver disease and NASH. If you want to have any improvement in the liver related to the weight loss reduction, you need to have at least 10% of the weight loss to improve NASH. But even if you cannot achieve a 10% weight loss with so-called lifestyle modification, even lesser amounts of weight loss are going to improve different components of the metabolic syndrome. Mind you, all these components will have different morbidities in a given individual, and hence even smaller amount of the weight loss in an obese patient is going to give you some dividends. The more the weight loss, more the resolution of the fibrosis. If you can achieve a 10% weight loss, you will have a 70% resolution of the NASH, and over a period of time, 30% of the patient may even have a regression of the fibrosis of the liver. But are we able to achieve this weight loss with current therapies, which we keep listing from Dr. Ajay Duseja almost on daily basis? Obeticholic acid, Romisetron, Elderfermin, Pegbalfermin, Firsocostat. What do they achieve? They hardly achieve any weight loss. to the dismal tune of 1 to 2%. This is not something which is going to do anything to the obese individual who have NAFLD. Look at the bariatric surgery. If you have a substantial weight loss, you are going to have substantial reduction in the adverse events related to the liver, as well as you are having a substantial reduction in the cardiovascular mortality. Not only that, major chunk of the NASH resolution occurs over a period of the time with extensive weight loss. Not only resolution of the NASH, if you just have patient over the 5 years, a substantial portion of the patient losing weight will have resolution of the fibrosis also. Semaglutide has been shown to improve NASH over a period of time, over a 68 period. But what is it related to? Look at this, 18% weight loss is what is going to give you resolution of the fat. So for any resolution of the fat in the liver or resolution of the fibrosis, you need to have weight loss which is achieved by controlling obesity. I'm sure all of you are aware of this study from Ali Lilai, which has shown that over a 72 period, the use of GLP-1 analogs lead to reduction of the fat. That coupled with recent introduction of glucagon agonist. So you have a drug which is a GLP-1 agonist and glucagon agonist. So it mimics a decreased dietary intake and increases exercise in an aim to reduce weight. And in this mouse model, within a period of 12 weeks, you have almost doubling of the weight loss compared to GLP-1 agonist alone. And look at this mouse model again showing that compared to the monotherapy, within 12 weeks period, you have almost complete resolution of the fat if you use a combination of GLP-1 agonist with glucagon. And based on that, these authors also conducted this phase 1 study called MAD trial. I don't think it is a MAD trial, it is a multiple ascending dose titration trial in which with increasing doses of these drugs, look at this 12 weeks reduction in the weight, almost double of the GLP-1 agonist monotherapy. 100% of the patient will lose more than 5% weight over the next 12 weeks, whereas 50% of the patient in 12 weeks, mind you, 3 months is the first time you can ever achieve a weight loss. And then MRI-PDFF, if you look at 12 weeks, almost complete resolution of the fat. This is something which may be a game changer in the future. So ladies and gentlemen, if you want to treat NASH and obesity, the baseline has been lifestyle modification. Look at this static figure. Nothing can change. Patient doesn't listen to you, and this is what the patient can achieve. Best answers comes from 30% reduction in the weight with bariatric surgery, which many of us do not take it regularly because of our own mindsets. So what is happening is that you have increasing number of drugs which are trying to emulate the results of the bariatric surgery with short-term therapy. So the current algorithm for management of obesity with NASH, first step is lifestyle modification to restrict fat, that means treat obesity. Second step is again to lose weight using...
Already have the advantage of a biased topic, but you can't exceed your time limit. So
just last slide.
10
Finish.
seconds.
Yeah. And then in third step, if you do not do anything, then you switch on to bariatric surgery. So I think in patient with obesity in NASH, we should treat obesity in NASH and not NASH in obesity, because you have collateral benefits, you have improvement in fibrosis as well as improvement in outcome of so many other components of the metabolic syndrome. Thank you.
Well, whatever Anil you said seems more easily said than done. Saying that patients would lose 10% of body weight and that also visceral fat just because you told them so is not necessarily what is achieved, and therefore the next speaker is probably going to counter you by saying that let's concentrate on more achievable targets than the ones which are more theoretical and more appealing to the patient but rarely achievable. You have your time, and we've already acknowledged that you have a difficult time, so even if you counter him on a few points, I think it'll put him on a back foot.
Good morning to you all. At the outset, let me thank the organizers, especially Gaurdas sir, for having given me this opportunity. And this topic has been allotted to me, and people have been trying to psych me out for the past 1 week, starting with our previous speaker, Dr. Anil Arora, because last week we met in the ACG, and he said, what is the debate? Just, and now the moderator also is trying to psych me out. So I wonder whether this is where I stand. Unfortunately, I'm not Perry Mason, and I don't have Delastrate with me. So I agree with some of the points that Dr. Arora mentioned. But one thing you have to understand that all patients who are obese are not metabolically unhealthy. There is metabolically healthy obesity. So we should not go and overtreat obesity in these patients. And another thing is fibrosis is the key. Even though we are all fixated on NASH, probably because of the therapy, for clinical trials, NASH is very important. Fibrosis is more important. And several studies, meta-analysis, systematic reviews have found that as the fibrosis increases, mortality also increases. But recent couple of meta-analyses have shown that it is not actually cardiovascular mortality, but it is the extra hepatic malignancies and liver cirrhosis that is the major driver of mortality in such patients with NFL. And Dr. Arun Sanyal has presented that cirrhosis regression is associated with improved clinical outcomes in patients with non-alcoholic steatohepatitis. So weight loss is important. I agree with Dr. Arora. So if you look at the highlighted portions, you find that fibrosis regression, which is what we are targeting, occurs in 45% if you have a weight loss of more than 10. If you have a weight loss less than 10, it does not matter whether you do not lose weight. Your weight loss is 5 to 7% or more than 7%, but less than 10%. So how many people can achieve this weight loss? So in fact, losing weight may be the easy part. Studies have found that up to 30% of individuals who are given dietary restrictions and lifestyle alterations lose about 5% weight loss. A third of that is about 10%, will lose about 10% of your weight. But the problem is, it's not the weight loss, but you regain the weight. About 20 to 25% of these patients who have lost weight, regain weight over 2 years. So the net number or percentage of patients that will lose about 10% weight is around 7%. And again, if you diet, what happens to your metabolism? Your metabolism slows down. And repeated diets will slow down your metabolism and make it much more difficult for you to lose weight. And again, fixating on obesity, management alone may lead to lack of optimal management of other comorbidities. Remember that obesity is just one of them. And it is better to see the bird as a whole instead of just the eye of the bird. Now, as the stages of fibrosis increases, the progression rate also increases. The time to get to the next stage decreases significantly. So weight loss is definitely good. I agree with Dr. Anil, but the chance of achieving and maintaining it, that is more than 10% weight loss, is only about 7 to 8%. So what is the alternative? Is there an alternative? If you can you change the diet composition instead? Excess saturated fats, refined carbohydrates, sugar, sweetened beverages, you ask the patients to avoid. That is easier said than done, but it may be easier than following a diet. Reduce fructose. Previously, we used to think that fat is the enemy. Now we say that sugar is the enemy. But actually, fructose is a real dangerous sugar. Fructose is 100% extracted by the liver, metabolized in the liver, and de novo lipogenesis is much more with fructose. Fructose in the sweets, the fruits may not be that harmful, but high fructose corn syrup, which is present in practically everything, is ubiquitous because of its cheapness, its sweetness in all the pastries, should be totally avoided. And what about fasting? So we hear a lot of intermittent fasting, 5+2, 4+3, 1+1, and even the time-restricted feeding. You eat for 8 days, 8 hours a day, and fast for 16 hours. That brings in the phenomenon of autophagy, which will improve your overall health, even if it does not make you less fat. And another thing is the Mediterranean diet. It has been touted as something that improves your cardiovascular health status and has been found to improve your fatty liver and to some extent fibrosis. Can we adopt it? It is basically just fruits, vegetables, legumes, nuts, a bit of fish, a bit of wine, which we can avoid, And the problem with our diet is we won't be able to use olive oil. So Indianize the Mediterranean diet and use it. Coffee, that is easy to take, and most of us love coffee. And several meta-analyses have shown that. Even large studies have shown that coffee reduces mortality, coffee reduces fibrosis, and if you take more than 3 cups of coffee a day, it is supposed to reduce fibrosis. And exercise. Should we add on exercise to diet? Can you lose weight with exercise? Very difficult to lose weight with exercise was shown yesterday. The amount of exercise you have to do is humongous to produce a significant weight loss. But exercise has several important things. Independent effects of physical activity in patients with non-alcoholic fatty liver disease has been shown. And AASLD 2023 guidance says that patients with NAFLD should be strongly encouraged to increase their activity level to the extent possible. Individualized prescriptive exercise recommendations may increase sustainability and have benefits independent of weight loss. If you cannot do aerobic exercise, at least advise your patients to do resistance exercise. The good things are manifold. So pharmacotherapy, I won't be going into details. We have got the vitamin E from the PVENS trial, the pioglitazone, GLP-1 RA inhibitors, GLP-1 RA plus GIP-RA tirzepatide, SGLT2 inhibitors, which this conference is practically highlighting. And we have got the homegrown saroglitazar, which is an advantage that we have. And most of us have experience with saroglitazar and have found it to be useful. Now, if you look at vitamin E in the PVENS trial, it does not show any improvement in fibrosis. And no study has shown improvement in fibrosis with vitamin E. However, studies have shown that there is a reduction in decompensation if you use vitamin E for a longer period of time. So it may be that fibrosis is not progressing, even if it is not regressing. And long-term pioglitazone also has shown some effect in fibrosis improvement. It has reduced the fibrosis score by about 0.5 in this study. So pioglitazone is another drug that we can use, even though it is not too much favored drug for gastroenterologists or even for diabetologists because of its side effects. So to the future, looking at the horizon, there are many new molecules which may improve your fibrosis without venturing too much into the treatment of obesity, like THR beta agonists, FGF19, FGF21 agonists, to mention a few. So in conclusion, you should have a personalized approach to patients, whether they are obese or non-obese, whether they have, and with NAFLD. Weight loss is difficult. Keeping it off is even more so difficult. However, weight loss should be attempted, especially in patients with lower degrees of fibrosis. If you have F3 or F4 fibrosis, don't wait for just weight loss. You have to attempt other things. So alternative approaches acceptable to patients has to be explored. And at-risk NASH patients should not be dilly-dallied with. A multi-pronged approach is essential. Thank you.
Thank you very much. Primarily, what I gather from what you said is that, all right, you have an elephant in the room, and I don't mean by its sheer body weight, so do treat it. So if you see a very obese patient, obviously you're going to advise weight loss to that person. Yeah. But what about those who are lean NASH? Can you have obesity? He is not obese. So what you're saying is that the target changes, the primary therapy changes. If you have diabetics who are not obese but have got a high level of dyslipidemia, then the targets of the primary therapy changes. If you have people who have neither but only hypertriglyceridemias, the primary therapy or the primary aim of treatment changes. So what you're saying is, it's not just one thing. You have a patient, you have to tailor-make your primary therapy or primary target towards what the patient's
maybe you should be less of Arjuna and more of Duryodhana. Don't focus on the eye of the
Anil, you have 2 minutes to counter it, and then he'll have the last word.
I think he has agreed on most of the points which you suggested.
Thank you, Dr. Krishna. I think you have reiterated whatever I had said. If you see even his concluding slides, everything mentioned on weight loss. I fully agree with you, it's not easy. Then why do we have Dr. Arun Sanyal with us? He's there to help us out to reach a weight loss with the new pemvidutide combination which is coming into being. You can achieve 20% weight loss in 12 weeks. So if it is not achievable today, we have the services of Dr. Arun Sanyal. So you agree that if you cannot achieve, there is a way of achieving it. But I think you have reiterated whatever I have said. You said weight loss is most important. You said fibrosis regression. I have showed you best way. And mind you, Dr. Krishna, this was a debate on obesity and NASH. What Dr. Tyagi was saying, NASH will have different components. If you are not obese, you are thin. Obviously, you will not lose weight. You are already thin and lean NASH. But in obese NASH, if you do not treat obesity, then it is taking your team to World Cup test finals in November in Australia without Shubham Gill, Rohit Sharma, and Virat Kohli. If you think you can still win the final, then I think I am making a fool of myself. There is no way you can treat obesity and NASH without looking at obesity. You have reiterated whatever I have said.
Dr. Anil, 1 minute. Dr. Anil.
Anil, you can't run away. Dr. Rupra has a question for you. Basically, how are you defining obesity by BMI, and is BMI really the gold standard for obesity?
Absolutely. But for the present, I think, context, you have to go by the BMI has been defined both in the Western world as well as in our own Indian context. We in India have obesity and the related complication at a much lower BMI. At 2.5, there is the difference between Indian and the Western
Salman
standard.
Khan is obese.
Salman Khan is obese, but is active otherwise.
Anil, we were just discussing yesterday also. What is your understanding about fit fat? Would you like to comment?
Yeah, you see, so far as now,
Because
this
if
was
the
another
best-
important question which he has raised, that if you are metabolically fit, then it doesn't matter. But at some point of time, there are multiple hits. Everybody knows that if you just have a fat in the liver, even if it is to another 60% or 70%, unless the patient is being operated upon, you will have no problem. But then you have something lying in the liver which is looking for a second hit. That second hit can come anytime. It could be in the form of drugs.
Okay, so now you have 2 minutes of rebuttal, further rebuttal from Krishnadas, and then we'll open the...
Yeah. We have a polling question also left.
Be here, sir.
Thank you, Anil. I think you missed my last slide, probably. I think that obesity should be treated. The point of a debate is not to be dogmatic. It should be pragmatic. So it should be individualized. All patients, as he said, if Salman Khan is obese by BMI, you don't treat him. So you have to have a personalized approach. So there are many other methods by which, even though we are not treating obesity, you can improve your liver. So that is the point I was trying to make. It is just not fixating on obesity and missing all the other things. There are many other things, and as I said, only 10% of the patients will be able to lose about 10% of weight, and that is required to reduce fibrosis.
Yeah.
And many of these patients regain it. So you should not be fixated on obesity. You can treat obesity fine, but other options should also be explored.
See, the title says the primary target should be obesity. It doesn't say all targets.
Anil,
There
the
are
debate-
secondary targets.
The debate
also.
ends. We now open it to the House for questioning, and you are now, both of you are now in debate with them. So please come and relax and sit down here and answer their questions.
Anil, I think you can stay there. There's no chair there.
There's no chair there. So as a punishment, you
let's
stand.
Not, split hairs about the title, and I think we all know what.
Please
we're
don't talk
talking
about splitting hair to Anil.
Already split everything.
That's not fair.
No concession
That's
on
not even
that.
hitting below the belt. That's hitting way above the
You
head.
have to really look to find a hair, yes. And yes, as Tyagi said, even I would be obese by current definitions of, if you look at some, let's not look at what is the definition, and to say that because the title says obesity, you're talking about it. There's a vast majority of Indians who are 25 to 30, overweight so-called, who are in the NASH category, and also need to be dealt with. If you're somebody who's over 30, over 35, I agree the targets are more or less in line with what you said. But there's a huge number of patients in the 24 to 30 range which need our attention. And I would agree with Dr. Krishnadas that you see every intervention, there is always a category, irrespective of weight loss, this has metabolic benefit. So that is the point. It's not that if you're able to achieve weight loss, fine, but whether it be exercise, whether it be drugs, whether it be other interventions, modifications of lifestyle, intermittent fasting, time-restricted eating, all of them you have metabolic benefits irrespective of weight loss, which is what is emphasized. So you may lose weight, you may not lose weight, but I think the message should go across that this is multi-pronged. And each intervention has its, and you should be looking at, when you say obesity and NASH NAFLD go together, yes, they go together because there is something behind it which is driving both. It's not saying that obesity is driving NASH or NASH is driving obesity. There is something else behind that is driving both. And if you are able to address that dysregulated metabolism by whatever intervention we are doing, the patient will benefit.
Arun will tell us what else is going behind the back scene.
I'm not debating with you about obesity. My question is, what is your focus? Is it lifestyle modification? Is it bariatric surgery? Or is it GLP-1 agonist? In your huge experience, which is going to work?
Irrespective of what you do, so far as you are able to achieve a substantial weight loss, everything will fall in place. Irrespective of how you do. I think this new concept of GLP-1 agonist and glucagon agonist or GIP-1 agonist, that is going to be the game changer.
Can I make a comment?
Oh, yes, of course.
The time is yours. I find that chairperson and moderators are unusually hostile to Anil.
For a change.
Because they are my close friends also.
For a change, they are hostile to Anil. Otherwise, Anil is very hostile to all of us.
When you're talking about obese NASH, that means it's a NASH with only one other factor, that is obesity. And I quite agree with him.
There is no debate.
Everything should be weight loss.
But, you know, I'm not just being biased. I actually said he's got a biased topic. I agreed with that right in the beginning. That he already has the advantage of a topic that is, you know, in his favor. If the topic had been obesity should not be the primary target point, it would have been more interesting.
What I would like to add,
I think the speakers for the debate were selected from the body habitus.
Who is speaking? I can't.
Yeah, I'm speaking. Yeah. So I think the message which we need to give to our patients is that even if you're, I'm saying it with my personal experience, it's extremely difficult to lose weight. And even if you lose weight, it's difficult to maintain it. So I think the message we need to give to our patients is even if you're not able to lose weight, move.
Yes.
Be active. Start walking. If you're sedentary, start walking. If you're walking, start doing brisk exercise. So I think the focus only on weight loss demotivates our patients. They come back after 3 months, haven't lost much weight, have lost 1 kg, have gained 1 kg. So I think excessive focus on weight loss should not be a practical real thing.
I think with the cinematic, comments from Professor Tyagi, so I think both of them did a fantastic job. But what we tend to forget is many people in India are obese, and about a third, and they don't lose weight. We tell them everything, what all things that we can do. So, but the primary focus is to reduce the transaminitis, or reduce the necroinflammation in the liver, or reverse fibrosis. That should be the aim. I think obesity management is only a part of it. I think we should go extend beyond, because I have patients, even last week I was seeing a patient, vegetarian, and absolutely doing 5-kilometer walk every day, brisk walk, not losing weight, not even 100 grams. So, but now there are drugs which can reverse the fibrosis and bring down the necroinflammation. So I think weight reduction is one aspect. I don't think that alone will work.
Can we have the last comment from Dr. Sanyal so that...
Dr. Sanyal, your last biased comment, please.
Why biased? He should have unbiased comments.
Yeah, I really didn't want to be put on the spot over here and got shot from both sides. I think the key is you're both right, because the disease, as it progresses, changes from a predominantly cardiometabolic disease to a liver-dominant disease. And the tipping point is when you get to bridging fibrosis. So as hepatologists, the target population for us is the patient with advanced fibrosis who has not developed clinically significant portal hypertension, because that's when we can have the biggest impact. Once I think they get clinically significant portal hypertension, currently we do not have effective drugs. Maybe they will come in the future. But very early on, they're not dying of liver disease, not in a 5-year time horizon. It's cardiometabolic. But it's only when you get to that advanced fibrosis. So I think both of you are correct. And that's my politically correct answer.
Thank you. We've had a very
diplomatic
debate. and we've had a very diplomatic conclusion. Everybody, thank you very much for laughing at all the right points and clapping at all the wrong ones. Thank you very much.
Dr. Tyagi, I think there is a audience poll. So can that be put
yes,
to
there's an audience
poll?
Yeah.
Can you have the last of my slide?
So, is that by a...
Yeah, there is one poll
There is a
question.
pad there.
There's a
Yeah.
pad everybody's got.
Yeah.
So please go through this. And in the next, what?
10 seconds.
10 seconds, you have to press the right button. No booth capturing. Please do it on your own. So what
Weight
what
loss.
was C?
Weight loss.
Okay. Right. So we should have had this before, whether anybody changed their opinion after listening to them. But yes, Anil, you have stuck on to the general perception that
Weight loss is
advise
important.
everybody weight loss. So see you 5 kgs leaner next time. Best of luck.
For
And, let's
lean
move
Nash
on to the
debate,
rest of the
lean Nash debate, you want me next time?
Whichever. Thank you very
Thank
much.
you very much. I must thank, apart from the speakers, the chairpersons and the moderators. I think you livened up Sunday morning. Thank you very much for doing that. Big round of applause for them. We are running a little late, but nevertheless, I thought that, let's all warm up on a Sunday morning.
Request
Dr. Saraswat, please, Vivek.
I think it's always the best solution to kick off the days with debates because it livens it up, and it's great to see on a Sunday morning a crowd which is almost filling up. So I think one takeaway which many of us would go back from this conference is to become possibly what we can call in a new term of hepatoendocrinologist, because a lot of focus on becoming better with your diabetes management, and that brings us to the next session, which is about the most talked about drugs in the current scenario with new trials coming in every day. That's about GLP-1 analogs. And for that, I would like to invite the chairpersons for the session, Dr. Sunil Dadich, Dr. N.P. Bohidar, Dr. Lalit Shimpi, Dr. Zubin Dev, and Dr. Ashish Kumar. I'll also like to invite the moderators for the session, Dr. Ajay Bhalla and Dr. Narendra Chaudhary.
One important housekeeping announcement. Please fill the feedback form which is kept in your table. This is very important to us. Please fill the form.
Good morning, and we move on to the session on pharmacotherapy, and it's my pleasure to invite Dr. Arun Sanyal to give his lecture on GLP-1 biology and scope in an FLD. Dr. Arun, please.
Good morning. It's a tough act to follow after the exceptional debate we just heard. So my job is now to switch and talk about GLP-1s. And my job today is really just to set the stage, because we're going to have more discussion about GLP-1s. And here are my disclosures again. So we'll start with a question, which is, what is the principal mechanism of action of GLP-1 agonists in NASH? Suppression of hepatic lipogenic genes, increased hepatocyte fatty acid oxidation, increased adiponectin production, in the liver, decreased delivery of fatty acids and glucose to the liver, and reduced intestinal permeability. Can we have the audience poll, please? It's a pre-test to see who knows what. Audience poll, please. Kya hua? All right, well, moving on. You lost your opportunity, okay? You all know what you know, and then we don't want to get any further behind. So GLP-1 is an incretin. It is released from L cells in the intestine, and essentially GLP-1 and glucagon are almost alike, and they have a common precursor. And through alternate splicing, you either make glucagon or you make GLP-1. In the intestinal L cells, you release GLP-1. GLP-1 sensitizes the islets and allows it to release insulin, so it is therefore called an incretin. Now, GLP-1s have many biological effects, and they have principally a central effect where they affect the satiety center and reduce appetite. In addition to that, now it turns out GLP-1s have a myriad non-CNS effects as well. From the cardiovascular perspective, it has some cardioprotective effects. From a vascular perspective, it has been shown to reduce strokes. From a renal perspective, it reduces the slope of decline of GFR in people who have metabolic syndrome. In addition to that, from a gut perspective, it reduces postprandial lipidemia. From a pancreas perspective, as I mentioned, it's an incretin, releases insulin release. And so many of these, actually, from a fatty liver disease perspective, also are potentially beneficial. Now, very important, GLP-1 receptors are not present in the liver. So all of the effects of GLP-1 are mediated through its effects outside of the liver. But through all this reduction in adiposity and systemic inflammation and improving the overall metabolic health, it reduces inflammation. The delivery, because it improves insulin sensitivity, it reduces fatty acid and glucose delivery to the liver, so there's less substrate to form fat. And so it improves glucose metabolism, and it also essentially results in improved glycogen stores. So there are a number of GLP-1 agonists that have been developed, and semaglutide right now, as you talk about pure GLP-1 agonists, is the one from a NASH perspective, is the one with the most data, although all of them have same class effects. And these are the original data with semaglutide with 0.05 all the way to 0.4 milligrams, showing you can get 10 to 15% weight loss. And with the current dosing of 2.4 milligrams weekly, you can get up to 20% weight loss with semaglutide within 6 to 12 months. Now, of course, the weight comes off, but if you stop the drug, the weight comes back on. So we still haven't solved that problem of needing therapy long-term once you start therapy, unless you work on the behavioral underpinning and allow people to change their lifestyle enough while you're pharmacologically bringing their weight down. Now, the reason GLP-1 agonists have taken the metabolic field by storm is summarized in this slide. If you look at all-cause mortality, composite renal outcome, worsening of renal function, or hospitalization for heart failure, in meta-analysis summarizing the data, it is significantly superior to placebo for all of the above. And in people who are at metabolic risk, especially diabetics, it has been shown to improve glycemic control, core MACE, renal function, and actually there's early data that it reduces neurocognitive decline as well. You've seen this data with semaglutide. You get 59% resolution of NASH, but the effect with fibrosis is more modest. But if you look at the proportion of people who have progression of fibrosis, if you look at the placebo shown on the far right of your screen, you will see that it's about 18%. Then if you look at dose-wise, what we found is that there's a progressive dose-dependent decrease in the proportion of people who had progressive fibrosis. Remember that GLP-1s are working outside the liver. Then they have to reduce fatty acid and glucose delivery to the liver, reduce the fat in the liver, which in turn will reduce injury, which in turn will reduce inflammation, which in turn will reduce fibrosis. So the first thing when you slow this engine down is reduced progression before you get increased reversal. So it does work. Already the field has moved far beyond pure GLP-1. So from a weekly GLP-1, there are oral GLP-1s. Oral GLP-1, the original one with semaglutide, is about half as effective as the injectable one, but there are other second-generation oral GLP-1s that are looking really good. And beyond GLP-1, there is a combination with GIP, which allows you to dose higher, and combination with glucagon, which actually has direct liver targeting. And then there is a triple agonist with GLP-1, glucagon, GIP that I will actually present the data at the ADA later this year. And then, of course, there are oral small molecule agonists that have been developed. The GLP-GIP co-agonist, the GIP has additional effects both in the liver and in adipose tissue, which insulin sensitizes, and of course also allows higher dosing of GLP-1 because it ameliorates the nausea to some degree. And tirzepatide is the prototype compound for this, and this is the New England Journal paper. And as you can see over here, the degree of weight loss that you see over here is about 25% within 72 weeks. So we are really talking about bariatric level weight loss with tirzepatide, and in diabetes trials, dramatic improvement in liver enzymes, FIB4, and all the other markers of liver. And there's a phase 2 trial that is fully enrolled. We will report the results next year, this time with tirzepatide. GLP glucagon, similarly, glucagon oxidizes fat in the liver and actually improves mitophagy and generation of healthy mitochondria, thus reducing oxidative stress and inflammatory injury signaling from the glucagon, in addition to the extrahepatic benefits of GLP-1. And you saw, Anil showed this data with pemvidutide. There's also another molecule called cotadutide. Pemvidutide really is lead in class in terms of defatting the liver, and you can see pretty dramatic absolute and relative defatting of the liver. And there are already clinical trials with triple agonists for NASH that are ongoing. Hanmi is a Korean company which has a triple agonist. So to summarize, GLP-1s has emerged as a key anchor for the treatment of metabolic syndrome because of weight loss, improved MACE, improved renal outcomes, and glycemic complication. Second and third generation compounds are producing bariatric level weight loss and are likely to become the true comparators to bariatrics as medical therapy in the future. Nausea and GI tolerance are the main adverse events, and it really, you have to take, if you're going to use GLP-1s, you have to spend, just like with interferon, you have to learn how to use the molecule so that it is tolerable for the patients. Just telling them to take GLP-1s is not going to work because they're all going to come back vomiting and they'll stop taking the drug. So this is something that we can talk about in the discussion later. Thank you.
Thank you, Dr. Sanyal.
Yeah.
One question, Dr. Sanyal. Any comment on oral versus subcutaneous semaglutide efficacy? Any difference?
So the oral is half as effective as injectable. And so that's the reason it sort of fell by the wayside. But there are other oral molecules in development that look quite promising right now. So to my knowledge, oral semaglutide is not being developed any further, not for NASH anyway. But there are other molecules that are being developed.
Arun, excellent presentation as always.
Thank you.
My question is, why does placebo have an efficacy of 20 to 30% in all the trials, including your own PAVENS trial?
Well, you know, that has to do, first of all, this is actually the reason why you have to have a placebo-controlled trials, because people do things that are not always captured. Even when you go into a trial, even when you tell don't change anything, people change something because they know I'm doing some research. They'll be a little bit more mindful of what they're eating. They will do things without that you will not be able to capture. And that's why I think the placebo group is so important. Plus, there is noise in histology reading, we also know. So there's also intra-observer, inter-observer, all of those variability issues that come into play, sampling variability. So it's a combination of all of those, and this is one of the biggest challenges in doing trials, because sometimes you get a 7% placebo response rate, sometimes you get a 20% placebo response rate, so you cannot really figure out how to plan your study.
Thank you, Professor Sanyal. I think we'll need to move on for want of time. We can have the questions and coffee. So we go on to the next talk by Dr. Amit Mando, who is a good friend and a senior consultant hepatologist at Global Mumbai. So he'll be talking on GLP-1 drugs for obesity and NAFLD. Dr. Mando.
Yeah. Thank you, Dr. Lalit. Thank you, Professor Chaudhary, for giving this opportunity. So after Professor Sanyal has set the stage, I would like to go into what the data shows about the GLP-1 agonists in obesity and NAFLD. So that's a topic given. So just to classify the GLP-1 agonist, on which I would be spending the maximum time, we have the short-acting ones, which is the exenatide and lixisenatide, which the half-life is less than 12 hours. Intermediate-acting ones, liraglutide, 12 to 24 hours, and the long-acting ones, the dulaglutide and semaglutide. And then there is a continuous-acting one, which has a longer half-life. So what do we have in India? It is good to know what's going on abroad, but we also need to know what we have in our armamentarium today. And these are the GLP-1 agonists which are available in India. We only have currently semaglutide, which is oral. We do not have injectable semaglutide, except for some patients which it can be ordered. So these are the things we have. We have liraglutide, which is once daily, dulaglutide, and semaglutide oral. So this is the first two are the short-acting ones. And of course, liraglutide is once daily dosing, which can be used. And dulaglutide is a long-acting one, which is once a week. So going into the data on obesity first, this is the data with the liraglutide, the classical scale study, which has been published. So initially, it was for pre-diabetic population. The scale 1 and 2, it was initially for pre-diabetic population. They were non-diabetic. It was only for obesity. And the BMI which was chosen in these patients were either more than 30 or more than 27 with dyslipidemia. So these were the patient group. And in the first scale study, 3,000 patients were enrolled, 56 weeks, and it showed almost 8% weight loss, which was very encouraging. And a few of those patients were then continued for 160 weeks more to see whether they would prevent the development of diabetes, because almost 86% of these patients had pre-diabetes. So there also, there was a weight loss of almost 6%. Then it was further studied in the diabetic group, 600 patients for 56 weeks, and the effects were almost similar, 6% weight loss over that. And then in various sub-populations like patients with sleep apnea and obesity, it has been used. There has also been a study wherein there has been a run-in weight loss with an aggressive diet modification, a very hypocaloric diet of 1200 kilocalories. So both the groups were given that diet, and then then liraglutide was given, and it showed that there was a 6% additional weight loss. So definitely efficacious drug over and above the hypocaloric diet. And then what about semaglutide? Semaglutide, there is of course the STEP trials, the phase 3 program, where the primary target was to see for the weight loss. And it was again across various subgroups in non-diabetic population, in diabetic population, and the dose was 2.4 milligram once weekly. So initially it was given for 68 weeks, and then there was a 7 weeks follow-up where the drug was allowed to be washed away because it has a long half-life. And clearly there was And mind you, these were all given in a graded manner. So they were started with 0.25 milligram, then 0.5 milligram, so every 4 weeks. So tolerability is a big issue. All these trials, the drugs have been increased gradually over 4 weeks, and around 16 to 20 weeks, they would reach their target. So again, significant weight loss to the tune of almost 15%, and almost 16 to 18 kgs weight loss across all subgroups, and also sustained weight loss over more than a year as compared to placebo. Coming to the Pioneer program, which is the data on oral semaglutide, which is what is available to us today. As Professor Sanyal just mentioned, that the weight loss is just as half. So if you look at the oral semaglutide data on obesity, almost 90% of patients had more than 5% weight loss, and 60% of patients had more than 10% weight loss. If you look at the Pioneer program, we don't have much data on NAFLD as far as this oral semaglutide is concerned, but weight loss, yes, 5% weight loss, almost 50% would achieve even with oral semaglutide. Not as efficacious, half as efficacious, but nonetheless better than placebo. There is reduction in waist circumference, and HbA1c reduction is also there, but yet it is not approved for weight management. Coming to the NAFLD data now, from obesity we move also to NAFLD data. Coming to these 4 important studies on liraglutide, the first one is the Armstrong et al., where 52 NASH subjects were randomized control trial. This is a classical lean trial which was published in Lancet, and this was a biopsy proven study, placebo-controlled 48 weeks, where there was 39% resolution of NASH versus 2% in placebo. So significant effect as far as NASH resolution goes. 9% had progression in fibrosis in liraglutide group. Then there have been other studies in diabetic population. So this was in a non-diabetic population, which was mainly for NASH. And then there was 87 subjects studied by Feng et al. With type 2 diabetes and NAFLD, where again there was a reduction in intrahepatic fat. This was not biopsy, the biopsies were not done. There have been smaller other studies and one large randomized control trial of obese adults, where they also studied the effects on the liver and found to have beneficial effects. Coming to dulaglutide also smaller studies, except the first one was with NAFLD on metformin, and the dose is 1.5 milligram weekly. The weight reduction with dulaglutide and liraglutide is not as good as with semaglutide. It is much lower, but definitely much better than placebo. And the weight loss is around 5% weight loss in 56% of population, and 10% weight loss in only 7% of population with dulaglutide. But there was a decrease in liver fat content in patients which were studied with MRI-PDFF. This is the data with exenatide, where 16 newly diagnosed patients with obesity were studied, and they were compared with insulin, and there was a significant lower levels of liver enzymes and significant decrease in body weight. So all these drugs have shown beneficial effects. Semaglutide, the maximum effects, lira and dulaglutide, little lesser effects than sema. So semaglutide this is the study Professor Sanyal mentioned about the Newsom et al., which was published in NEJM, 320 subjects with NASH and fibrosis stage 1 to 3, which was a randomized control trial, 0.4 milligram per day. There have been other studies also, and there has been one pilot study with oral semaglutide, 16 subjects with NAFLD. I'm spending a few more minutes on oral semaglutide, that is because that is what is available with us today. So if you look at the last study in this, 14 milligram per day, 24 weeks, that is a 2.4% weight reduction, and AST and ALT decreased by around 25 to 50%. GGT decreased by 37. So again, very surrogate markers, not biopsy proven. So we don't know whether there was resolution of NASH or regression of fibrosis, but some beneficial data which is seen. This is the study which Professor Sanyal just mentioned in detail, the Newsom et al. NEJM study, which showed that almost 60% of patients with 0.4 milligram once a day semaglutide had resolution of NASH. So this was based on biopsy, the NAFLD activity score. There was resolution of NASH as per the definition in 60% of patients. the regression of fibrosis by one or more stages was seen in 43% of patients with 0.4 milligram semaglutide. But here, the placebo effect was also 33%. So it was not significant on statistical analysis. But 43%, I think, is quite a significant regression of fibrosis. I think even with bariatric surgery, that is what has been shown in most studies. Then there was other effects on body weight. We have just mentioned almost 13 to 15% weight loss over this over the study period. And there was an increase in HDL and decreased free fatty acids, triglycerides, and VLDL. So definitely a better metabolic profile was seen. HbA1c there was a reduction in HbA1c, but hypoglycemia usually is not a problem with these drugs. The major side effects were nausea, constipation. So GI intolerance is something which is going to be a major problem, and that led to drug discontinuation in some patients, not a lot of patients. Just one slide on GIP, GLP-2 agonist. This is tirzepatide, which probably has shown. So I'm going to the data of tirzepatide in NAFLD. So there was, again, these patients had, in the SURPASS-3 study, there was MRI-PDFF benefit shown. So there was a decrease, significant reduction in liver fat content, volume of visceral adipose tissue, and abdominal subcutaneous adipose tissue compared with insulin. So this study is again mainly for obesity, but we also see that there is a beneficial effect on NAFLD and NASH. Again, surrogate markers as per these studies. Meta-analysis has mainly been with liraglutide and dulaglutide. The meta-analysis have not taken semaglutide, and again, just similar results which have been shown. Just highlighting two papers which were published, which were presented in ACG last year, and we had this best of ACG, so I'm just picking these papers, where they had these analysis, dual therapy with metformin and GLP agonist improves mortality in diabetic cirrhotic patients. So this was a study which was a retrospective cohort study from their database, and they found that the 3-year survival and hepatic decompensation, so these were patients who were type 2 diabetic, cirrhotic, and semaglutide was used to treat diabetes, and they found, not semaglutide, but GLP-1 agonists were used to treat diabetes, and they found that it had better survival effect. The all-cause mortality was low. And the 3-year survival in type 2 NASH cirrhosis patients, their difference was not significant. So the all-cause mortality was low, probably because of a better metabolic profile of these drugs. This was again another data which was shown GLP with SGLT2 inhibitors, and it showed a better effect in development of cirrhosis. So as a treatment in my practice today, where do I place GLP-1 agonists? A compelling indication where I would want to use is where I need to reduce weight, reduce appetite, reduce weight gain, and not have much of hypoglycemia, and reduce the cardiovascular risk. So when this kind of metabolic profile is there, these drugs would definitely have a role. But in my practice today, sitting in a city in India, we can probably use only oral semaglutide at incremental dose, which we have started using in some of the patients, in obese individuals with F2, F3 fibrosis. And we are a part of multi-center trial for injectable GLP-1 agonist in cirrhosis, if we can convince them to get enrolled. But right now, we are using in some patients oral semaglutide. Again, it's not conclusively evidence-based, the oral semaglutide, but we are using in some patients. Thank you.
Thank you, Amit, for the excellent lecture. I had one question, maybe it's a little philosophical one, and I'd like some comments also from Professor Sanyal. So, if we see at the GLP-1 analogs, they have a very dramatic effect on obesity, on weight loss, and on reduction in HbA1c, I would say. But what we are looking at in a condition like NAFLD is something which works long term, which is gradual, which also stimulates the patient to work on his lifestyle modifications. And the dramatic effect of all of these agents may reverse once you stop them. You know, they are going to a stage where you're having weight loss like a bariatric surgery, but they're probably going to act only till the time that you give them. Wouldn't we be looking at more agents which act more gradually and also allow patients to get stimulated enough to really work on their metabolic profile.
Yeah, so it's actually always going to be a combination. This is going to be one of the aspects of treatment. The lifestyle modification, diet will also play an important role for the long term. But there has been some data, if you look at the obesity trials, both with liraglutide, there has been some sustained effects of almost 6 to 8% weight loss over 2 to 3 years. Beyond that, we don't have evidence. But I think if it is going to be used in a diabetic population, also as a treatment for diabetes, maybe it will have to be used much longer period. And we don't know the endpoint. Maybe Professor Sanyal can allude to that as to what would be the endpoint of these drugs in treatment of obesity and diabetes.
So currently, for diabetes, this is long-term therapy.
Yeah, that's what.
Because when you stop the drug, the weight comes back in the majority of these patients. What it does, in my view, is it buys you time. It gets the process moving. And, if you can get somebody's BMI down in the meantime, this is the time to think about the behavioral aspect. We don't spend a lot of time talking about the behavioral underpinning of this disease any more than cardiovascular or diabetes. And that's really, I think, a missing piece because it is so critically linked to behavior. So I think these drugs that are working on obesity is a short-term solution while you can figure out how to get the patient more engaged with lifestyle. And if they can then maintain their lifestyle. One of the problems is a lot of these patients who are obese, they truly have muscle dysfunction. They have fatigue, they cannot exercise. So they're inefficient in utilizing metabolic fuel. So they really cannot get out and start running. It's not a matter of being lazy. So if we can get them to that point where they're a little bit metabolically healthier, maybe they will have a better response to behavioral therapy.
Dr.
I
Amit,
think we'll take the questions
we
later
can move on.
after we have our last speaker.
Yes.
No. We'll have a question and answer after the third speaker. We have Professor Raki Maliwal now giving a talk on the case-based learning on GLP-1 drugs.
Good morning all, and thank you Dr. Gaurdas, because what I'll be presenting in the next few minutes is about a case, and this case I treated a long time back. December 2021 was this patient who presented to me in the outpatient department, and it's a success story. After that, I've used this oral GLP-1 in several of my patients after discussing with the endocrinologist. So I'll just to show this patient was a 49 years old female, and she was morbidly obese, 108 kg, and she was outside diagnosed with cirrhosis, which was possibly NASH related, and she had been put on a restrictive diet with a reduction in fats, calories, and also on salt and water restriction. And she came to me in the OPD and complained of extreme weakness and fatigue. Now, interestingly, she was a bipolar disorder diagnosed 25 years back, and her pre-morbid weight was just 58 kg. So after she was started on these antipsychotic medications, the lithium and all, her weight had increased over the next 20 years. She was also a diabetic diagnosed 4 years back, a hypertensive, and thyroid most likely had developed secondary to the lithium which she was taking for this bipolar disorder. So this was an ultrasound. It showed features of chronic liver disease and portal hypertension. These were her labs. Just to show here, the patient had well-preserved liver function. Albumin was normal. The eGFR was 112. AST-LT, we can see here. HOMA was 6.4. Her FIB-4 was 3.6. CRP was 10. And we can see here she was hypertensive. She was having a MAP of 105. Her LDL cholesterol was 95, and HbA1c was 7. Other organ involvement, she had no microalbuminuria. Her CT showed a large lienorenal shunt, and she had isolated gastric esophageal varices too on the endoscopy. Her fundus was normal, and nerve conduction study was also okay, and she had mild concentric LVH. And this was a treatment history. She was on telmisartan For thyroid, she was taking Thyronorm. And for bipolar disorder, all these 4 drugs are known to cause weight gain and also GI symptoms. But when I discussed with the psychiatrist, none of them could be modified in her because she was well controlled for her bipolar disorder. For diabetes, she was taking linagliptin, metformin, and she was also on SGLT2, empagliflozin, at 25 milligrams. So this was her working diagnosis. She was a chronic liver disease patient, NASH-related, and her problems were morbid obesity. She was class 3 obesity with a BMI of 42, hypertension. She also had obstructive sleep apnea, bipolar disorder, hypothyroidism. So my question to the audience is, what should be the preferable approach towards the initial nutritional assessment in this patient? So the options are patient doesn't require any additional assessment as she's obese, she's compensated, and well-preserved synthetic function. Detailed nutritional history and screening for functional capacity. DEXA scan is required for all such patients, or directly go for a hypocaloric diet prescription and target the weight reduction in this patient. Okay. Yeah, so what we did was we did an initial nutritional assessment. So as the patient had already given a history of dietary restriction, she was also found to be frail. So her frailty index was 4.6. And this is just to show the concept. And yesterday we were discussing about sarcopenic obesity. This is just a CT scan. And to show here, the SMI was 40. And she has this myosteatosis. This yellow is the fat in the muscles. So what would you recommend as a nutritional prescription at this, to this patient at this stage? You will put her on a calorie of 500 to 800 with 1 to 1.5 grams ideal body weight. Diet comprising 1200 to 1500 with a protein of 1.2 to 1.5. A diet comprising 500 to 800 and 1.2 to and the present body weight based. And the diet comprising a higher calories, a Mediterranean diet composition, and 1 to 1.5 grams. So can I have the audience vote? Yeah, so this is what we also prescribe for her. So this is also very important that we should never prescribe these patients' diet based on their current or the actual body weight. It is the ideal body weight, which is very easy to calculate using the Broca's index. So for females, you need to subtract the 105, and for males, 100 centimeters from the height. And what exercise protocol would you recommend to this patient? So a resistance exercise with regular slow walking, aerobic, moderate intensity, 40 minutes per day for 5 days, a vigorous intensity exercise, or no need of recommending any exercise to this patient. Okay. So this patient was very frail, and she was actually requiring people to support her to even get up from the chair. And she was morbidly obese, having knee problems, spine problems, so she was not able to say. She just said that it is difficult for me to walk. So we just told her do some resistance exercise and regular slow walking. So what will be you looking at your targets here in this patient in the initial stage of her disease when she has come to you? Would you target the weight loss here? Would you target the weight loss along with the improvement in functional capacity? Or would you improve the functional capacity and metabolic health of the patient as a priority with or without weight loss? Or you will target both the functional capacity improvement, metabolic health, and at least a 10% weight loss? Okay, so a lot of difference of opinion over here. So can we ask Dr. Dadich, what would you do for your patient at this?
So at least you should be mobile with hypocaloric diet. So achieving 4th is our goal, but I don't think you'll be able to achieve this.
If muscle mass can be improved, it is additional benefit over just weight loss.
Yeah. So even we thought, and we targeted an improvement in the initial state as functional capacity and her metabolic health. So we gave her the diet I already discussed. We targeted the improvement, and we did not go for the initial weight loss management in this patient in the initial stage. And we stopped telmisartan and switched to carvedilol, started her on simvastatin as well. And we also sought nutritional psychiatric approval. And she came back after around 2 months' time, where she was feeling a little more energetic and was feeling better. At this point of time, we did a liver biopsy for her. This is a transjugular liver biopsy, just to show you that she had a fibrosis over here. We can see micronodules. She had macrovascular steatosis, she had ballooning, and lobular inflammation. So the pathologist scoring was NAS score of 5 in this patient with the F4 fibrosis. Her HVPG was 18. So despite a large linear-renal shunt, she was still having a high liver pressure. So the next question over here is, now what would you target the glycemic goals in this patient who is obese and diabetic and cirrhotic? A glycemic goal of very tight target, which is recommended, 5.4 to 6%. A glycemic goal of 6 to 6.5%. 7 to 7.5 is okay, or a 6.5 to 7. Okay, yeah. So, any comments from the moderators or chairpersons? What glycemic goals should we be targeting?
Regarding the glycemic control. Anything around 6 would be okay.
Yeah, so 6 to 6.5 is a good target for such kind of patient, especially because she's a cirrhotic, and therefore, okay.
Can you turn? So I have to disagree with that. I think these people do not have much glycogen in their liver, and their ability to tolerate hypoglycemia is very poor. And in general, in the diabetes field, people are beginning to move away from this very tight control because of the risk of hypoglycemia at night, particularly in the context of insulin. When she's on insulin, she's on some basal insulin. So maybe somewhere, I would be happy in the 6.5 range, but I would be a little worried about trying to get too tight, because in order to do that, there's an increased risk of nocturnal hypoglycemia.
Completely agreed. So we should not be targeting a very strict glycemic target in this patient. And like Sir had already said, because there is risk of hypoglycemia and also weight gain with insulin, so what would be your initial strategy for reaching those targets? You would like to stop insulin, continue metformin, SGLT2, which she's on, and add a OHA, or add a pioglitazone or a GLP-1 analog, or you would just target a weight loss and metabolic health strategy. Okay, yeah. So we go on from here. Yes, this is what we also did in this patient. But again, the next question relates to that, and we can discuss on which is the most appropriate weight reduction strategy in a cirrhotic patient. So would you go for a bariatric surgery, despite that she's a class 3 obese patient, or endoscopic approaches here? But again, the challenges here is that she's having gastric varices, and a GLP-1 analog is what is now the future looks like, and which can be safely used in these patients. But still, I would like to have an opinion on the bariatric surgery. Would anybody recommend going for a bariatric?
No, if gastric varices are there.
Okay. Okay. Done? Do I have time, or should I wind up? Okay, so pharmacotherapy for NASH. Here, do we need any additional pharmacotherapy, or we are okay by just, or we should be treating the NASH because we saw the activity score and we saw that this patient has F4 fibrosis. So again, the data is not there. but we can have a discussion. Sir, what would you suggest, Sanyal, sir? Would you treat the NASH here with?
I think I'd be careful with obeticholic acid because the top-line data from the reverse trial did not show any improved benefit for the cirrhotic population. So, and then there's some occasional cases of liver toxicity in the cirrhotic population. So I think I'd be very cautious in the cirrhotic population. If transplant is a potential option in the future, you want to optimize this patient's condition because once you have cirrhosis with clinically significant portal hypertension, in many ways you're now just waiting for the guillotine to drop. So one big part of the long-term approach is to make sure you keep the patient in the best possible shape so that when the liver does decompensate, then they're going to be good candidates. And with that in mind, a drug that reduces weight, stabilizes the heart, reduces further renal, decline is good, and GLP hits all those check boxes. So I think it's reasonable to use a GLP-based therapy. It also allows you to back off the insulin, which can further not only increase the weight, but set up the patient for nocturnal hypoglycemia. It's a really big cause of death in this population.
Okay, thank you for that. So we started this patient on oral semaglutide, and the dose was
Just a question: do you not get a lot of bloating in these patients and nausea because you've increased from 3 to 14?
We were lucky that she did not get any of these side effects, and she tolerated it well. And over 9 months follow-up, we can see here she reduced 11 kgs of weight, had improvement in all the metabolic parameters, LDL cholesterol, HOMA-IR. And also the fibroscan over here, we can see there was improvement, splenic stiffness, and her frailty. Now she's become pre-frail. So she came back last month, and she's doing quite well. Thank you.
So one additional comment to here on this side.
Sorry, sorry.
So one additional comment I'd like to make is that it's valid to add a GLP-1 analog in this case, but I'll be careful because she is on multiple medications with multiple comorbidities and does interact with that, particularly levothyroxine and lithium. I think it will probably increase by almost 33% availability. So I'll be careful adding a GLP, or at least keep a close watch on any potential side effects occurring from
We
other
checked
drugs.
for the, you're very right, and the first strategy that we wanted to take up in this patient was to actually modify the antipsychotic medication.
Right.
But the problem was that she's been stable with all those drugs for years, so nobody was wanting to fiddle with those medicines.
Yeah,
but
once we add the GLP-1 analog, the bioavailability of other drugs might actually increase. So you may have previously...
But 9 months down the line, this patient has been doing well, and we had checked for the interactions. There was no such problem. Thank you.
Raki, excellent case. Just one comment. You had the address of the patient, and you also had the name of the patient in your slides. Just so that you don't get into trouble in future. Just make sure that those are not there.
Sorry.
Confidentiality issues, no problem. I think that was a good case. I'm sorry we are 45 minutes late. So what do you suggest? Should we move on?
Yes.
Vivek is upset that he didn't get a chance to ask his question. But, we have made 4 counters open outside for coffee. If all of you can just go grab your cup of coffee and come back in, and then we would like to start in 7 minutes or 10 minutes. Otherwise, we'll run very late. But let me thank all the moderators and the chairpersons. I'm sorry we were really running behind time. So let's start. Start. hello, while we are getting started, may I request all of you, there are feedback forms on the table. Can you just take a little time, 2 minutes, to give your feedback? So there are two parts. One is, of course, what you have attended. The other one is suggestions for the future. So do put in your comments and suggestions so that we can improve upon it, okay? So leave it on the table. You don't have to put your name if you don't wish to, but that will be very valuable for us.
We start our next session. FXR agonists play important role in regulating lipid glucose metabolism and maintaining the intestinal microbiome. To kickstart the next session, I would invite onto the stage Dr. S.R. Agarwal, Dr. B.C. Sharma, Dr. J.R. Mahapatra, Dr. B.S. Satyaprakash, Dr. Varun Gupta, and the moderators for this session, Dr. Raju, Dr. Mali. I request them to invite the speakers to the stage as well.
Good afternoon. This topic of NAFLD is very close to my heart. Dr. P.N. Rao, my teacher, who is here in the audience, gave this topic to me 10 years back in an API meeting, and I reduced to 15 kg of weight to make me eligible to give the talk. Thanks, Dr. P.N. Rao. Now, it's my pleasure to invite the hero of today's meeting, Dr. Arun Sanyal, to give his talk on biology and its GLP, FXR biology, OCA, and future FXR-based drugs. Dr. Arun Sanyal.
Thank you. Thank you again. Let's see. Here are my disclosures. Okay. So, quick question at the beginning. This is your pre-test. Which is the ideal patient for FXR-based therapy? Stage 2, stage 3, stage 4, or histologically active NASH regardless of fibrosis stage? Oh, okay. Well, let's see what the data tells us. So the first thing, FXR is the cognate receptor for bile acids. And so I know that unless you're a bile acid aficionado, many people don't normally think about bile acids in their everyday work. So bile acids were discovered by Henrik Wieland and got the Nobel Prize for that in 1927. And really, these are derivatives of cholesterol. And the only way the body can get rid of excess cholesterol is either to secrete it in bile or convert the cholesterol into bile acids. And this happens in the hepatocyte through two pathways, one in the cytosol, one in the mitochondria. And they result in two different bile acids called cholic acid and chenodeoxycholic acid, which are called primary bile acids. These primary bile acids come out in the bile, and they form micelles. And these micelles then allow to solubilize the cholesterol in the bile. And when they go into the intestine, they are converted by the bacteria in the intestine that take off hydroxyl groups from these molecules. And cholic acid is converted into deoxycholic acid, and chenodeoxy is converted into lithocholic acid. And these are very hydrophobic molecules and cytotoxic. So deoxycholic acid has been linked to a variety of cancers, and lithocholic acid is also very cytotoxic. So a tremendous amount of biology has now been described with respect to how these bile acids actually work. So when I was going to medical school, I was taught that the role of bile acids is to dissolve fat and to allow us to digest fat. But turns out every time you eat, you have enterohepatic circulation. These bile acids are reabsorbed in the ileum and they circulate back to the liver. And during this process, they provide information to cells, not only in the liver, but elsewhere in the body, that nutrition is coming, because every time you eat, you have enterohepatic circulation of bile acids. And they are very important sensors of nutrient availability and allow the body to readjust its metabolic machinery based on availability of nutrients. So in the intestine, bile acids can bind to what's called TGR5 and also to FXR. And by binding to these FXR receptors, it releases from the intestine something called FGF19, which feeds back on the liver and has very similar biological properties as bile acids and FXR agonists themselves. So bile acids, when they work on FXR in the intestine, they are basically forces the intestine to clear the hepatocyte of bile acid. So it either will shut down production of bile acids or it will move bile acids into the bile. Now, cholesterol is turned into bile acid. So if you shut down production of bile acid, your cholesterol level will go up. So that's the basic biology. Now, we have actually published extensively the pharmacology of obeticholic acid, which is the prototypic FXR and the first generation FXR agonist. And what you see over here is sort of a radar plot where in the center, in the dotted lines, is what the activity for gluconeogenesis, inflammation, fatty acid synthesis, fibrosis, TGF-beta signaling, and bile acids is supposed to be. And in the solid line is what it is in NASH, and what you're seeing in the red line is the shrinkage, how you're bringing it back towards normal. And so it reduces the lipotoxic stress and the inflammatory fibrogenic signaling in response to that. So jumping from here, knowing that it can actually affect lipogenesis, it can affect inflammation, it can affect fibrosis, that provides the rationale for studying it. And I will leapfrog over all the early phase studies like the Flint trial, et cetera, that were done to the Regenerate trial that we published a couple of years ago. And this is a phase 3 and the largest NASH treatment program currently worldwide. So it's a 3-arm study, placebo, 10 milligrams and 25 milligrams of obeticholic acid. And you get a biopsy at the beginning. And the way the drug approval system works in the United States is they follow what is called a conditional approval pathway, where for drugs that have, for diseases that have great unmet need, there is no other drug out there, they will allow approval based on surrogate markers with the idea that you will continue the study and show that the surrogate marker improvement translates into actual clinical outcomes improvement. So at month 18 is the interim time point for that surrogate marker analysis by histology. And there are 2 endpoints: fibrosis improvement by 1 stage or more without worsening of NASH, or NASH resolution without worsening of fibrosis. So, or not and, either one will give you conditional approval. It's not a full approval. It just says there's a huge unmet need, we have reasonable evidence that it sort of is working, but keep going on with the study, but the drug is now approved. So over time, there were 2 types of analysis done. The original analysis, there were 2 pathologists who read all the biopsies. But what has happened during the course of the last 2-3 years is that the best practices in terms of how NASH histology is to be reviewed in a clinical trial has evolved. So the current guidance from the FDA is that you have to have 3 pathologists. And at the very least, they have to read the biopsy independently and agree on all of the features. If they disagree on even one, that's a non-responder. So then of the 3, 2 have to agree on all 4. And then if the two don't agree on all four, then the third one is brought in, and then at least two of the three have to agree on all four. And if they don't, that's a very conservative approach to reading the biopsy. So the data for the original analysis shown on the left, new analysis shown on the right, and basically you land in this pretty much the same place, that there is improvement in fibrosis without worsening of any of the NAS components, which is steatosis, lobular inflammation, and ballooning. And those with F3 seem to have a little bit better response than those with F2. So remember, F3 is where the natural history, you already have a big jump in liver-related outcomes. Yet the disease can still be turned around. So F3 is in many ways the sweet spot for treatment of NASH from a liver perspective, because we have not quite, the F4 is ideal if you can, but that's a very high bar. We have not achieved that yet. And so if you look at basically the entire population, which also includes people who have stage 1 disease, you can see over here that actually there's a very high response rate. So on all stages up to stage 3, good anti-fibrotic response. And whereas in placebo, you are seeing over time that it's relatively flat. If you look at the treatment arm, you're seeing a greater proportion of people who are improving their liver histology. Now, OCA has a number of side effects, and this is why 2 years ago the FDA said, no, we're not willing to give you conditional approval, because approval in the end is the analysis of benefit and risk, not just meeting an endpoint. And so they said, keep going. So we now have over 8,000 total patient years of exposure, and 1,000 patients have received the drug for over 4 years. It is the largest safety NASH database to date. And as you can see, it is a relatively balanced treatment emergent adverse events. And of course, the most common one is pruritus, which is, as you might expect, higher in patients on OCA. There are several adverse events which are considered adverse events of special interest. And there is a signal for gallbladder disease with high-dose OCA, because OCA reduces the, remember, it is suppressing bile acid synthesis. So there's less bile acid coming out in the bile, so cholesterol saturation goes up, and you get gallstones. So you can actually get cholecystitis. There was a signal for pancreatitis initially, but it's completely flat. There was an initial signal that the glycemia might go up a little bit. That's completely flat. And similarly for urolithiasis. From a liver safety point, there are occasional patients who had some liver enzyme elevation, but it was almost all mild, with a couple of exceptions, with a few exceptions that were considered potentially more serious, and one patient who actually ended up getting a liver transplant. Cardiovascular safety actually turns out that the increase in cholesterol, it tends to drift down over time and is quite manageable with statins. And the core MACE, 4-point MACE, and 5-point MACE are all relatively flat. So there is no evidence that you're having more cardiac events with this. Very interesting, when you give the LDL cholesterol, when you give this drug, the LDL cholesterol goes up within 1 month, but by the time you come out to 48 months, even in those who did not get statins, it drifts back down to baseline. And certainly those who get statins have very rapidly, their cholesterol comes down to baseline or even below baseline. There was some AKI question in the beginning, but it's absolutely, as you can see, the number of patients with AKI are similar to placebo. Now, the reverse study is a cirrhosis trial, which also looked at 10, 25 milligrams versus placebo. And unfortunately, the top-line results was negative. It did not provide histological benefit. So where we've landed now is that there is a biological rationale from preclinical studies suggesting improvement in lipogenesis, inflammation, fibrosis, gut permeability, and microbiome. The OCA actually has been shown to reduce fibrosis, and REGENERATE is an ongoing trial for clinical outcomes. And there are other FXR molecules that are being developed, but they all have the similar tolerability issues. So I'm going to stop there because I know there's other case-based discussions coming. Thank you.
Jan is on stage, okay. And I now request Dr. Midun Sharma to start the case-based discussion.
Thank you so much. So it's a privilege to be speaking today. I would take a case which is a very simple case to look at, but this is what we get in our real life scenario. So no disclosures. So this is a 34-year-old male person with a BMI of 28 who has basically an IT managerial job, and he wanted a job change, and they did a pre-employment checkup. His history is that he takes some wine occasionally, regularly consumes some aerated beverage, an occasional smoker, and the results that came in his pre-employment checkup was a rise in the AST and ALT with all other parameters of viral serology and all negative. And the ultrasound report is on the left-hand side, which wrote as fatty infiltration of the liver. This is what we see in practice. And he got scared, and he comes to our clinic. So at this point of time, how do you approach? This is a very common scenario. So do we need further tests to confirm the diagnosis? And do we do a fibrosis assessment in all of these patients? Do we look for comorbidities? And while we do that, do we start lifestyle modification and diet? Or we do all of the above? Can we have an audience poll on this? Yeah, so the majority of the people feel we need to do all of this, which is what we did. So when we have a patient with a fatty liver on ultrasound, we should understand that there are inter-observer variations, but the sensitivity is around 84% with a specificity of around 93%, but the ultrasound sometimes misses early fibrosis. The second big question in this patient was whether this was an alcoholic or a NASH or a non-alcoholic fatty liver. So the amount of alcohol this patient consumes was below the definition of alcohol use disorder. So he is a non-alcoholic fatty liver patient. We looked for risk factors in this patient. He was obese, he had a sedentary lifestyle. His food habits all point towards a possible goal of management which needs to be intervened. And the question he asked us is the fat causing any harm? Because we have been discussing from yesterday, a lot of doctors brush aside fatty liver. So how do we assess whether it is causing harm? A liver function test was done. We should keep in mind a normal ALT doesn't rule out no harm to the liver. A FibroScan, in his case, the CAP score was 310 and a KPA value of 8.2. FibroScan is very good in predicting F3 and F4, but it's better even to rule out that there is no fibrosis. We did a FIB4, which was 1.27. Liver biopsy in routine clinical practice, I don't think we do in a patient who comes with these complaints. We looked for other comorbidities. He was recently diagnosed as a hypertensive. And then how do we treat and manage this patient? So it could be lifestyle, dietary modification, weight loss, or a combination of all of this. So at our center, we gave him the traditional way of managing a NAFL. We asked for energy restriction. We asked him to cut down on his fructose-containing drinks, which he takes every day. We told him to stop alcohol, exercise, with including resistance exercise, cut down on his calories, and if possible, to take some coffee, which could possibly help. But it seems the patient was not very happy with what we advised, because he came for shopping for some medicines, which we did not give on the first day. 2 months down the line, he went to a nearby clinic who prescribed him obeticholic acid 5 milligram and some UDCA. But he did not exercise. His unquantified calorie intake continued, and he showed a slight increase in the BMI. And then he comes back again to our clinic saying he is not feeling fresh, he has some itching over the body, and he repeated his blood tests. So if you see here, there has been a mild increase in the AST, ALT. As the previous speaker has very nicely elucidated, the cholesterol has shot up with 1 month of obeticholic acid. The FibroScan value remains more or less similar to the last report. So there are a lot of issues here. Why no improvement in steatosis and fibrosis despite being on medication? How much improvement was expected with the use of Effexor? Was the duration of treatment less, or was the dose that was used inadequate? And are the side effects that the patient is having is because of the drug, because of his lifestyle, or because of fatty liver itself? So first question is very clear, that he is missing his lifestyle modification, which is the key to the management. So here I would like to see what do we feel, that these patients had pruritus because of NASH itself, or was it attributable to OCA? Was the dyslipidemia again due to obeticholic acid, or because he did not do any lifestyle modification? Do we feel we can use this dose of obeticholic acid, which we all practice in our real life scenario, or all of the following are correct? Can we have an audience poll on this? So most of the people here feel that it's side effect of obeticholic acid causing pruritus and dyslipidemia. And let us see what the literature says. Most of this has been covered by the previous speaker. So here we'd like to highlight the initial trial, that was the Flint trial, where they took NASH patients and gave obeticholic acid 25 milligram versus placebo. At week 24, there was an analysis of the delta change in the ALT levels, which the pre-designed value was 20, and there was a 24% decrease. So in this patient, definitely the duration to even see an ALT change doesn't match with the clinical trials. And however, it was at this point of time that in this study there were concerns raised over the increased LDL cholesterol, and many of these patients were sent to the primary care physician for management of dyslipidemia. And there was an increase in the insulin resistance, paradoxically, which normalized over time in some of these patients. The study had an endpoint at 72 weeks, which was a decrease in the NASH score with no worsening of fibrosis. And if you see that there was a significant improvement in the primary endpoint when compared to placebo, there was a significant improvement in the delta change in the NASH score. But the endpoint in this initial study was resolution of NASH, which was not statistically significant. And in this study cohort, 23% patients had pruritus and 6% in placebo. This was followed by the Regenerate trial, which I would not go into details, which has already been elucidated by Professor Sanyal very nicely. This study showed that there can be regression of fibrosis by 1 point in these patients in the interim analysis. So there has been another data which correlates more with our Indian scenario, where we don't do paired biopsy. So this is a study, again, which is the same cohort of patients where they did non-invasive tests to see the benefit of using obeticholic acid. And if you see that at OCA 10 milligram and 25 milligram, there was a decrease in the VCTE score. The fifth score showed improvement, while the liver stiffness in patients who received placebo continued to rise. So patients who had more than one stage fibrosis improvement on a biopsy showed an improvement in these non-invasive tests. FIB-4 reflected equally fibrosis and worsening, while the ELF reflected more of the worsening and could not pick up the cases which improved. So this patient definitely could possibly benefit in the long run by continuing with OCA with lifestyle modification. So these are the changes in liver chemistries which we expect in these patients. If the red line below shows obeticholic acid 25 milligram, as we see that there is usually a decrease in the ALT, the GGT, and the AST level, and there, as expected, some amount of increase in the alkaline phosphatase. In our patient, there has been an increase, possibly because to a very short duration of treatment, and we cannot call it as a treatment failure. Was the dose adequate? We all use 5 milligram in our clinical practice. I have hardly seen anyone prescribing 25 milligram in real life scenario in Indian patients. This is a meta-analysis done from our center. Anand is here, it's his work. So there are 7 randomized controlled trials, 3 of NASH, 3 of PBC, and 1 of PSC, which we included. And the data showed that at any dose, improvement of NASH fibrosis occurs. Obviously, the highest of 2.23 odds ratio in patient receiving OCA 25 milligram. Coming to in PBC, 5 milligram was the most effective. And when we compared the pruritus, the lowest dose of OCA, which caused less pruritus, was 10 milligram in NASH. This study concluded that possibly a lower dose of obeticholic acid can be used and show improvement in fibrosis, but this needs to be validated in studies which are powered to meet that endpoint. So the next question was the itching due to obeticholic acid, or can NASH cause itching? So this study raised a point that 21% of these patients had pruritus at baseline. Why do NASH patients have itch is still not clear. It has been seen that patients with fatty liver have a higher fasting and postprandial bile acid level despite a normal alkaline phosphatase. The discussion of this study mentioned that it could be they have a drier skin, and there could be many diabetic patients have neuropathy and increased sensitivity leading to itching. And it also pointed out that if it was a male patient in the study, patient who had a GI comorbidities and patient who had a depression or a psychiatric comorbidities had a higher risk of developing itching at baseline. Male was protected, and females had a higher incidence. So was this itching due to OCA again? The same question. The study showed that 20% of patients with placebo also had itching. It was obviously higher with obeticholic acid 25 milligram. The mean duration to the first pruritus was around 6.4 months in placebo arm compared to a very less of 1.4 months with 25 milligram. So with 5 milligram, whether it caused that itching was still debatable. But what is more important, that the investigators found that this itching doesn't have an impact on the quality of life on the patient. This is again a subgroup analysis where showed that when there is improvement in fibrosis, despite some amount of mild itching, these patients reported improved quality of life in terms of fatigue and overall well-being. And the authors concluded that itching with 25 milligram OCA is not a barrier to treatment. Coming to the last part of it, was the rise in LDL cholesterol due to OCA? Possibly yes, possibly no. We don't know. Could be a combination of both. LDL cholesterol do rise at month 1, but most of this cholesterol are not the small LDL cholesterol. The major, if you subdivide it, it's the harmless cholesterol, LDL cholesterol, which rises. And there has been a study to show that we can manage these patients with statins. This study gave statins from week 4 with 10 milligram atorvastatin, and it showed a rapid decline by week 8. And as the other study also showed, that even if statins are not used, many of these patients return to a baseline level of LDL cholesterol over time. The adverse effect could be in your genes. There have been studies where they have shown that some patients with a particular SNPs have an increased response to obeticholic acid, some to steatosis, and even a particular cohort has been identified where pruritus can be more with use of obeticholic acid. There are a lot of new FXR agonists under review. Some are steroidal FXR, some are non-steroidal. I won't go into details for the constraint of time. So to summarize, obeticholic data is promising in NASH patient with fibrosis, and we all know it's still not FDA approved. Pruritus patient-related outcome is similar and is manageable. Lipid abnormality can be controlled with statins, though there has been argument that the commonest cause of death in NAFL is cardiovascular, so a small rise in LDL could have a big effect size, but that has been negated in the recent studies. Multiple FXR agonists under trial, whether a drug like obeticholic acid, which reduces fibrosis, or a drug like saroglitazar, which decreases steatosis, could be an ideal combination, would be an interesting concept. But at this point of time, we need to understand that the key to management is lifestyle. The picture on the left top corner is in Singapore, where our department, we used to have department runs, and whoever used to run for 3 consecutive Sundays, they used to get a pair of Nike shoes. So we discussed this yesterday, the incentive-based Exercise programs at workplace is very important with a healthy diet, which will start in school. And those people who think they have no time to exercise will sooner or later have time to find for illness. Thank you so much, and I take this privilege to welcome you all to AIJ Liver Conclave on 30th June. Thank you.
Thank you, Dr. Mithun Sharma. What happened to your patient? What happened to your patient?
So this patient was continued on obeticholic acid 5 milligram, and he started lifestyle modification. And this is 6 months now. The ALTs have normalized. The fibroscan has still remained the same.
Okay, very nice talk, Dr. Mithun. So you just did an AIG trial with a low dose of OC of 10 milligram. And still, it's a pharma division. Everyone is prescribing 5 milligram as a starting dose. And more than hepatologists, what I believe, physicians and even lower GP doctors are writing OCA 5 milligram right, left. What is your take about it? How much OCA you are using in your practice? Can you tell me?
So OCA in my practice, as of now, no. Because I'm not using 25 milligram. 5 milligram we are not using at our center at this point of time. Yes, in real life scenario, a lot of prescription come with 5 and 10 milligram. 10 milligram may still be justified based on the meta-analysis, but as you know, meta-analysis is basically playing with statistics. The study which was powered to see 10 versus 25 did not show any benefit of 10 milligrams. So at this point, evidence-based, we can't say that 10 milligrams should be recommended.
Can we allow a hand raise? How many OCA are used in the house? Because it's
readily
available in our country now.
Yeah, we can have an OCA rise amongst how many people are using OCA in real life practice. So I think it's very less. It's less than 10%.
So, but if you go to an API meeting, a physician forum meeting or something, so it will be more.
So some things are, I feel, market driven. Some companies have even told us that we have stopped approaching hepatologists because it is difficult to convince them at this point of time to use OCA. So let us go and meet people who get convinced. As of now, data is not convincing. We should accept that and move forward.
So I think agree with Varun. It's more, I think, written by the physician community in the country than by the GI fraternity of the...
Yeah, exactly. At this point of time.
It's just 5 and 10. We don't have any 25 milligrams.
Yeah.
And no one actually gives 3 pills to the patient for treatment of NASH.
We'll take one more question. One last question. We are half an hour behind schedule. So this will be the last question.
A very simple question, Dr. Mithun, after this wonderful talk, even of yours and Dr. Sanyal's. We talk about pruritus with OCA. How do you treat pruritus of OCA?
So that's what, so the pruritus are two things in this study. If you see the investigator reported pruritus, when you keep on asking the patient, do you have itching, do you have itching, you start having itching. And the patient reported outcome is much less than the investigator reported outcome. So I feel it's more to do with patient reported outcome. We should let the patient come and we should do a study and see where we don't explain the patient that pruritus is a side effect of OCA, and let us see how many patients actually come back to our clinic complaining of pruritus. So most of the time we explain to the patient that this is a side effect and it gets on to the patient. That's possibly my real life take on it. So that's what the study showed, that the mild pruritus that occurs with obeticholic acid, whether we apply the same principle as we do in PBC, where we decrease the dose or give it alternate day, is still debatable.
Thank you, Mithun.
I request the moderators to please hand over the memento.
Sanyal and Dr. Mithun Sharma for their excellent talks and chairpersons.
The next session is on antioxidants. For the chair, I invite Dr. Shiva Prasad, Dr. Ramesh Garg, Dr. Hariharan, Dr. Sanjay Banerjee, and Dr. Sanjay Khanna. And to moderate the session, may I invite Dr. Arun Sanyal and Dr. Vandana Mida. I request them to introduce the speaker as well.
So we come to the next session, which is on revisiting an old classic by antioxidant. And we all know that there was a lot of interest after the original PIVOT study, but probably because vitamin E is not on patent and available freely, there has not been corresponding, I think, progressive incremental research that's happened over these years. So today's talk will be on an interesting, important update on the status of vitamin E, tocopherol and tocotrienol, and I'd request the speaker, Dr. Amit Goel, to come up and deliver the talk.
Thank you, sir. I would like to thank my teacher, Dr. Chaudhary, for giving me this opportunity. He was my head when I started my journey in gastroenterology. So I will talk about vitamin E, which was discovered as a compound present in vegetables and which was essential to bear a childbirth, which was alcohol-soluble substance, and that is why it was named as tocopherol. So it is a generic term, vitamin E. It contains 8 compounds, which can be grouped in 2 series, tocopherol and tocotrienol, which differ in the presence or absence of unsaturated bond in the side chain. Each compound has a phenol ring and a side chain. Each series has 4 compounds, alpha, beta, gamma, and delta, which differ in the number and the position of methyl group in phenyl ring. Important point is that these compounds cannot be synthesized in human body, and the vitamin E requirement of our body is given by alpha tocopherol. Other 7 compounds are not contributing to give our vitamin E requirement. So these sources are obviously plant sources, primarily nuts and oils which are present. And tocotrienol, they are richly present in palm oil and rice bran oil. So these are the 2 different oils which are rich in trienol, otherwise tocopherol is widely present. What I want, whatever oil we take, maximum concentration of the type of vitamin in our circulation is alpha tocopherol. Why? Because all the forms of vitamin E are absorbed. After that, they are taken through chylomicrons to the liver, and through liver, they are excreted with the help of alpha tocopherol transfer protein. And this protein has high affinity for alpha tocopherol as compared to other components. And that is why most of the vitamin E circulate in our body in form of alpha tocopherol. This is the standard. We know how the fatty liver disease progresses. I will not go into its detail. How vitamin E work? It has 3 major properties: antioxidant property, anti-inflammatory property, and anti-apoptotic property. Lots of mechanisms are implicated. None of them are very well established other than antioxidant property. I will not go in detail of these things. There are other minor mechanisms which are like they manipulate the membrane-bound enzymes, cell signaling, cell proliferation, gene expression which are related to cholesterol metabolism, inflammation, and cell trafficking. So just I will, a little bit detail, I will go on the antioxidant property of vitamin E. The phenol ring of vitamin E compound has an alcohol group, and that is the main compound moiety which act as antioxidant agent. All the vitamin E, all 8 type have similar antioxidant property. Some literature suggests that tricotinol have some little bit higher antioxidant property as compared to tocopherol group. But the major point which I want to emphasize here, that alpha tocopherol, they inhibit the formation of free radical, but gamma tocopherol scavenges the pre-formed oxygen radical, oxygen-related and nitrogen-related. So reactive oxygen species and reactive nitrogen species. How they work? When we have lots of fat inside the liver, they are metabolized and free radicals are produced. These free radicals react with oxygen and form peroxides. These peroxides are neutralized with vitamin E, alcohol group of vitamin E. And the vitamin E is again, which is oxidized, is reduced by the help of ascorbic acid. In absence of vitamin E, These free radicals are neutralized by polyunsaturated fatty acid, which has 1,000 times less affinity for peroxide radicals. And that is why whenever polyunsaturated fatty acids are used, they damages the membrane. And this is how vitamin E works. So how the clinical application of vitamin E, these are the 5 outcomes in which we are interested, is whether it prevents development of fatty liver, whether it normalizes the biochemical parameter, it reduces the inflammation or histology, or it reduces the risk of HCC and overall all-cause mortality. These could be the 5 endpoints in which any study or a clinician will be interested in. We have very limited data related to animals for the risk of HCC, which I will not be talking, and we have almost a single study data which I will be coming about the overall mortality in NAFLD, but that is not NAFLD. So we have no data in 2 objectives, we can say. This is the single study which included data for more than 210,000 British population, a biobank population-based cohort study where the detailed dietary data was included at regular interval to see how much the data is consistent and how much vitamin E intake they are taking. So intake of different parameter was taken. Vitamin E was one of them. And the data showed that NAFLD diagnosis was reduced by 12% in those who were taking high dose of vitamin E. And based on imaging, this ratio was reduced by 24%, means MRI or ultrasound or any other modality. And overall mortality was 5.3% less in those who were taking high dose of vitamin E. But please mind, this was overall mortality in population, not in fatty liver disease. So we cannot say that high dose of vitamin E is associated with low risk of mortality. And the same thing is given here. The effect was more marked in those who had diabetes or had high BMI as compared to non-diabetic population or with normal BMI. This is the meta-analysis of 5 studies where the vitamin E was used along with the control group, and biopsy was done to assess the effect of vitamin E on severity of inflammation, fibrosis, and ballooning degeneration. And we can see that it has shown effect on enzyme and histopathology both. Serum ALT was reduced by almost 20 international unit. AST was reduced by 29 international unit, which is significantly different. And similarly, different component of liver histology was also improved, like steatosis was reduced by 0.5 unit and lobular inflammation by 0.2 unit. Hepatocellular ballooning was reduced by 0.34 unit and fibrosis by 0.23 unit. So effect of vitamin D on NAFLD, all these studies, what I have shown in the meta-analysis, were included the patients of fatty liver disease or NASH without diabetes. We have a single study which has studied the effect of vitamin E on patient with NASH with diabetes, type 2 diabetes. So this was a proof of concept double-blind placebo-controlled trial which was recently published. Included 105 patients in 3 arms and biopsy-proven NASH they had. The first group was vitamin E, 400 milligram BD, plus placebo for pioglitazone. Second group was given both things, vitamin E plus pioglitazone, and third group was given placebo for both the drugs. And here we have the result we have, that the primary outcome measure was reduction of 2 points or more in NAFLD activity score, which was significantly seen in those where the pioglitazone plus vitamin E both was given as compared to vitamin E alone. And similarly, individual component of liver inflammation markers were also reduced when the combination therapy was given. If we compare the PIVEN trial, which was the fatty liver disease, vitamin E was used along with pioglitazone in non-diabetic patient as compared to diabetic group, we can see here that the effect of pioglitazone plus vitamin E was significantly higher in diabetic group. So when the result of comparison of this slide is showing that in non-diabetic population, vitamin E alone may have effect, but in presence of diabetes, both group, a combination of vitamin E plus pioglitazone will likely to have good result. So just a last slide about coming up role of genetics, because this was the one study where they have taken data from the well-known PIVEN trial and the TONIC trial and measured the serum vitamin E level at different time interval, and shown that those who were responder to the vitamin E had low vitamin E level as compared to those who were non-responder. And this low level could be the effect of increased vitamin E metabolism, higher intrahepatic use of vitamin E, or storage of vitamin E in liver. So anything could be the factor. They have identified some genetic mutation also, which I have not gone into it. Just to complete my talk, I have enumerated the well-known side effects. So before prescribing the vitamin E, we should know the side effect. In summary, regular dietary intake of vitamin E may reduce the risk of NAFLD. Vitamin A seems to improve the serum enzyme and histological activity. Vitamin E alone may be effective in those without diabetes, but with pioglitazone, it may be effective in presence of diabetes. Genetic factor might be playing a role in bringing out the effect of vitamin E in patient with NASH, and data are limited on role of vitamin E for the risk of SCC and overall mortality. Thank you.
Thank you, Dr. Amit. I just have one question. How do we choose the dose? How was the dose of 800 mg per day chosen? You take the RDA, it is just 20 IU, that is to prevent a vitamin deficiency. Here you're giving it in therapeutic reasons. So is it possible, I mean, is there a reason that 800 is the preferred dose, or would you be able to have similar benefits, say, with a smaller dose, 200 or 400 IU daily?
Sir, data is not that much that I can say. That definitely, this will be the another area where we should explore that really we need 400 milligram per day or 800 or maybe 100 unit will work. Probably Dr. Sanyal can give better answer for that.
Maybe I can answer that question. So it's 400 units or 800 units, not in milligrams. Yeah. So it's actually units. So we did our original study with combination that was published in CGH with 400 units. And around that time, there was a pediatric study done by Joel Levine where he gave up to 1.6 grams, I think. So 1,600 units. And so when we were designing PIVENs, we had a long discussion and argument whether it should be 400 or whether it should be 1,600. So after a lot of arm wrestling, we split the difference and said we'll go with the middle. So it's really, there's no science behind it. And in fact, I think the 400 works just as well as the 800. That's my personal bias. Also, one of the genes that actually really identifies who will respond is the haptoglobin genotype. We published this, and that if you have a genotype 2, then those are, if you just want, so you can have 1-1 or 1-2 or 2-2, that's your genotype. If you have a 2 allele, you'll be a responder. If you're a 1-1, they have no response to vitamin E. And there is an ongoing trial, actually from the NASH CRN, looking at 200 units, asking just to answer the question you asked. So it's an ongoing study right now.
Anil?
Okay, Dr. Amit?
Yeah.
Okay, go ahead.
Yeah. My question is, when you look at non-specific thing as vitamin E, which is primarily acting as an anti-inflammatory, antioxidant agent, because excessive metabolism of the excessive oxidation of the fatty acids, you are forgetting the initial event of deposition of the fat. And when you analyze 2 lakh patients for 10 years, there's so much of heterogeneity.
I agree, sir.
Age, diabetes, hypertension, lifestyle changes. How do you come to a conclusion that such a non-specific thing will ever be useful? That too for a period of 6 months, that too at a cost of risk. I think it's asking too much.
No, sir, I do not believe, but that is the data what is available. That's why I thought I should bring it forward. But questionnaire-based dietary intake information cannot be so much reliable. I accept it widely, especially because diet varies so much day-to-day basis or time to time that I fully agree that. But that is the data we should know.
Dr. Amit, what is the role of vitamin E in pediatric NAFLD?
In pediatric NAFLD, PIVEN, TONIC trial, that has also...
Because we have many trials, many Italian trials, Spanish trial, TONIC trial in JAMA, and meta-analysis. The results are not very encouraging.
Yes. In vitamin E in pediatrics, NAFLD is not showing that much effect because their pathogenesis and their presentation histopathology is also different from what we have adult NAFLD, actually. So really whether this therapy will work in pediatric NAFLD is not clear.
We can continue this discussion over the lunch. Maybe we can have just one question.
So just one simple
Last
thing.
question from
So
Dr.
after
Mittal.
this is for Professor Sanyal, maybe able to the best person. So we keep on telling that vitamin E not to be given in diabetes because the original trial in NEGM did not include diabetics. I just wanted to know from Professor Sanyal why you didn't design a study later on with diabetics, because that's the biggest population with vitamin E. Was there any concerns about it?
No, there are really no concerns, and actually the diabetic patients respond just as well. The issue was, you have to remember that when we designed PIVENS, there was no data in NASH, and there was some concern that troglitazone, you remember troglitazone, which is very hepatotoxic, structurally had some similarities to vitamin E. So there was some concern at that time that the diabetic population, at that time troglitazone was still around, and that whether some of the diabetic patients might be getting a glitazone, which may or may not have some hepatotoxicity, and then it would confound our ability to understand whether it's vitamin E or the glitazone. So that population was left out when the PIVENS was designed. Since then, mainly because of funding in India and all the Flint trial and all it used to be an academic enterprise, NASH. Nobody cared. It was all about hepatitis C. You'd have rooms like this, and everybody would be talking about the variant of interferon therapy and whether you went from 45 to 55% response. Then suddenly there were direct-acting antivirals, and it was almost game over. So then NASH after Flint became a pharmaceutical, moved over into the commercial space. So the pharmaceutical industry took that over, and there was very little interest in doing big trials. But I think there is potentially a role. There's a difference between taking vitamin E, thinking you're just going to live forever, versus taking it for a disease with a very specific morbidity and mortality. It's all about benefit risk. And the key is identifying the correct dose, which is what we're trying to do now. But there is a retrospective study from Indiana University which shows that liver decompensation was cut by half in people with stage 3 and compensated cirrhotics getting vitamin E. And also transplant-free survival was 2 times higher in patients who received that. And along with the people chosen on the basis of haptoglobin genotype, I think if we do that, that's the study I would like to do. In people with haptoglobin 2 allele who have stage 3 disease, to see whether you can prevent decompensation. Because then you can answer one way or the other, yes or no, whether it has any role.
And I think the duration of vitamin D would also be
longer.
I think we have to go on to the next session. Ashish is...
So one small question, please. I'm waiting. Just one question. As you are told, the diabetics will be benefited better with a combination of vitamin E and pioglitazone. One point which we need to consider is several of the diabetics, maybe around 50%, are having cardiac comorbidity also. And as pioglitazone is known to be a cardiotoxic drug, how do we try to synergize all these things?
Yes. I think that can be taken up later. That's a long response. I think we'll have to end this now.
Thank you. I request the moderators to hand a moment to the speaker, Dr. Amit Goyal, and then pose for a group photograph. So after a very exciting discussion on vitamin E, there are a lot of gray areas in management of NAFLD, like the treatment is not perfect, the drugs are not perfect, even lifestyle management is not perfect. So the next session would be a panel discussion on gray areas, and for that I would request our chairpersons, Dr. Anand Kulkarni, Dr. Nipun Verma, Dr. Akash Roy, Dr. Sandeep Satsangi, Dr. Arun Walson to come to the dais. And I would also request our moderators, Dr. Chaudhary and Dr. Shinoy, to come. I request the chairpersons to introduce the moderators and the speaker. The speaker would be Dr. A.C. Anand, whom we heard yesterday also for an elegant talk on exercise. So he would be covering on gray areas. Dr. Anand.
Thank you, Dr. Anand. I think it would be nice if you can have this case presentation.
Yes, sir. I'll start with some maths. I have 9 questions and a case. Case will be about 7 to 8 minutes. And 9 questions means we have 2 minutes per question, because total time available is only 30 minutes.
Okay.
I have already distributed the questions to the panelists. So I expect sharp 1-minute answers, not very lengthy answers. The pie diagram on the right side of the slide shows the etiologies of chronic liver disease in our wards at Bhubaneswar. And there are 2 diseases which are vying for the first position. I'm told the similar situation is there in almost all the medical colleges and hospitals. But there are times when these 2 diseases intertwine with each other, and one such case I'm bringing it here. Before objecting, Deepika, kindly read the footprint. It's not a patient's picture. 47-year-old lady who was a COO of a private company reported for a dull aching pain in the right upper quadrant and lack of appetite. She was a diabetic for last 6 years and was taking metformin and sitagliptin. About alcohol, she said that I take occasionally, only socially. Her BMI was 32.4. She was active and had no sarcopenia. Clinically, there was tenderness in the right upper quadrant. And these are the things which were sent by the referring doctor to us. The ultrasound showed hepatomegaly with grade 2 fatty liver. There was increased visceral fat. Gallbladder was normal. And the investigations are shown here. Provisional diagnosis given was NAFLD. And Anand, can you tell me what is your impression about the diagnosis and what further step will you take?
So since there is consumption of alcohol and AST more than ALT, I would be still skeptical whether it is NAFLD or not. I will be digging on more history about alcohol intake.
Excellent. I was less confident about confronting her about alcohol history, so I did some of the tests again, and the suspicions which Anand Kulkarni has brought out were confirmed. She had macrocytosis. Her GGT was quite raised. So we questioned her again about the alcohol intake. She denied daily drinking. She says, I'm always within limits. I take 1 drink, at the most 2 drinks, and mostly on social occasions, which are only 1 to 3 times a week. Sometimes I take little more, that is 3 to 4 drinks on a weekend, but that weekend comes once in 1 or 2 months. Husband mostly accompanied her in the parties, and he agreed with her assessment. There were no colleagues available. So my question number 2 is to Arun. How will you decide whether this is a significant alcohol intake or not?
First thing we have to remember is that most people underreport their alcohol intake. She being the person being a female and of high BMI, this alcohol limit would be serious. Third thing about this history is she has got weekend binge drinking, which a recent study that is published in 2022 has said that binge drinking, especially in the weekends, has increased alcohol-related mortality.
It doesn't reach the definition of binge drinking.
Yeah, but there are other risks that she is having along with that, and she has a borderline low platelet, and her fibrosis score is also high. So I would consider that as a significant drinking pattern.
Okay. There are other methods of finding out. For example, recently there was a paper published about ethyl glucuronide in the hair samples or in the urine. And also there are other methods by which we come to get to know. For the regular use, we already have MCV and gamma GT available with us. The other tests which can be done are also listed here. Unfortunately, we did not do any of these tests. And I'll just project one slide to show what is the current definition of NAFLD. It is based on exclusion of alcohol. And exclusion of alcohol, the limit of alcohol which is permitted to these people has been varying with the varying studies which have been published. Some people said that it should be 0 amount of alcohol. Some people said that 140 grams of alcohol per week is permitted. And then we have 21 wise people getting together to tell us how much it should be. For example, in ASLD, it says that 294 grams per week is permissible for males, and 196 grams per week is permissible for females. In India, of course, they would be considered alcoholics. So, question is whether these recommendations are evidence-based. What is your opinion, Akash?
So, the definition for alcohol intake standardization is not evidence-based. Not only does the amount of drink vary, but also what is significant alcohol consumption also varies. If you see definition from Japan, Australia, USA, UK, they're all variable. And this cutoff of 14 and 21 comes from an old Scandinavian data where they had, which was the retrospective analysis.
So that means that NAFLD cannot be accurately defined. Okay. My next question is, can Hodgkin's disease, Hodgkin's lymphoma and non-Hodgkin's lymphoma coexist?
Well, yes, biologically it is possible, but
it's never been reported.
We need to have molecular tests for
it has not been reported. Normally, we give a justification of using a negative nomenclature for NAFLD by saying that we already have non-Hodgkin's lymphoma. But problem is, non-Hodgkin's lymphoma does not coexist with Hodgkin's lymphoma. But NAFLD, can it coexist with alcoholic liver disease? So that is the audience poll question right now. Is alcohol-associated liver disease and non-alcoholic liver disease in this patient, what is she suffering from? Is it AALD, NAFLD, or BFLD? Can we have an audience poll? So audience is baffled. Dr. Chaudhary, would you like to comment? Is it logical to have a non-alcoholic liver disease in which alcoholic liver disease is also there?
Much of the things in life don't go on logic alone. So I mean, it's common sense. I think that there is a factor, both the two factors are operative. Very difficult to actually tweak one from the other in this scenario. Very difficult.
Okay, so let's go to the next question then. We now need to find out which is the dominant disease in this. Is it alcoholic liver disease which is dominant, or it is the non-alcoholic liver disease which is dominant? And how will we decide that? Can I ask Anand whether physical examination will help?
A firm enlarged tender liver may be suggestive of alcoholic hepatitis since there is elevation in enzyme, but physical examination per se may not.
But you can have tenderness even in the non-alcoholic fatty liver disease.
Tender liver in NAFLD is less likely, and high BMI, high waist circumference probably points more towards metabolic components. So, alcohol-associated fatty liver disease with metabolic components.
All right, I agree with you. There are no symptoms and signs which will exclude a disease. There are some symptoms and signs which will suggest that it is possibly insulin resistance is a dominant factor here, and it can be NAFLD, or the patient has signs of chronic alcohol use, and that may be alcoholic liver disease is present, but nothing can exclude the other disease. And therefore, the possibility remains that which is dominant, we cannot find out from the physical examination. What about imaging, Arun?
Imaging, it's, there are, not really, there is one proposed sign which I have not seen in my practice is kind of something called as a pseudo-parallel sign in acute alcoholic hepatitis. But by and large, clinically, to differentiate NAFLD and ALD by imaging is difficult?
There is a study which has recently been published. It shows that alcoholic and non-alcoholic steatohepatitis, vascular branching heterogeneity on MRI is a diagnostic marker for alcoholic liver disease. And they have identified perivascular branching pattern on imaging, which they say is a promising novel diagnostic marker that can be used with other methods to help distinguish alcoholic steatohepatitis with NASH, but whether it can exclude the other is not reported. Then there is also use of AI, that is deep learning supports differentiation of alcoholic and other. This particular paper from Nature has studied 4 protocols of deep learning, and they said that the proof of principle study shows deep learning classifiers have the potential to aid in discriminating liver cirrhosis etiology based on standard MRI. Any comments on that, Dr. Chaudhary?
So basically, the AI techniques are, depends on what data they have been trained on. If there is no gray zone in the data, the clear-cut cases and controls, then it is going to overestimate the accuracy of a model. So that is what we need to look at.
So I don't think even that can differentiate between the two.
Yes, so we need to have, and there are emerging data, molecular-based techniques, different forms of cell death, different types of microbiome in patients with ALD vis-a-vis non-alcoholic fatty liver disease. So we need to go probably deeper into the biology of patients.
Okay, Nipun, next question is for you. What is the role of liver biopsy in differentiating between the two?
Well, grossly, there is fatty liver in both the situations. So certain features which may tend more towards alcoholic liver diseases like central hyaline necrosis, perivenular fibrosis, or maybe, the cholestasis. These are findings which are very peculiar to alcoholic liver disease, may not be seen in pure non-alcoholic fatty liver disease patients. And I think, and microvesicular steatosis sometimes can be very severe in patients with alcoholic hepatitis, which alcoholic liver disease not probably seen in non-alcoholic fatty liver disease. But grossly, the finding, and the neutrophilic infiltration, which is predominant in patients with alcoholic liver disease. So these are the certain features.
Okay. There is a Dr. Sakhuja's paper which says that one can differentiate, looking at the histology, whether it is a predominantly alcoholic damage or it is a non-alcoholic damage. What would you say to that?
What is the question, sir?
This is Dr. Pooja Sakhuja's paper, which says that you can differentiate between alcoholic and non-alcoholic fatty liver disease on histopathology.
I think it is the predominant phenotype based on history examination and the biopsy which makes the clinical diagnosis. So this is something which has been described. Yes, it can be helpful for making the diagnosis.
Okay, I agree with you that you said that hepatic canalicular cholestasis more likely to be present in alcoholic cirrhosis, alcoholic steatohepatitis. Similarly, bile ductular proliferation, sclerosing hyaline necrosis. These are more commonly seen with alcoholics. On the other hand, mixed macrovascular and microvascular, as you said, is more likely to be in a non-alcoholic fatty liver disease. A lobular inflammation and nuclear vacuolation, apoptotic injury, more likely in the non-alcoholic fatty liver disease. Okay, next question is, when do we do liver biopsy in this situation? Should we do liver biopsy in the patient that has come?
Just to prove that's all, otherwise, just to prove that it is alcoholic hepatitis, otherwise I would not be doing in patients and outpatients unless I'm planning for steroid therapy.
No, the clinical picture is with you. With this clinical picture, would you like to do a liver biopsy?
No, sir. I would like to do a ANI scoring, alcohol,
okay.
NAFLD scoring.
So let's go to then ANI scoring. Akash, what is the role of ANI scoring? It has been described some time back, quite an old paper.
Yes, it's quite
and in clinical practice, how often it is used?
So it's quite an old paper, came out of Mayo. It was originally was a biopsy proven, and then they had compared. It uses 4 components: ALT, AST, MCV, age, and BMI, 5 components. This works good. I've been working on this around 400 odd patients. I think we'll present this at INAZR. But this has 2 limitations. Number 1, if somebody's lean and has got fat, doesn't take alcohol, this classifies them as alcoholic fatty liver. And the other side, if somebody is a female, is obese, consumes alcohol, still it classifies as non-alcoholic fatty liver disease. I calculated the score yesterday for this case itself. It gives a score of 2.6 and probability of only 6% to have an alcoholic fatty liver disease. So the score is good, but it has got its limitations, and it caps off the MCV at 92. So even the MCV was 103. We put in the calculator, it will still come out to be 92.
No, my calculation was different.
My calculation was different.
So there's a small change addition. The cutoffs are 2. There is an upper and a lower ceiling. It's 92 and I think 103. And there is a cutoff of 3 times for AST. So if you apply that, then it's okay.
My calculation was alcoholic liver disease in
Yes,
this patient.
this patient
97% probability of alcoholic liver
I
disease.
think the difference is because there were 2 reports available, and you may have used the reports which were sent by the GP to us, and you may have used the reports that were done at our hospital. And I agree with you that alcoholic steatohepatitis is what is shown by the calculation here. So do you think that if the patient has alcoholic steatohepatitis, she needs treatment only for alcoholic hepatitis and not really a treatment for non-alcoholic fatty liver disease?
No. I guess this is very clear that we need to treat both the cofactors in a given patient to have better outcomes. So
without deciding which is a predominant disease, would you like to embark on treating both together?
So the both factors are playing in the pathogenesis of a patient. So I feel we need to do an abstinence, we need to do a physical activity, and the diet and the lifestyle changes similar.
Okay. Akash, what is your opinion on this?
I agree on this.
You don't need to differentiate, you need to just treat.
So by definition, this, if you see the original reports, it does not fit into the clinical diagnosis of alcoholic hepatitis. So I think we have to manage both of it and not individually focus on the individual part of it.
So
Arun?
both the metabolic component also drives the disease, the fibrosis or the steatosis, and the alcohol can drive. So both are synergistic and the effects are bidirectional. So I think for this particular patient, you have to address both the things.
Okay. Before I come to the last question, there is another question which I have. What is the impact of alcohol on NAFLD? Yes, Anand.
Sir, previously they used to say that 20 grams light consumption less than 10 grams is useful, beneficial. But recent reports suggest that 0 intake should be maintained for NAFLD patients to have a better prognosis.
Any other opinion?
We suggest 0 consumption.
So well, it is the type of drinking also has been reported that wine could be safe and probably protective. Mouse studies at least have shown, but any intake beyond 10 grams has been shown to be harmful for overall health. Global burden of disease have reported that in terms of cancers, in terms of progression also. At least it is very, very clear in patients who are having having alcoholic liver disease, presence of obesity and high BMI is directly correlating with the increased progression of fibrosis, cirrhosis, mortality, HCC. That is very, very clear. But in a patient with established NAFLD, moderate amount of alcohol is still controversial. The binge drinking is probably more harmful in such group of patients.
But I'll repeat, this lady did not, by definition, go in for binge drinking.
If I take the NIAAA definition.
I think we should go for the Canadian guidelines, which have come out of late. I think any amount of alcohol is injurious. I think it is our duty not to tell patients to continue with alcohol intake, even if you think it is NAFLD with less than 20 grams. We do not know what is the impact of even less than 20 grams. But based on these Canadian guidelines, in relation to overall mortality, which you mentioned, the risk of cancer, it starts from 10 grams. So why do you expect a person to drink and expose himself to cancer in the presence of a disease which is likely to develop into cancer, both NAFLD and alcoholic liver disease? I think we have been discussing on a subject
personally,
which is really a gray area. To me, whether you call it NAFLD or an alcoholic hepatitis, it requires aggressive treatment.
Dr.
That is the
Chaudhary,
bottom line.
can we reverse the question? What is the effect of NAFLD on alcoholic liver disease?
You're asking me. See, here I'll tell you, we are debating it as scientists, okay? Practically what I would do in the clinic, I would ask this lady to just invest 6 to 8 weeks of stopping alcohol and trying to see what happens to the liver enzymes. The chances are very good that in 8 weeks' time, it might come crashing down. And after that, if she's comfortable continuing, fine. If she wants to explore and still retry drinking and it shoots up, it more or less drives home the point. And I think sometimes it's a much more convincing evidence than to even do a liver biopsy.
Okay. Sir, one more point I would like to say that if there is an underlying severe fibrosis or significant fibrosis or advanced fibrosis, any amount of alcohol is going to be very, very injurious in the patient. So
I agree with this
sir,
point.
This is very clear.
One additional submission. In patients with cirrhosis, in patient with high fibrosis, or in patient with multiple comorbidities which can drive the disease, we all know the answer that the alcohol is not safe. The only problem is lifetime, people who are teetotalers or people who have mild drinking and no comorbidities. That is the only gray area we currently have. In these people, our advice should be that there are far more better ways to reduce CV risk than consume alcohol. That should be, as doctors, a medical opinion should be that there are far more easily available things to reduce CV risk like exercise, and the amount of whatever the wine or whatever is required for CV risk protection is too much. So I don't think we should be recommending alcohol at any level to any spectrum of the disease.
I actually feel hesitant to show the paper that I have to show you because there are about 200 people here and they all blindly believe what Dr. Arun Sanyal says. And he says that modest alcohol consumption is associated with decreased prevalence of steatohepatitis in patients with non-alcoholic fatty liver disease.
So we need his opinion, sir.
Sir, to just add, sir, I may be wrong, sir. I'll pose this question to Dr. Sanyal himself.
We will talk to him.
This study had excluded binge drinkers.
No. We will. That's a different group together. But I'm telling you the title of the study is this.
To draw conclusions.
And in addition to that, this is not the only study.
Yes.
There are other studies as well. This is, for example, who consider alcohol as a nutrient. The paper is Nutrients, and it says moderate alcohol intake in non-alcoholic fatty liver disease, to drink or not to drink. And then he goes on to quote 15 studies where the benefit has been shown, both in terms of reducing the steatohepatitis as well as reducing cardiovascular mortality. These are the 4 studies here, another 4 studies here, another 5 studies here, and another 3 studies here.
The problem is they don't stop at 10 grams, 20 grams. Once they start, there is no end. Even the ALD patients.
Sir, this would be practical in a patient who's been provided trial packets of alcohol.
So I think this is addressed.
What is your opinion?
I think, sir, what other things patients is consuming apart from alcohol is also very important here. There has been a study which showed that, if the patient is consuming in moderate amounts of alcohol, and a Finnish study actually showed that they were consuming a lot of green vegetables and fermented foods together.
I think I'll skip the discussion because only 1 minute is left. But the summary of both the studies said that this data is not reliable.
Not reliable.
And the bottom line is the data is far from solid, and possibly we should be relying on larger data, better collected. And there are 2 studies which people are now talking about. One is this, which was published in Lancet, and which showed that all-cause mortality rises if you're taking more than 100 grams per week. And the second study is published in BMJ Open, which says that this review found that any level of alcohol intake and NAFLD may be harmful for the liver health, as Dr. Shenoy was saying. Based on this synthesis, the most up-to-date longitudinal evidence, clinicians seeking patients with NAFLD should currently advise total abstinence from alcohol. So I want this to be clear, and don't go by the earlier paper that I presented from Dr. Sanyal. Last question is, as I mentioned that if you define non-alcoholic fatty liver disease by absence of alcohol, how can you say that it can coexist with alcoholic liver disease? Wouldn't the nomenclature of metabolic dissociation associated fatty liver disease sort out this confusion? I want to have an audience poll on this. Audience says that we should use MAFLD rather than NAFLD. And I'd like to have comments from our moderators and then from Dr. Arun Sanyal.
Who, me? No, I'm happy SP Singh is not in the audience. He would eat you all. I mean, he's one of those people quite dead against the new name change. So anyway, but there are two ways of looking at a problem. And I would ask Shenoy to give his views.
No, I think this case brings into consideration of the coexistence of two diseases. But nevertheless, alcohol being one such substance where you don't get the truth from the patient. I think interviewing more than a few thousands, I think the truth never comes out. They say they drink occasionally, but when you ask his wife or his relatives, they say most of the time he's drunk.
No, I wouldn't go so far. I'll tell you what, we did some study on genetic polymorphism of the alcohol metabolizing enzymes. And for many of you who know, there are people who would drink almost a bottle a day for 40 years and nothing happens to their liver. Whereas some people have very sensitive livers, so even with small amounts they get into trouble. And we haven't yet understood that part so well. So here the problem is that this lady was really what she and her husband were telling, wasn't drinking that much, but it could be quite significant for her, which we do not know. And that's why the only method would be to do a trial and error observation if she agrees, rather than right from the beginning say stop all alcohol. You know, she'll think that one of the pleasures of her life is denied. So at least let her prove the point in 2 months.
Dr. Sanyal, your comments on this question.
Well, first of all, that paper, the discussion was very long, and we put a lot of disclaimers in the discussion.
Even in conclusion, you said that prospective studies should be done to find out the truth.
Subsequently, we did that, and we published a second paper, which you did not show. Where what we did was we took everybody with the same histologic stage of disease. And then we looked at those who were absolutely zero alcohol versus small amounts of alcohol. These are not heavy drinkers. And what we found is basically it really did make, those who consumed alcohol had a little more steatosis, but it didn't make any difference with the other features. But the big issue is what you showed, that they have a cancer risk. And the alcohol cancer connection, even the community doctors don't make. And so many family practitioners are not aware that even one drink on a regular basis increases the risk of breast cancer. So for a woman, I think at the very least ethically, we have to tell the patient that on a regular basis, if you're consuming alcohol every day, then even one drink increases the risk. It may be a small increase, but it is an increase in the risk. I think there is a whole multi-society thing coming out soon. So hopefully this will sort out. The issue is not that this current nomenclature is illogical. I think everybody agrees that the use of a non is a non-term. And it's maybe time to think about a better terminology. There were two issues. One is the process followed for the so-called consensus that led to NAFM.
So you were part of that?
No, my name was used incorrectly without my permission. I will add, and that really pissed me off. Number two is the fact that, this is a multi-stakeholder. The bigger issue is the case definition. If you only include the diabetics, you disadvantage the children, because then, pediatric NASH falls out completely, and what we call pediatric fatty liver disease. And the second issue is mixing in alcohol and calling it all under one umbrella makes the disease more, it is already a very heterogeneous disease. Now when you add alcohol, you're making it even more heterogeneous. So it's going to be even harder to show what drugs work and what drugs don't work. We need a way to enrich the population which is purely metabolic or mixed and study them separately, in my view. So that was a point of conversation, and that conversation is sort of now maturing, and there is a, I think like 8 society or 10 society document that will probably come out. But you're absolutely right. The current nomenclature makes no sense. It never did.
Thank you, sir.
Can I make a just quick comment, sir?
Sure.
Yeah. So
Moderators, chairpersons to decide.
No, as long as we are going to get our lunch, so please be brief. We are
so very briefly, you
we
know,
are
after
eating into
the
lunchtime.
Original Mayo ANI study, there was another paper, if I remember, where they had added gamma GT to that, you know, and that actually increased, you know, its value. This was not very, 4 or 5 years back. So that is one comment. The second is, we published 2 papers on this coexistence, and one of the paper actually said whether the NAFLD and ASH can coexist, but then this was the kind of a gray area. They were all cirrhotics, ACLF, and then we called them as, you know, that if you have presence of metabolic syndrome, obviously, you know, it adds on to your severity.
Thank you.
Thank you very much. I think that was a very, very educative case, made all of us think, and we could not come to a consensus, which means it was a very intriguing case. Anand, I trust you to do such things. Wonderful.
Thank you very much.
Can we honor you a little bit, or have you already been honored?
I have been honored.
You have been so it's my pleasant duty to thank my co-chairs and panelists, and I think we have one more session before we break for lunch, so we'll make it quick. Thank you so much.
Thank you.
So, without wasting any more time, for the next session, which is on PPARs, I would like to invite the chairpersons, Dr. Krishna Das Devdas, Dr. Sujit Chaudhary, Dr. Santosh Hazara, Dr. Monica Jain, and Dr. Varun Gupta. I request all of you to come to the stage. And the moderators for this session would be Dr. R.K. Day and Dr. Manish Bhatnagar. And I request the chairpersons to introduce the first speaker. The first speaker would be none other than Dr. Arun Sanyal. Dr. Krishna Das, you can, yeah.
Dr. Arun Sanyal, please come to the dais. I don't think he requires any introduction anyway.
Yeah, I think by now everybody knows. So moving on, PPARs. So stage setting question. Which of the following about PPAR-based therapies is correct? PPAR alpha improves insulin sensitivity. PPAR gamma acts principally on adipose tissue to reduce lipolysis. PPAR gamma has potential for causing anemia. And PPAR gamma agonists increase spontaneous femur fractures. Can we have the question, please? Okay, so we will see. Let's look at the data. So we'll start with something that you're all familiar with, which is that there are many comorbidities, and they're all linked to metabolic stress, which historically we have measured by insulin resistance as a surrogate marker. In this setting, PPAR gamma acts both in adipose tissue and in the liver itself. In the adipose tissue, it improves insulin sensitivity, and as a result, it increases, and it does this by increasing adiponectin. Adiponectin is also a target for FGF21, so it shares that common with FGF21. And adiponectin then can affect the liver and produce benefits in the liver. Through its effects by improving adipose tissue insulin resistance, it also decreases the release of fatty acids from the adipose tissue. So there are two peripheral effects. One is adiponectin, the other is reduced fatty acid release. And by improving insulin sensitivity, when you take a food intake, it increases glucose clearance by striated muscle, so there is less glucose available to the liver for de novo lipogenesis. Within the liver, it directly works on this transcriptional factor called PGC1 alpha, which affects mitogenesis. And mitochondria are at the heart of what causes the damage in NASH. Because when you stress your metabolic machinery, you produce oxidative stress. It damages the mitochondria, and the mitochondria are the primary source of oxidative stress. So you accumulate these sick mitochondria in NASH, and what this does is it allows you to generate new healthy mitochondria, and so thereby reduces oxidative stress, which also has anti-inflammatory and then anti-fibrotic benefits. So it has both effects in the liver, which are different than the effects in the periphery. So we've already seen the data with pioglitazone, so I'm not going to waste any time, but I will make one point over here. If you look at the proportion of people who had a one-stage improvement or greater of fibrosis with pioglitazone or vitamin E, the green bars are the vitamin E. What you see over here is that the proportion is a little bit higher. Now, in the original PIVENS trial, the study was not powered for fibrosis. So for this effect size, there was no p-value. But if we had if we had 140 patients in each arm, this would have been statistically significant. So there is some evidence that it does improve fibrosis to some small effect, but so does pioglitazone. Now, you already have saroglitazar, and I think the next talk is on saroglitazar. So I'm not going to waste too much time over here, except maybe to talk about the basic science, which is that saroglitazar improves key features of NASH in a preclinical model where it improved all the individual features. We published this in 2020. It reduces cell stress, which is unfolded protein response. It improves oxidative stress. And JNK is a very important inflammatory pathway, and you can see that it completely shuts down the JNK that is associated with Western diet. And it reduces smooth muscle actin, which is a marker of fibrogenesis. And this is also shown that it has a big footprint in terms of the immune inflammatory response. So not only does it have the conventional metabolic benefits, but actually cools off the inflammatory response in NASH as well. And it has been shown in early studies to improve ALT and also liver fat content in phase 2 trials. And glycemic parameters, I'm not going to, I didn't realize that, Ajay, you are going to give this talk, so I'm sorry I have these slides in here. So I'm going to go very quickly through this, and also to point out that it does actually, there's some early data now on histology as well, which I'm sure Ajay will cover. So what I'll jump to now is lanifibranor, which is actually not talked about a lot, but it is actually potentially, it could be a very important player. So there are 3 types of PPAR receptors, the PPAR alpha, PPAR gamma, and PPAR delta. And PPAR alpha predominantly increases fat oxidation. PPAR gamma is insulin sensitizing, and then PPAR delta is anti-inflammatory. So lanifibranor is a pan-PPAR, and PPARs are nuclear receptors. So it is a pan-PPAR, so it has all 3 effects. Now remember, there was another drug called elafibranor, which was also a PPAR alpha delta and had no effect. It's been taken out of, it's no longer in development. There was a drug which was a pure PPAR delta, seladelpar, but there was some concern about whether there was some hepatotoxicity. Turns out it didn't really matter, but that really has not going anywhere. So fenofibrate has been looked at, doesn't really work by itself. So you do need some PPAR gamma, and you need potentially, but PPAR gammas have some issues with pioglitazone. You know, you get the weight gain, you have fluid retention, and you can even get some dilutional anemia. So people are looking at these combinations. So LANI is a pan-PPAR, and actually it has been shown to affect all of the different features of NASH. So here's the phase 2 trial that we published in New England Journal, where it looks at initially the SAF score, and you can see that over here, dose-dependent, statistically significant results in resolution of NASH. So the primary endpoint for this was the SAF score rather than a resolution of NASH, which is the regulatory endpoint. So I'm just showing you the regulatory endpoints. So you see a greater proportion, 44% in the ITT population and 51% in the per protocol population. Similarly, if you looked at improvement in fibrosis, significant. So this is the first drug that hit both NASH resolution and fibrosis improvement compared to placebo. And when you look at the combined endpoint, which is both resolution of NASH and fibrosis improvement, 1 out of 3 patients actually met this endpoint. So that's actually a pretty substantial step up from where we were previously in terms of generating high-quality evidence to show that something actually works. So lanifibranor is currently in phase 3 trials, and it's called the NATIVE trial, and it is moving forward around the world. I don't know if this is in India, if LANI is I don't think India is part of this phase 3 trial, but I would keep an eye on lanifibranor within the PPAR space. Saroglitazar, which you'll hear about in detail, which you already have here and is approved, that and I think lanifibranor are going to be important players. But what is very encouraging to me is that it tells us that our therapeutic armamentarium is growing. You heard about the antifibrotic benefits of OCA, the major benefits of GLPs. Now you're going to hear, you've heard now about lanifibranor, and now you're going to hear about saroglitazar. So with that, I think I'll turn this over to Ajay.
Can we have the questions at the end?
Yeah, let's do the questions at the end.
So let me invite Dr. Ajay Dusheja, who will be speaking on saroglitazar, the experience so far. Dr. Dusheja needs no introduction in this audience. I think that's, please, you continue your.
Thank you at the outset. Again, my sincere thanks to Professor Chaudhary for giving me this opportunity, and also, getting this meeting associated with INAZL. So I bring greetings from PGI Chandigarh and INAZL. So I'll start with, where Dr. Sanyal left, and I'll again start with the audience poll. You heard of different kinds of PPARs. So the first question, can we have the audience poll? What is saroglitazar? Is it a PPAR alpha beta agonist, alpha gamma, beta gamma, or it's a pan PPAR? I'm surprised actually 4, 6, and 6% people are writing something else. So it's a PPAR alpha and a gamma agonist. It's a dual PPAR alpha and a gamma agonist. Okay, the next question is, this is again for the audience. Saroglitazar can be considered as pharmacotherapy in NASH F1 to F3. Choices are only in those with diabetes, only in those with dyslipidemia, only in those with diabetic dyslipidemia, and both in those with and without diabetes and dyslipidemia. So your choice, your time. So, okay, the majority feels that this can be given both with and without. So my job now is to tell you the evidence and the experience so far with saroglitazar, and I have around 13 minutes to do that. So as we know, the saro is a PPAR alpha and a gamma. You heard elafibranor was an alpha and a delta or a beta, you call it. And then you heard lenifibranor, which is a pan PPAR. Okay, so different kinds of PPARs, and you heard about their actions. So I'll start with, our recent NAFLD nasal, I would say, the consensus guidance paper, not really the guidelines. And what we said, and obviously the pharmacotherapy biopsy-proven NASH, but yes, if the biopsy is not possible, I think you can probably take this decision maybe based on non-invasive assessment also. And if you need to have a significant fibrosis. For SARO, we had given a weak evidence and a level 3 evidence based on whatever data was available, that this can be used in patients with F1 to F3 NASH with a weak evidence and grade 3. So why this was weak and why this was grade 3 evidence? As I said, we followed the grade system for this, and I'll show you some data on this. So as you heard Dr. Sanyal, this all started with preclinical studies, in the animal models, and this was, 2 studies, one of his studies which he quoted. And then thereafter, there was another study, the animal model study, which actually had shown that in both HepG2 cell lines and in the mice model, saroglitazar was better than fenofibrate and pioglitazone in improving not only steatosis, but NAS score, and even there was an anti-fibrotic effect of saroglitazar. Then, as I said, the first approval for SARO was for diabetic dyslipidemia. I think this was way back in 2010. And then this Dr. Kaul had compiled all these studies predominantly, where the SARO was being used for diabetic dyslipidemia. And within those, 18 studies and 5,000 patients, there were probably 3 studies where NAFLD with diabetic dyslipidemia, as I said, they had NAFLD and they had shown improvement in ALT, CAP, and LSM. So this was the initial, paper. Then, lots of studies, I think, started happening because this molecule was only in India. So most of these studies, all these studies are from India, some from US now we have, and majority of them are published in JCH, whether you look at, the Ludhiana team, whether you look at, Gangaram team, whether you look at this Tamil Nadu paper. I think lots of papers started coming in on looking at the efficacy of this molecule. Then this was the Evidences 4 study, which Dr. Sanyal was referring to. This was a phase 2 randomized control trial. Small number of patients, maybe 25 in each arm, and different dosages of 1 milligram, 2 milligram, 4 milligram compared with placebo. And there they had shown that the reduction in hepatic steatosis based on MRPDFF and the reduction in ALT levels, insulin resistance, dyslipidemia was much better in the SARO 4 milligram group in comparison to placebo and the other groups. Then he also quoted, they did this again a phase 2 study. This is a histology-based study, which is published, very small number, 16 patients. Again, they were all biopsy-proven patients. And again, look at numbers are very, very small. And this here, again, the drug was given for around 6 months. And they showed that, yes, it is better than placebo in improving the NAS score, resolution of steatohepatitis, and also maybe better in fibrosis. In India, this was a larger study which happened, and this was known as the Evidences 2 study. It was 100 patients, 10 center data, and all was, again, biopsy-proven NASH with NAS score of 4 or more, and they were, 2:1, they were randomized into the SARO and the placebo. And these were the results, and here in this study, the drug was given for 52 weeks, which is almost a year. And when you look at the reduction in NAS score by 2 or more, I think in comparison to placebo, 52% versus 23%, and there were no major adverse events, But then unfortunately, this paper has still not been published as a full paper. We recently, as I said, lots of studies were happening, in SARO in different parts. So we just compiled these studies, and these are all clinical studies which we have submitted for EASL. 44 studies have been conducted, including 7 RCTs on SARO, and the duration ranging from 12 to 52 weeks Most of these studies, looking at the non-invasive assessment either by CAP or LSM, maybe just 2 with MR-PDFF, and only 2 studies are there which are looking at only the histology. I showed you both these 2 studies. So based on this, as I said, I think we had given that weak recommendation, and the level of evidence was also 3. But then thereafter, we have had 2 more studies, and Dr. Sujit Chaudhary is here as one of the chairpersons. I think this is his data, which is a small number again, but in this study, they had taken patients with F3 and F4 fibrosis also. And this is, again, numbers are not very large, 8 patients in F3 and maybe I think 11 in F4, but they could show an LSM reduction in almost all stages, and even in F3 and F4, they have shown that there is a reduction in LSM which is happening, and in addition to improvement in CAP, AST, ALT, HbA1c, LDL, and the triglyceride. And again, I think no major issues, maybe pruritus and diarrhea in 1 patient each. This is again a very recent paper, again from Professor Sanyal's group. Shadab is the first author here, and this is the first data which has come on Saro in post-liver transplant patients. So this is again a post-transplant patients, again a phase 2A data, and this is again 30 patients. Entry point was CAP more than 264. 18 were finally included, and they showed reduction with MR-PDFF reduction, a 30% reduction from baseline, and 47% of all patients and 63% of patients with baseline MR-PDFF of more than 5%, they had reduction with saroglitazar. And again, I think this was a well-tolerated drug. There were no major issues. So what could be the end point of using this drug? I think, again, as I said, the longest trial that it was 52 weeks. So in our INAZL recommendations, I think we had given this. You can probably use it for 1 year, but then this could be individualized. You can look at the ALT reduction, which Regenerate study, taught us. You can look at MR-PDFF, which we normally don't do it. Maybe you can look at reduction in CAP and then take a call that how long do we need to use this drug. Finally, I think this was another paper from Dr. Sanyal's group. I think another, I would say, a benefit, yesterday he spoke about, the atherogenic dyslipidemia in patients with NASH. And this is again their paper where they have used this Saro and have shown that there is improvement in all these atherogenic dyslipidemia, whether it's LDL or triglyceride and the small density LDL cholesterol in patients, those who received placebo. And this, the benefit they could see as early as 4 to 6 weeks after, initiation of therapy. So, ladies and gentlemen, I'll just summarize that the experience so far with saroglitazar, I think, is probably, as I said, we have had, at least from India, 44 studies, 7 randomized controlled trials. Before that, we've had some preclinical studies in animal models, predominantly from, again, Dr. Sanyal's group and the other groups. And the initial data was in diabetic dyslipidemia, which showed reduction in ALT, hepatic steatosis. But now we have data in NAFLD with or without diabetic dyslipidemia, and it shows that it improves ALT, improves atherogenic dyslipidemia, it improves hepatic steatosis, which is seen predominantly on CAP, also some data on MR-PDFF, and only 2 studies on histopathology. It improves ALT, NAS score, and histology, as I said, only 2 studies, and there is data which is now evolving that it may also be beneficial in improving fibrosis. And one of the latest papers, as I said, is based on LSM, and then you had some animal data. There are some limitations. Most of these studies are, have small number of patients, and the largest randomized histology-based study, which is 102 patients, is still unpublished, and the data on fibrosis is sparse. So based on that, as I said, we had given that weak recommendation, and the level of evidence being 3 on this. So thank you very much for kind attention. I'll take this opportunity to invite you all for the annual meeting of INAZL happening in August in Bhubaneswar in Mayfair. Thank you very much.
Thank you, Dr. Duseja. Thank you so much. If we leave aside the data, then I can guess that in this room, everyone will have its own experience with the drug. But again, you can just sit down, we can have another talk, and then it will be an important discussion at the end of the session. Or may I invite Dr. Akash Shukla? Sir is Director and Consultant Hepatology at HN Reliance Foundation Hospital, Mumbai. And he will present a case with discussion on PPRA drugs.
Good afternoon, everybody. At the outset, I must thank Dr. Gurdas Chaudhary sir and Inazal for having me here. It is very difficult to find something new in case-based discussion for PPAR. Let's see. So I think we have discussed this time and again, that PPAR have a role in every step of pathogenesis of NASH fibrosis. This was discussed both by Dr. Sanyal and by Dr. Ajay Duseja sir about the PPAR agonists, and I think I was equally surprised by the first audience poll, just like you were. But I wanted to tell that there are certain natural PPAR agonists as well, which is very interesting. Some of the things which we are quite familiar, silymarin, resveratrol. A lot of studies now coming off on resveratrol now for different liver diseases. Chicory seed extract, chrysin, which is what is used by the bodybuilders for anabolism, filarin. Camel milk is another which has been shown to stimulate PPARs, both alpha and gamma. And ostol, which is again a very commonly used substance extracted from plants. So let's go to the case. 48-year-old lady underwent a diseased donor liver transplant 4 years ago for cryptogenic cirrhosis. She comes with high transaminases, SGOT of 49, SGPT of 112, GGT of 50, REST, LFT, CBC, all other parameters are absolutely normal. She is on adequate immunosuppression, compliant. She's on TAC level of 4.8. The routine causes are all ruled out. Ultrasound is done, which shows grade 3 fatty liver. HbA1c is 5.6. Triglycerides 165. Other parameters are normal. There is no obstruction. Surprisingly, her BMI is 19.5. So what will you do for this patient? Can we have the audience poll? Stop TAC and start everolimus, diet and exercise, saroglitazar, pioglitazone, or evaluate further. So great. So I think it's a huge difference of opinion, but I find, okay. So we actually did a bioimpedance for this patient, and if you look at the bioimpedance carefully, the weight is just 44.8 kgs of this lady, but the fat-free mass is 22.6 kgs. So almost 20 kgs of this patient is fat out of 44 kgs. And the muscle mass is just 10.8. So although it's a poor indication, but you can see this is a patient who is very sarcopenic. 50% of the body mass is fat, although the patient is 44.8 kgs. So now what will you do? Diet and exercise, saroglitazar, pioglitazone, or vitamin E? So great. So we have divided opinion again. So this patient was started on saroglitazar 4 milligrams, and she was advised strict diet and lot of exercise. After 3 months, she came back for follow-up. Her transaminases were normal now. Triglycerides had reduced slightly to 140, but she had actually gained 8 kg weight. And her HbA1c, which was 5.6, was now 6.2. So we were very confused. What is this response and what is happening with her? So again, what will you do at this stage? Patient has gained weight, 8 kgs. Her HbA1c has increased. The other parameters have improved. Continue diet and exercise, do nothing else. Stop the saroglitazar, or put this patient on pioglitazone, add metformin, or do something else. So either continue diet and exercise or add metformin. I think both reasonable options. We actually went back to the history because something was not fitting in. So this patient had a habit of having late lunch around 3 o'clock. Because of the imposition on the diet, she only started having a cup of black tea in the morning. And after that, she used to do around 1.5 hours of rigorous exercise. And by afternoon, around 1 o'clock, she would get intense craving for food. And therefore, she started binge eating in the afternoon. So we decided to test her sugar level on a routine day at different levels. And at 1 p.m., her sugar was 58 milligrams per deciliter. And that is why she was getting intense craving for the food. And that is why she was having binge eating. And that is what led to the weight gain and the high HbA1c. We just modified her diet, reduced her saroglitazar to half a tablet a day. And after 3 months, her transaminases were normal. The triglycerides came down to 122. HbA1c was 5.5, and she lost 9 kg. So she continued with the diet and exercise, except that we modified her diet and her daily lifestyle eating habits, and that solved the problem. So learnings from this case was sarcopenia is an important contributor to development of NASH, and even in people with 44 kg, you can have significant NASH, and now we know retrospectively that her cryptogenic cirrhosis was probably NASH-related. It must have been the same body build right from the beginning. Reviewing history whenever there is unexplained phenomena is very important, and go into the details to find out what exactly is happening. We have to be careful about prescribing these drugs, and when we advise very strict diets to our patients, and about the timing of the meals. And I don't know whether for people with very low lean body masses, you need the same dose or the dose needs to be reduced. I think that is something which is an open question which has to be answered probably in another study. I'll go to the second case. This is a 45-year-old gentleman on an executive health checkup was found to have a BMI of 25.5. The AST-ALT was 58 and 49. Rest of the reports were very normal. A hemogram showed a platelet count of 152,000. Rest okay. He is known case of diabetes for 4 years. He's taking metformin 1,000 milligrams per day. HbA1c is 5.9. Lipids are normal. No hypertension. Creatinine normal. No proteinuria. Ultrasound shows grade 1 fatty liver. Viral markers are negative. HOMA-IR is 1.4. Autoimmune hepatitis, Wilson's disease workup done negative. No history of any other medications. FibroScan shows a CAP value of 355 and a stiffness of 8.6 kilopascals. So what will you do next for this patient? Would you start saroglitazar, start pioglitazone, stop metformin and start saro, stop metformin and start pio, or start saro, vitamin E, and continue metformin? So majority will start saro and vitamin E with continuing metformin. I think the time given was too little for people to read the options. So the patient was started on saro plus vitamin E plus lifestyle modification. And after 3 months, HbA1c was 5.7. Lipids were normal. AST-ALT had come down to absolutely normal, 11 and 15 now. BMI 22 from 25. The only new complaint was now he was having nocturnal cough and early morning cough, which was dry. And that was the only thing which was irritating, but because of that, his sleep was getting affected. So what would you do for this patient? Assume that this is reflux related and add a PPI or maybe do an endoscopy, refer to a chest physician for the dry cough, ask for PFT, do a HRCT thorax, do the 2D echo, or do something else. Can we have the audience poll? Excellent. So I think we have, again, a divided house, but majority for adding a PPI or doing a scopy, followed by doing a 2D echo. Excellent. I think, Dr. Sanyal, you have done your talk fantastically. Everybody is sensitized to cardiology. So PPI was given to this patient. No relief, however, after adding PPI. So the patient was referred to a chest physician. The HRCT was normal. 2D echo was done by the chest physician, referred by the chest physician, normal. He did a PAFT, which showed small and medium obstructive airway disease. So he was advised inhaled steroids and bronchodilators. And with that, he had a partial relief. Around 40 to 50% relief was there. So the patient came back and he said, parameters are fine, but I'm not happy. I'm still having cough. My quality of life is getting affected. Whenever I wake up in the morning, I'm still coughing. So we had the option of either changing the bronchodilator or giving steroids systemically. These were the two things which the chest physician suggested, which we didn't like, or was to do an allergy testing to see if he's sensitive to something, or take a second opinion. So we decided to actually do an allergy testing for this patient. A skin prick test was done, which did not show any hypersensitivity. IgE was done, which was normal. No eosinophils on the peripheral smear. The cough was reduced to 40%, but still present and impacting the quality of life. So what will you do next? Send to another chest specialist, stop metformin, stop vitamin E, stop saroglitazar, or stop all NASH drugs? Parameters are all normal now. Wow. So I think still, divided house. So we actually decided to stop everything. His problem was not there of cough before we had started the therapy, so we stopped everything. And the cough actually stopped in the next 7 days. It was completely symptom-free. And then we decided to stop his asthma medications, and his cough was still absent. So there was nothing which was causing the cough when everything was stopped. So we decided to reintroduce metformin because he was diabetic. We thought that that was the most important drug to be given to him. And he did tolerate it well. And then we reintroduced saroglitazar, and the patient started coughing again in 5 days. And it was stopped again, and he again became completely free of cough in the next 7 days. So when we reviewed the literature, actually all these three drugs, vitamin E, metformin, and saroglitazar, have been reported to cause bronchial asthma. And therefore, we have to be alert and aware for unusual adverse events for these patients. So whenever you have an unexplained phenomenon which is started after the drug, we must think of this as an adverse event. And when I actually looked at the literature, this has been reported by Ratnasai and group, who have done the majority of the studies for saroglitazar in dyslipidemia and diabetes. They've reported 7.3% patients having asthma with saroglitazar 4 milligrams and 2.4% with saroglitazar 2 milligrams. So I think this is something which we have to keep in mind. It's rare, very unusual, but if it happens, we have to be alert simply because now it is being used so rampantly that the denominator has increased so much that we will get few isolated numerators of bronchial asthma because of these drugs. Thank you very much.
Thank you, Dr. Akash. Akash, please stay back. Set the ball rolling. Dr. Duseja, saroglitazar is an alpha, gamma, PPAR agonist. So why doesn't saroglitazar show the side effects of the other PPAR gamma agonist? Is it because of the ratio?
Yeah, I think it's a weak PPAR gamma. I think Sanyal will correct me. Yeah, it's a weak PPAR gamma activity. So that's the reason we don't see the typical PPAR gamma side effects of, weight gain, pedal edema, and all those issues with that.
Thank you. Dr. Akash, the first patient you mentioned was already on a TRF sort of diet, that lady. So could you have just gone on with the TRF? Because she was skipping her breakfast, so she is fasting for almost 14 to 16 hours.
Yeah, so that was the diet which she started after we counseled her.
Oh, you counseled her for it? Yeah.
We counseled her for diet and exercise the way we do, and she decided that because most of these people read online and they find that intermittent fasting is the best thing and it's the in thing. So she decided to do that, and that is what actually cause. So she was not having this diet before. This is what she started after we counseled her about diet and exercise.
Nice presentation, Dr. Akash. Both the cases were very interesting. What about Saro? Is it a particular time we should give in the breakfast? What is the best time to give saroglitazar?
I don't think there is a data on what time, but I think by and large after breakfast is what we would usually prescribe.
Akash, lovely cases as always. I was just a little intrigued by those side effects you showed for saroglitazar, 2% and 4%. There was peripheral edema seen with the with the 4 milligram dosage by about 2.4% patients and 0 for the 8 milligram. How do you explain that?
So peripheral edema is 2.4% reported with saroglitazar, 2 milligrams and 0 with 4 milligrams. So it was just one case. So it could just be something unrelated. So remember that when they report, it is not necessarily a causal relationship. It is any adverse event happening. And therefore, it may not be directly related to the medication. It could just be a chance thing.
Well, I'll just take one opinion from Professor Sanyal before we move to the audience questions. So like Dr. Duseja said, that the reason why saroglitazar does not have the typical glitazone side effects is because of the modest PPAR gamma effect. Now, there is this recent Destiny trial for with the pioglitazone. So pioglitazone, the typical glitazones as a class, they have got what we call receptor-mediated genomic actions, which are being mediated by PPAR gamma, but they also have got non-genomic actions, non-receptor-mediated actions, which play with the mitochondrial pyruvate carriers and all those things, which have been shown that in that, at least in that phase 2 trial, that it may be having. Do these drugs, saroglitazar, and do you anticipate that they could also be having some non-receptor-mediated actions?
Question to Dr. Suja.
No.
Do you want to answer? So the short answer is anything is possible, but we haven't really studied it, and I'm not aware that, I've not seen any papers on that. The Destiny trial data was a little bit confusing because they showed this anti-fibrotic benefit, but they didn't show the other stuff. For those who are not familiar with the Destiny trial, so pioglitazone is available in 2 enantiomers. So there's a dextro enantiomer and a levo enantiomer. And actually it turns out that the dextro enantiomer is actually more biological. You can separate out the metabolic effects from the weight gain by the levo versus the dextro. So the idea was if you go dextro, you will get all the metabolic benefits without the weight gain. But they did have some weight gain. So it was not absolutely pure. And it was weird that they showed this fibrosis benefit, but they didn't show some of the other things that you would expect with PPAR gamma, like improvement in fat, etc. So I think the data are a little bit confusing from that perspective.
A quick question with regard to the occurrence of anemia with saroglitazar. Maybe Dr. Sanyal could comment on that? Anemia with saroglitazar?
We have not seen it in our experience. Ajay, could you want to answer
We
this?
haven't seen that. Yeah, we haven't seen that.
So there's one case report, that's it. I don't think we have seen it ever.
Yeah, it's been reported more frequently with lanifibranor and even with pioglitazone.
Dr. Duseja, there is a question. This is a metabolic problem which is going to stay for long, say for lifelong. Why do we have an endpoint for this? Why shouldn't we saroglitazar be continued as lifelong therapy as in hepatitis B or other disorders which are going to give continuous inflammation?
Yeah, you know, you need to draw, we can't have the endpoints like we have in hepatitis B or C. This is a lifestyle, disease. So I think if something has to continue lifelong, this has to be lifestyle intervention. So I think having said that, how far should you give the drugs? I think we don't have a right answer. As I said, you can individualize your patient, but based on the studies which are available, we have come out with this guidance, that how much should you be giving vitamin E for and pio and saroglitazar. But in an individual patient, if you really wish to continue even beyond that, but obviously it cannot be for lifelong. You have to draw a line. Somebody would be responding, somebody would not be responding. And if somebody is not responding, then to continue it, for a longer period may not be really justified.
Say the patient with diabetes with dyslipidemia who was on fibrates, now started on saro, because of this liver
If
problem.
you're giving it for diabetic dyslipidemia, that's a different, different indication then. We're talking of NASH.
NASH with this. So
yeah, and once your fatty liver is taken care of, then if you start it for diabetic dyslipidemia, then it's pretty fine.
Thank you all.
Sometimes the patient doesn't want to stop. If I tell you my experience, sometimes the patient will come and I will say, after 1 year you're doing well, everything is fine. But he says, let me continue this drug, I stay well with it.
So individual cases are there. We have had patients, those who have continued sorrow with vitamin E combination for 3, 4, 5 years. We have seen that and we do get those kinds of things. But we must have some guidance. This is what I'm saying, right? We must draw a line. The lifestyle interventions is the main thing, which we must emphasize, and then draw a line how long to give a pharmacotherapy.
Yeah, Ajay, I think we have a few audience questions quickly.
Dr.
Lalit.
Harpreet.
Yeah, so
Dr. Harpreet Singh.
thanks, Akash. So in the second case, the patient was started off on saroglitazar directly. And we do have a lot of patients now in our OPDs who are no comorbidities, normal BMI, transaminitis, fatty liver. If you have excellent responses to drugs like these or the Piparaga, and you can use saroglitazar, so is it a case, do we make a case of starting medical therapy at diagnosis, or do you want to, like traditionally, wait with exercise, diet? Of course, weight reduction is not an issue because they are normal BMI people. Right? I'm talking about non-central obese also. So should we start them on therapy immediately when we see them, or should we wait for lifestyle interventions for a few months and then start Saro?
So I think in real life, we would almost always start the pharmacotherapy, although there is a good argument, especially in these people, to actually have a lifestyle modification and wait for 12 weeks and all. But I think most of them would have tried these things before they come to us, and they have been told this repeatedly. So in real life, probably I would start pharmacotherapy.
Because the traditional teachings are a little different.
Yeah.
Thanks.
Shall we have lunch?
Thank you.
It's time. And how many of you have flights or some, transport to catch in the evening? Quite a few. So I think we should break for lunch and reassemble. An optimist timing would be to reassemble at 2:15. If it doesn't happen, we'll stretch it to 2:25. But when you come in, please take the time to fill up the response forms and give us your suggestions for the next time.
Ajay sir.
Thanks to the chairpersons, moderators, and the speakers. A photograph there, please. Where is Arun Sanyal? Arun. What is your session? তুমি আগে চলে এসো।
थोड़ा आगे आ जाओ. So we are back after lunch. Kindly join us. We are starting our new session. And important announcement regarding that feedback form. Please fill the feedback form. This is very important to improve us in future. Moving to the next session, which is the debriefing of INSL guideline for managing NFLD in India. I like to invite Dr. P.N. Rao, Dr. K.R. Vinay Kumar, Dr. Asokananda Konar, Dr. Ashish Kumar, and Dr. Saines Sadasivan to chair this session. And I also like to invite Dr. Debashish Datta to chair this session. Kindly introduce moderators and speakers, sir.
May I request Dr. Mohan Prasad and Dr. Kaushal Madan to come on and then to moderate, please.
I think we are running behind, but all of you would agree that we had a lovely time today and yesterday, learnt a lot. At least I got a lot of fine-tuning info, so it was very enlightening. And now we are moving to a national scenario from a global scenario. So all our experts have come together and come out with this guidance paper on, non-alcoholic steatohepatitis, non-alcoholic fatty liver disease. So under the banner of INASL. So may I request our own Professor Ajay Duseja to tell us what is new in this guidance paper. Thank you.
Thank you, and welcome back after lunch. And again, my sincere thanks to the organizing team, Professor Chaudhary and all his colleagues. So I'll be taking maybe 15 minutes to just debrief you about the INASL, the guidance paper, I would say, which we have come very recently. This is freely available online on the JCH, site. This is so, why we, wanted this guidance paper was because the last, position paper which came from INASL was in 2015. So this was the paper, and this was that time in association with, Endocrine Society, Indian College of Cardiology, and Indian Society of Gastroenterology. Since then, say for last 6-7 years, a lot of new things had come. So we thought, let's make it, some guidance within, India. And we also wanted to be, little more practical, which is possible in clinical practice, rather than, following, what is kind of recommended in most of the other, guidelines. So finally, we have a, task force of INASL, the NAFL task force. So around 11 of its core members we met, and then we decided, and this was, COVID time, and we did this all online, and 33 working party members were then selected. And then we finally had 7 teams with group captains, and each team was then given research questions, and we had multiple virtual meetings. And most of, members of this, task force and the core committee and the working party are amongst the audience. You can see that. And even though this was a, a guidance paper, but still, we followed a proper, grade system. And we came out with, the level of evidence as 1, 2, 3, and the recommendations also as strong and weak. So the guidance, was basically on 3 things. We thought it's probably not possible, to cover everything here. So we just focused on nomenclature. There was a debate still going on between NAFLD and MAFLD thing. And then there was some issues about the lean NAFLD or NAFLD in lean, what should be. So we thought, let's sort out some nomenclature on that, diagnosis, and predominantly on the risk stratification, when to refer, how to refer, whom to refer, and what needs to be done at baseline and all that. And finally, we thought we'll come out with the, treatment. So, as I said, for the nomenclature, as I said, I think these all 33 members had actually discussed on multiple virtual meetings under, as I said, 7 groups. So I'll not be able to show you the whole data, but maybe some of the consensus which we finally reached, and then this is what I'm telling you. As I said, this is all paper is freely available online, and you can have a look at the disease. So as far as the nomenclature was concerned, I think NAFLD versus MAFLD, I think it was discussed, and finally I think the consensus was that probably I think that MAFLD is obviously, NAFLD, we know there are deficiencies with NAFLD. Professor Sanyal was also pointing out that. But then, the MAFLD is probably not a good replacement, because there are issues with even MAFLD as the, terminology. So we said till that time, I think we probably need to continue with NAFLD. Let's see, EASL ASLD is also undergoing this consensus, meetings, the Delphi rounds. The 4th round is almost over. And, so finally we will have something, maybe steatotic liver disease or something will come out. But till that time, we said that we continue with NAFLD, number 1. The second thing we said was that, when we say NAFLD in lean, or when we say lean NAFLD, we always take into account only BMI. Over India, we were saying that anybody who has a BMI less than 23 would be called as a lean NAFLD. But then nobody, talks about the central obesity or, the visceral adipose tissue, which is so very important. And within the lean group, I think there's a lot of data which has now come in, which shows that these patients are, majority of them are insulin resistant. They could be, centrally obese. So we suggested that, yes, in addition to the BMI, I think the central obesity, which is clinically assessed, by waist circumference, should also be taken into account, while, calling somebody. These are, not really, we didn't have very strong evidence for all this. So the recommendations here are weak, you can say, and the level of evidences are also 3. But this is what we thought it was. As far as the diagnosis was concerned, I think, again, I'll show you the flow, how these patients come to us in the clinic. Most often they will come to you with an ultrasound report, which is actually showing a fatty liver, which is being done, say, for elevated liver enzymes or for dyspepsia or whatever. So I think the ultrasound and the CAPS are, the usual modalities by which they have been kind of diagnosed. But the thing which we kind of, again emphasize was that you should not just somebody who comes to you with elevated ALT, rather than just calling him as NASH, which may not be right, because it's kind of a histological diagnosis. I think it may not be a good idea to differentiate between NAFL and NASH just based on the ALT, and you can just call it as NAFLD with elevated ALT. Then we focused more on, non-invasive assessment. We saw, because, our own data, the consortium data had shown that, that the liver biopsy in clinical practice is not really maybe widely accepted. So we said that the liver biopsy can be done only if there is a discordance, between the non-invasive results, and if there is a competing etiology, which are, standard, guidelines by other societies also. So we said that you can probably do the liver biopsy here. Otherwise, I think maybe you can just stick to the non-invasive assessment, ultrasound, CAP, APRI, FIB4, and all those, and maybe then take the help of elastography, and these cutoffs can be taken. Specifically for NASH cirrhosis, we said, again, I think if you look at the ASLD recommendations, they would say that the patient should have had a biopsy diagnosis of maybe NASH in the past to make a diagnosis of, say, NASH cirrhosis. Then again, this was discussed. We know that the fat tends to disappear or tend to decrease with the onset of fibrosis and cirrhosis. So I think this is what, again, with a weak recommendation we had given, that once you have excluded all other etiologies of cirrhosis, and if somebody has obesity or central obesity, and in addition there is another metabolic risk factor, you can probably call him as NASH cirrhosis rather than just calling it as a cryptogenic cirrhosis, because most of these cryptogenics are NASH cirrhosis, and this was another recommendation which we had come. As I said, the risk stratification is very, very important, whom to send the patient to, for the, tertiary care level, and, the kind of, the setups we have at a primary health care and the secondary health care levels, I think we know. So these are, again, the, the guidelines, the Western guidelines, where they would use different, steps to, non-invasively assess them, maybe initially by FIB-4 or NFS, and then there's a second line which they are suggesting for like fibro test, fibrometer, HAPA score. Most of these are patented scores which are, proprietary items, and then obviously are not available in this country freely and are costly. That is number one. And secondly, all these, cutoffs are predominantly focusing on what we call the advanced fibrosis, which is F3 or more. But then we said, we again discussed this issue, and we said that probably that F2 is equally important, and I'll show you data on that. And then we said that these patented scores may not be easily available, so I think we need to be simpler. And even though we know there are issues with APRI, we know there are issues with FIB-4, we also know there are issues with, vibration control, transient elastography or FibroScan, but I think in the kind of prevalence we have and the kind of, this disease, we said that I think it's good to just use these two simple scores of, APRI and FIB-4, and then, liver biopsy, as I said, only for discordance. And again, if you look at this, MRE is again not really available in most of the centers. So I think what we said was that once you come out with, diagnosis of, fatty liver, either incidental or whatever, or again, this was a suggestion that if possible, I think the American, College of Endocrinology had suggested some screening for obese or diabetic people. Once you have fatty liver, we said you just use two scores, and predominantly at a primary and a secondary healthcare level, where you may not have access to, the transient elastography also. So you can use these two simple scores of APRI and FIB-4 and predominantly to rule out significant fibrosis, which I said F2 and more. So if you're pretty sure that this patient is unlikely to have significant fibrosis, I think it's just good to continue with lifestyle interventions at the primary level or at the secondary level. And I think you can then maybe, follow him up maybe yearly, too early, depending upon, and look at his metabolic risk factors and control those metabolic risk factors. But if you're not sure whether you have, really excluded significant fibrosis, I think the next step which we were suggesting is that you basically do a transient elastography. We know that the transient elastography may not add much to already, APRI and FIB-4, but yes, this is, as I said, the FibroScan is now kind of pretty widely available in this country. So we said that next step could be a FibroScan, and then if your LSM value is less than 8.2, I think you can still presume, and maybe you can rule out the significant fibrosis, which is F2 and this thing. And then again, these patients can be, on your follow-up, and then the lifestyle interventions and the control of, metabolic risk factors is what is required. If the patient is suggestive of cackled, or even we more than 13.6 based on the meta-analysis, we said they can even be called as cirrhosis. I think they need to be managed on the usual lines of, cirrhosis. I think again, but if the, this is kind of here between 8.2 and 13.6, I think then in addition to lifestyle interventions, we suggested that yes, a decision to consider, pharmacotherapy, NASH-specific pharmacotherapy can be considered even without biopsy, if the biopsy has not been done. So I think these were the recommendations. As I said, we tried to be simple as possible. And just to show, why did we choose, F2 and significant fibrosis, and why not advanced fibrosis? There's again good data to say that even F2 patients, if you look at their all-cause mortality, is obviously higher than those who are F0. We know that fibrosis is a major determinant, but that even at F2 you can have, and even the liver-related mortality can happen even at F2. And yesterday we did discuss this paper, about Dr. Sanyal's group, where the cardiac events and the non-hepatic cancers, they are similar across all fibrosis stages, which means that even at F2, obviously they can happen. So we said, I think we probably need to just exclude the significant fibrosis or F2 and then take a decision depending upon what it turns out to be. Why did we, APRI and FIB-4, as I said, are widely available, and why did we just choose that, 0.45 and 1? Again, there's an Indian data which we looked at, and then this actually had shown that, APRI of 0.45 kind of, excludes any kind of fibrosis, or at least excludes, significant fibrosis. And similarly, there was Indian data on FIB-4 cutoff, which they said that 1.3 may be a little inappropriate for, significant fibrosis. Obviously, it excludes advanced fibrosis. So there they had come out with this, 1 as the cutoff. So we followed this 1 as the cutoff to, exclude the significant fibrosis.
So once the diagnosis is made, I think the lifestyle interventions, as I said, I think are pretty clear. I think we didn't, they're almost similar to, what is available in the Western guidelines, the kind of weight reduction, the kind of calorie restriction, kind of exercise, and, again, the data on bariatrics surgery and the EBMT is really not available. So I think we gave these recommendations. And finally, coming to the pharmacotherapy, again, we said that, again, this paper, again, I think we did discuss yesterday about that. When you talk about lifestyle interventions, again, 5% weight reduction, in this particular study by the Gomez, the 5% weight reduction could be achieved only in 30%, and the 10% weight reduction could be achieved only in 10%. And somebody who already has NASH and significant fibrosis, and the other groups, many people are not able to exercise, not able to achieve, target. And so even without biopsy, if you think that patient has significant fibrosis or NASH, I think based on your non-invasive assessment, in addition to lifestyle interventions, you can take a decision to, add pharmacotherapy. And this, slide I had shown in pre-lunch also. So as I said, biopsy proven, if not significant fibrosis or non-invasive, and then you can choose between, how to choose between vitamin E, Pio and Saro. Again, I think we had given those, some of the questions. Somebody has diabetic dyslipidemia, goes in favor of Saro. Elderly male, just, little the risk of CA prostate, some data had shown that. So we said maybe you can avoid vitamin E. Somebody already with cardiac risk, or postmenopausal females, you avoid pioglitazone. So those kind of, recommendations we had given, that how to choose between the drug. Finally, the control of metabolic risk factors is very, very important. And, the diabetes, hypertension, dyslipidemia, they need to be managed, like the usual lines. And the statins obviously are not contraindicated even with elevated liver enzymes. Yes, the caution needs to be taken once they go into decompensation. And I think, again, we had some discussion yesterday on, the evaluation of the cardiac evaluation in these patients. Again, the data was, not very good, but then we came out with this recommendation that if somebody has NASH with advanced fibrosis, and especially if they are associated with, diabetes, I think they probably can be evaluated for the presence of, cardiovascular disease. Now, how to do it? Again, I think there was some discussion on that. The time will not permit me to go into that. So to summarize, ladies and gentlemen, I think, as I said, these recommendations or guidance paper is now available freely online. So we have spoken about nomenclature, as I said, NAFLD, MEFLD, also about, the lean NAFLD. The diagnosis predominantly is non-invasive, liver biopsy only in select situations, discordant, or when there is a competing etiology. And risk stratification is very, very important. You can do it with APRI and FIB-4. Rule out significant fibrosis, and if you're not able to rule out, do a transient elastography. Control the metabolic risk factors, very, very important, with or without pharmacotherapy. And pharmacotherapy in NAFLD only if you have either histological NASH, or if the biopsy is not available, NAFLD with significant fibrosis, non-cirrhotic. So here we're discussing all non-cirrhotic, not in cirrhosis, and how to choose between the three, vitamin E, Pio, and saroglitazar. I think that was also given. And finally, we said you need to have a holistic approach, and the evaluation of all the metabolic risk factors and the extrahepatic organs is also very, very important and need to be done on the case-to-case basis. So thank you very much. And again, my invitation to all of you for INAZL 2023 at Bhubaneswar, 3rd to 6th August. Thank you.
Thank you, Dr. Ajay. Apart from the scientific content, which, as you said, that is really available, the way the meetings were conducted, I must tell you something. Apart from the physical necessity, the mother of the inventions, as we know, we got a saying. During the time of the COVID, how to get over it? He has made the groups with a one group captain with 3 or 4 people in that particular group. Every group used to meet independently, separately, go into the details, and then come for, every group has been given one question in this one, and then they used to go details and come up with a solution, and again total meeting used to occur with everyone. And this indicated to me that as far as the physical meetings when it is concerned, this is, I think you can club these two things in your, this is a very excellent way which we went into the real depth and then formulated the consensus.
Thank you very much, sir. I think Dr. Rao was the president of INAZL that time. This all happened under his guidance.
No. Everything you have done, I was only director of this.
Yeah.
Can I ask one question?
Yes, please.
Very
Yeah.
nice presentation indeed. Is there any reason you did not include obeticholic acid in the treatment schedule?
No, we have not done that because OCA, again, is still pending approval from FDA, number one. And leave aside the FDA approval, we discussed about the FXRs in the morning, the kind of profile, the side effect profile, the pruritus, the dyslipidemias, I think still, we said, I think we have written about OCA, rather we have written about all the newer agents in that guidance paper and discussed the pros and cons, and finally we said, I think probably we can't approve it for the time being. Yeah.
Some of them have been written in the text, rather than
text,
the recommendations, you will find them in the text.
Yeah, Ajay, great presentation. Of course, we've all seen those guidelines. My question is a little more practical. Now you say, if I have a patient who has an ultrasound showing fatty liver, a FIB4 or greater than 1, and a VCT between 8.2 and 13, am I obliged to start an anti-NASH pharmacotherapy? Or is it acceptable to ask the patient to continue lifestyle modifications?
No, it's
in this category, you're given, INAZL recommends vitamin E, vitamin and pioglitazone, and a weak recommendation for saroglitazone. But what about the option of not giving pharmacotherapy?
No, absolutely. It is open. I think we are just giving, as I said, this is just a guidance. So we are just saying that, yes, you can consider a NASH-specific pharmacotherapy, but then if you still want to try the lifestyle interventions and see, it's possible after 3 months or 6 months as LSM drops down to less than, say, from 8 to, say, 6 or 7, I mean, it's fine. It's okay. I mean, yeah.
And in any compensated cirrhosis, suggest you use a cutoff of 13, but even a little more than that, even you don't want any specific therapy, even vitamin E you don't recommend?
We are not recommending because, again, other than the Dr. Nagachala Sani's retrospective data on vitamin E and the metformin data, again, from the same group, and now the recent data which has come up, I think we did not have a large data in the reverse trial is also a failure on OCA. So I think we were not recommending any drugs for cirrhosis.
Yeah. Many congratulations for bringing up this nice paper with a lot of updations and all. What I like most, in fact, is the definition of the lean NASH, You have added the waist circumference there,
Yes.
So that's something is actually something good, which will avoid quite a lot of confusions. And if you just go through that, there can be some overlap between the Bovino 7 in the liver stiffness measurements, etc., which probably may be addressed properly. And something which probably I wondered, in fact, is here, during the pharmacotherapy, which everybody will be looking for the guidance here. Well, we are dealing with only 3 or 4 drugs, but then how it can be modulated in critical circumstances, that probably people would like to go for. For example, in the case of the saroglitazone or the other medicines, these patients will be admitted with, say, diabetes, with some critical illnesses, What happens? Suppose the creatinine is going up a bit, so how you should be able to modulate, whether you need some sort of modulation or not. Probably you may be able to looking up to that. That also can be included there. That's my suggestion.
Thank you.
Excellent.
Right. So before we end, just one, I think, comment, what Dr. Shiva Prasad said, and I agree with him, that beyond 13.6, we have not considered as an indication for pharmacotherapy because of the studies which have excluded biopsy-proven cirrhosis. Since we are not doing biopsy and not recommending biopsy, an LSM value of, say, 14 or 15, I personally feel should not be considered a contraindication for pharmacotherapy. I think this message should be clear.
No, it's not a contraindication. Yes, it's, obviously not a contraindication. There's a possibility that 13.6 may not turn out to be a cirrhosis, which is a likely chance. Yeah.
Yes, excellent talk. And just
Thank
wanted to want to know, saroglitazone, for those people who do not have dyslipidemia, is there any data for that?
Yes, the Indian study and lots of other studies which I showed pre-lunch paper on SARO, the SARO has been used with or without dyslipidemia. So that's possible, yeah.
Right. I think we have to close now. Thank you, Dr. Duseja.
Thank you very
much. Thank you. Thank you very much. Thank you.
Dr. Duseja, to the panelists, to the chairpersons, we have to move on. Flights to be caught. There's quite a bit of rain going on. So we move to the next one. In the interest of time, what I thought is we'll probably change the sequence. we'll first have the presentation by Neeraj Saraf. So Neeraj, as you know, is a transplant hepatologist. And it was felt, there was a lot of debate going on as to how much should be the role of transplant hepatology in this NAFLD meet. So Neeraj obviously had his heels dug in, and we were wondering how it would be. But nevertheless, I think Neeraj has a lot of passion in this area, a lot of experience. So we'll go ahead with that. May I request Dr. Sanjeev Sehgal, is he around? Dr. Sanjeev, please come over. Dr. P.K. Agarwal, Dr. Ramesh Rupray, Dr. Konar, are you still there? And Dr. Murugan, Dr. Debashish Datta, he probably just left. And Kaushal, you are still there. Somebody's glasses. A person who is finding it difficult to see, raise your hand. Oh. Over to you people for this discussion.
Thank you, Professor Chaudhary, for giving me this opportunity to speak on this topic, and also for having me in the organizing committee. It's been a great learning experience. So I think the final answer to most problems in hepatology is liver transplantation. That may be a little bit of a bold and overstatement, but I think it's true to a large extent. So let's see what are the challenges in transplanting obese NASH cirrhosis. And like Dr. Chaudhary said, this is a transplant topic deviating a little bit away from, and I think most of the audience here would be non-transplant gastroenterologists or hepatologists. But we're all seeing these patients, we're all referring them for transplantation. So I think it's important to know the challenges. And I think even post-transplant, there are at least 10,000 transplant recipients in the community now in India. And all gastroenterologists and hepatologists are seeing post-transplant patients, and we should be aware of the challenges that these patients may have. So obese recipient is generally defined by BMI of more than 30. So we have a obese NASH, and then we have NASH, and we have obese non-NASH. So can these three be sort of loosely interchanged? Well, theoretically, no, but for the purpose of this talk, I'm going to be sort of loosely interchanging them because there's very little data or experience only on obese NASH. So there are a lot of papers on obesity, a lot of papers on NASH. Obese NASH is a very specific term, so I'll use these terms loosely a little bit. Most of the NASH we know are obese, and a lot of obese patients do have a NASH, and even alcoholic or other etiology patients who are obese, who are non-NASH are obese. So what are the challenges in transplant for obese NASH cirrhotic? So there are pre-liver transplant challenges, challenges at or peri-transplant, and challenges after liver transplantation. So on the left side, you have the implications, and on the right side, you have the interventions. So pre-transplant, you have an increased waitlist mortality, increased portal vein thrombosis, and the interventions, I'll talk about more detail, trying to reduce the weight, evaluate for cardiovascular disease. At the time of transplant, there's probably increased morbidity and mortality, longer ICU stay, and more infection, and the intervention is to have strategies to prevent infection and manage comorbidities. And after transplant, there's a question whether these patients have a poorer survival. We'll talk of that again. More cardiovascular events, recurrence of NASH, more de novo malignancy, and renal issues as well. Now, if you look at the top right corner, I've added something there. For me, this is the biggest challenge in transplanting obese NASH in this country, which is predominantly a living donor liver transplant. So I asked 5 of my colleagues at different centers that for you, what is the biggest challenge in transplanting an obese NASH patient? And everyone said finding a donor. So I'll talk of that a little bit during my talk. So prior to transplant, there are a lot of challenges. NASH is clearly the most increasing cause of HCC among patients, and the proportion of HCC related to NASH has increased several fold, and we should keep this in mind while evaluating a patient for liver transplant. Obesity, NASH, or patients with metabolic syndrome have higher CKD, and that is a challenge in pre-transplant, trying to maintain their creatinine, and probably seeing whether they need a liver alone or a liver plus kidney transplant. Most of the patients with morbid obesity who have NAFLD are often have sarcopenic obesity, and there's a recent paper that a significant percentage of them had myosteatosis, which can negatively affect waiting list mortality and post-transplant outcomes. And once obese patients are listed, there is a higher chance of developing portal vein thrombosis, and we should be looking for this complication regularly. So there's a higher risk of cardiac morbidity and mortality in patients waiting for liver transplantation. In patients with NAFLD, they're at higher risk for cardiovascular events compared to those without NAFLD. In patients with end-stage liver disease, severe peripheral vasodilatation can mask myocardial dysfunction and have a condition like cirrhotic cardiomyopathy, rendering pre-transplant cardiovascular stratification difficult. There may be arrhythmias, and in obese, there's possibility of obstructive sleep apnea and cardiopulmonary related complications, which increases surgical risk. So they should have a detailed cardiac evaluation. I'll not go into details, which has different levels. And so starting with medical history, going on to echo or a dopamine stress echo, and then finally angiography if needed. Again, in patients waiting for transplant, there is more decompensation and higher waitlist mortality. And this is a paper which showed that compared to normal weight and overweight patients, there was more decompensation in the obese patients. And another study by Shklansky et al. Published in Liver Transplantation showed that in patients who had a BMI of up to 40 or more than 30 had significantly higher waitlist mortality as compared to those with normal weight. So how can patients prior to transplant be managed for obesity? Well, we've talked of, I'm not going to go in details, we've talked of weight loss, caloric restrictions, but these are not easy in decompensated patients. There's some papers on intragastric balloons. We published one study of a small number, 10 patients, a few years ago of pre-transplant patients. And our aim there, again, was to reduce the weight to improve their graft recipient weight ratio so that they could adequately be transplanted. Bariatric surgery, not a great option in decompensated patients, and probably should be reserved for compensated patients who don't have clinically significant portal hypertension. So probably patients who are listed for transplant, bariatric surgery is not a great option. Now coming to donor challenges and what I talked of. So for example, of an average height, you have a BMI of 30 or 35. So you have a 100 plus kg recipient. So finding a donor with right lobe volume to give a GRWR of 0.8, which is a standard, and a left lobe volume enough to have a residual volume of at least 30% so that the donor safety is not compromised is not easy. And if you find such a donor, most of the times their liver will be fatty because they themselves probably are overweight and fatty. So this is a major problem, and it's a logistical issue in transplanting patients. And what happens if you give them a smaller liver? So they have small for size syndrome, which is defined as bilirubin more than 5, ascites more than 1 liter per day, coagulopathy, with the exclusion of other technical issues. So how can we overcome this challenge of a small for size syndrome? This is something we published a few years ago by modulating the portal inflow by doing a hemi-portal cable shunt. We can use patients with GRWR of 0.7, and we had similar results of 0.7 with portal inflow modulation as compared to patients with GRWR of 0.8 or more. Dual lobe liver transplants have also been done, and they've been shown to have equal results as compared to single lobe transplants. Now, what about issues at the time of transplant or peri-transplant? So this is a single center study from UK, large number of patients, and this showed that patients who were obese had significantly higher ICU stay, longer hospital stay, more infections, and more ascitic fluid drain, and the total infective complications was significantly more than non-obese. And again, another meta-analysis which looked at obesity and early post-transplant survival, and most studies favored the lower BMI group with lesser complications. So coming to long-term challenges, what are the outcomes in a obese NASH or a obese cirrhotic versus a non-NASH or a non-obese patient? These patients have more cardiovascular events, regular monitoring is needed, and NASH is an independent predictor of chronic kidney disease. Managing immunosuppression is again an issue. They tend to gain more weight after transplant, and obviously a large percentage of them have a recurrence of NASH after liver transplantation. So there's various studies which have looked at outcomes, and surprisingly, when I went through the details of these studies, there are conflicting data on the outcomes of obese NASH or obese even non-NASH patients versus normal weight patients, and there are large studies, and so this one by Saab et al., 76,000 patients found no association with BMI, although the control group had malnourished patients, and that was criticized. Another meta-analysis showed that morbidly obese patients had higher 1, 2, and 5 mortality rates. So there's conflicting data on long-term outcomes, and probably more data is needed. This is a recent paper published in Transplantation, which showed poorer outcome of NASH patients. This is SRTR data from the United States, and there was significantly higher poorer outcome in NASH patients as compared to non-NASH recipients. Now, this is an interesting paper published in Liver Transplantation by Satpathy, which actually showed that overall survival in NASH patients was better in the obese as compared to the non-NASH patients. So if you look at the top left corner, the overall survival in NASH was better in the class 3 obesity patients as compared to the normal weight patients, and similar was the graft survival. And so their explanation was that the insulin resistance improves in obese NASH patients, and that is why they probably have a better outcome. And I think a lot of studies also probably there's a selection bias, and I think the obese patients are selected very carefully, and maybe that's why they have a good outcome after liver transplantation. I think this is just to show various studies which have shown that there is significant recurrence of NASH after liver transplant, and a lot of them have not just NAFLD but NASH and fibrosis. And this is our own data, small group of 30 patients showing that almost 1/3 had NASH, and of them, half of them had significant fibrosis on follow-up. I think I'll skip this. Again, managing recurrent NASH after transplant. This is again something we sent to the ILTS, which is next month. A small data of 30-odd patients on saroglitazar, which showed that it improved dyslipidemia, improved the CAP values, and the ALT values. And I think there's one more paper from Dr. Sanyal's group, which was presented at AASLD last year, of showing similar results in 10 patients in the post-transplant. Immunosuppression, again, is a challenge, and because most, the group of drugs we use, corticosteroids, tacrolimus, cyclosporin, they all cause obesity, and they all cause components of metabolic syndrome. So you have to weigh the, sort of balance it out, and probably use a small dose of mTOR inhibitors with reduced dose of TAC when feasible. I think I'll just skip this. Management of obesity after transplant. I think drugs we've already talked of. Bariatric surgery is probably a good option. Sleeve gastrectomy is the preferred way to do the surgery, as because other Roux-en-Y gastric bypass has more potential for malabsorption of immunosuppressive drugs. So my take-home message is there are pre-transplant, peri-transplant, and long-term challenges in the care of obese NASH cirrhotic. There are renal and cardiac issues which need to be assessed prior to transplant. There is increased waitlist mortality. Obesity, we should try and manage prior to transplant, although that's not easy. I think it has to be done in the compensated stage and not when a patient is actually on the list and decompensated. It is very difficult to decrease obesity at that point. In living donor transplant, appropriate donor finding is the biggest challenge we face. To have an adequate graft volume and portal inflow modulation and dual lobe are ways to overcome this. Obese NASH patients have higher infections, longer ICU stay, and hospital stay, although there is heterogeneity on data on the long-term outcomes. Recurrence of NASH, renal and cardiac issues are common, and recipients need to be monitored for these throughout their post-transplant period. Managing immunosuppression is also a challenge in NASH patients and in obese patients. I think a lot of drugs which are coming up could be possibly used, although there is no data in post-transplant patients, and maybe endoscopic procedures or sleeve gastrectomy can be done in obesity after transplant. So obese NASH cirrhosis is here to stay, and we probably have to act on the NASH or the obesity part in the earlier stage, in the compensated stage, and not when the patient has decompensated. I think it's too late really to improve their obesity at that point. Thank you.
Yeah. Thank you, Neeraj. I think that was very elegantly, covered, and you really, spoke of the things which are really practically relevant. And we all know in LDLT, donor is the biggest issue. But having said that, when we actually compare our results in obese versus non-obese, we've been together. Because of careful selection, there's a bias probably. Overall end results are really not so different.
Yeah, that's what most of the data also shows. But I think a lot of data is midterm, and it's not really a lot long-term. Yeah. So I think we need probably more long-term data to really show that they have similar survival.
Right. Neeraj, one practical question, I was just thinking, in your presentation, you said that the obese people, you try to downgrade them first. At times you do a sleeve gastrectomy, an intragastric balloon and other things. Don't you think that...
No, I didn't say that for pre-transplant. So I don't think you can do bariatric surgery in a decompensated patient.
That is what.
No.
So basically, what I basically, what I gathered was, probably that you want to downgrade the thing, do a surgery and then go for a transplant again?
No, so I think it's very difficult to decrease the weight for the patient who is going for liver transplantation. I think it's very difficult. You can't really they can't exercise, lifestyle modification is difficult, and you cannot do any surgery. And I showed some papers on endoscopic treatment. So bariatric surgery, I think you have to reserve for post-transplant obesity, not for
pre-transplant, isn't it?
And Neeraj, so you have a recipient 35-40 BMI. The surgeons now are happier to do lower GRWR with inflow modulation. They have more experience, so they are pushing for that. In South, we have the option of DDLT. So do you think we should really try to get the weight down as much as possible, maybe using a balloon? What do you do when you get a
situation? We did a small series of balloons. These are only, again, you can't really put a balloon in a patient with CTP score of 10, ascites and varices and encephalopathy. So that too was done in a very select group of patients. A few of them were compensated, had HCC or had early decompensation. So I think for an obese patient, probably DDLT is really the only answer. LDLT is very difficult.
Thank you.
I think one message which I got from your talk is that once the patient has reached a stage of transplant with obesity, you transplant them with whatever challenges you've pointed out, and be aggressive for obesity management in the post-transplant.
Definitely.
I think that should be the message.
Definitely.
Thank you, Neeraj, for a wonderful talk.
Thank you.
Thank you very much, everybody. Neeraj, thanks. Thanks to the chairpersons and the moderators. We move to the next session in the interest of time, because I think quite a few people are getting very jittery about missing their flights. So we'll go to the last session first. So this is the special talk by Dr. Arun Sanyal. May I request Dr. P.N. Rao Dr. Sarin is not here. Dr. Narendranathan, Anup Saraya, Harpreet Singh, Sunil Jain, Dinesh Garg. And if there are still seats vacant, may I request Parimal Lavate to join me? You have a flight to catch? You can wait. So this is going to be a very important talk because this more or less tells us what the future is going to be like. And nobody better than Arun Sanyal to tell us what it's like. After that, if we have time for 10 minutes, we'll go through the panel discussion for the case-based application of therapies for NAFLD, which Manav and I will do.
Okay.
Over to you, please.
Yes, so thank you. So you already heard about GLP-1s, you heard about FXRs, you heard about PPARs, we talked about vitamin E, we've talked a little bit about bariatrics, even transplant. So we've covered a lot for therapeutics already. So I was wondering what I should talk about over here. So let's see, So I'll break this up into sort of a more pathophysiologically oriented approaches. So let's first talk about therapies that focus outside the liver, because the liver is a victim in NASH. And transplant is a great example you just heard. When we put an organ in, that organ has no fat in it. But within a year or two, it's full of fat, and then it starts getting steatohepatitis and fibrosis. That tells you it's not the liver, it's everything around the liver that's driving the disease. So that has led to a lot of interest in trying to find therapeutics outside the liver. And a story that is emerging is that multiple endocrine axes are dysfunctional in these patients. So we've known about hypothyroidism and fat in the liver, and now there is evidence that at a cellular level, even when your circulating thyroxine TSH levels are normal, there may be cellular hypothyroidism. But another axis that is now emerging is hypogonadism. So it turns out, as you see over here, that if you look at obese male patients, about 72% of them with fatty liver disease are hypogonadal. That is, their free testosterone levels are below the lower limit of normal. And in biopsy-proven NASH, we found 62%. So this is in an otherwise unselected population of 71 patients who are obese and had NASH. So that's a remarkable finding, that such a high number of patients actually are hypogonadal. And what you see on the right, then, is the decrease in MRI-PDFF when you bring their free testosterone levels back to normal. And we're not talking about supratherapeutic treatment of with testosterone. This is just bringing them to physiologic range. And you can see an improvement in ALT and an improvement in MRI-PDFF, and a substantial number of people actually completely losing the fat in the liver. So histology data are currently being generated for this. Another axis that is abnormal is the growth hormone axis. It turns out normally you release growth hormone releasing hormone in a pulsatile manner, and this changes in these obese patients who develop fatty liver disease. And downstream of growth hormone is somatomedin and IGF-1, which importantly regulates visceral adipose tissue. And what we see over here in this study of tesamorelin, which is a synthetic GHRH releasing hormone, is that it reduces liver fat at 12 months. And there is actually histologic data in a patient of NASH in the context of HIV using tesamorelin. And this drug is actually approved for visceral adiposity in the context of HIV, and now is being tested for garden variety NASH. The third thing we learned is from our bariatric patients is that even before the patients start losing fat, their glycemic control gets better. And so before they lose weight, they already are getting better metabolically. So that led to the idea that maybe there's some signal from the duodenum where the food is being excluded from that may be driving all of this. So that led to the idea that you can basically do a duodenal mucosal ablation And this is done through this procedure called the fractal procedure, where you do a submucosal injection and then you put sort of boiling water in there. It's pretty crude, but it basically creates a surface burn and the mucosa sloughs off. And compared to sham scoped patients, they get substantial weight loss, improvement in hemoglobin A1C that lasts for up to 18 months after a single session. And the basis for this is that, as you can see in the histology, when you move to a diet of highly refined sugars and fats, all of the neuroendocrine cells that are distributed along your length of your GI tract are concentrated in the duodenum. And the duodenum mucosa hypertrophies. And so instead of having an ordered meal-stimulated endocrine response from the gut, all the hormones get released all at once from the proximal gut. So if you ablate that, you actually get substantial amelioration of the dysmetabolic state that occurs in these patients. Very exciting new data. We've already talked about GLPs and moving into oral small molecule agonists. I will not talk about that. And here are the data for SGLT2s, which don't have the same effect size. They are not as potent as the GLPs. They do seem to have some defatting properties of the liver and probably be additional add-ons in the context of diabetes management or cardiovascular management for these patients, along with the GLP-1, to manage their overall metabolic. And I suspect, given the number of patients with NASH who have background diabetes, and that number is rising as the population is aging, that the majority of our patients will have GLP and SGLT2s as background therapies, and then everything else will be sort of added on top of that. So with the SGLT2 inhibitors, there is now also a SGLT1/2 inhibitor. So the SGLT1 is in the intestine and 2 is in the kidneys. And so this blocks sugar uptake from the intestine and then prevents reabsorption in the kidneys. So you get a larger reduction in systemic sugar and you drive the gluconeogenic pathway. And these data show that in an early study, you get this really nice improvement in ALT, body weight, and GGT. And this paper has just recently been published in Nature Medicine. Now let's focus on the liver. So what we have learned is a 4-step mechanism in the pathogenesis of the disease, where the first step is the delivery of excess lipids and sugars to the liver, and that turns on the metabolic machinery and puts it in overdrive. That produces metabolic stress that leads to cell injury, cell death, triggering inflammation, eventually fibrosis, leading to cirrhosis. So this, of course, gives us 4 different approaches to therapeutics. But for practical purposes, most of the therapeutics is based at the front end, at the metabolic end, because you're treating the root cause. Now, we've already talked about pioglitazone. We talked about the other PPARs. And this is the DESTINY trial that we talked about briefly. And this is the dextro enantiomer of pioglitazone, which has been shown to improve some of the features of steatohepatitis over here, but not all of them. Talking about FXRs, we had a long talk earlier, but remember, when the bile acids bind to FXR in the intestine, you release FGF19. FGF19 development for garden variety NASH has been stopped. There is still an ongoing trial for cirrhosis that will read out, and we'll see what it shows. Now, FGF19 and FGF21 are quite related. They're part of the same FGF family. And they bind to these receptors called FGF receptor 1C, 2C, 3C. Now, whereas 19 binds to FGF receptor 4, FGF21 only binds to 1C, 2C, and 3C. So FGF receptor 4 is liver specific. So FGF19 is more liver specific. FGF21 has effects in the liver as well as elsewhere. And now each FGF21 molecule is a little bit different because of its varying potency for 1C, 2C, or 3C, and the degree to which it can penetrate the CNS. And FGF21 works both centrally to change our metabolic status, and it basically induces weight loss, thermogenesis and insulin sensitization, whereas the FGF19 works like a FXR agonist. So the first generation FXR FGF21, pegbelfermin, unfortunately failed in both bridging fibrosis and in cirrhosis. But a new generation molecule called efruxifermin showed really nice data, and these were shown at ASLD, where 41%, this is per protocol assessment, of patients getting 50 milligram dose compared to 20 had a fibrosis improvement without worsening of NASH. And almost 76% of these patients actually had NASH resolution. So our therapeutics for NASH is getting better and better. Here again, you have both highly significant improvement of both the NASH and the fibrosis. And very importantly, in their early study with cirrhosis, they found, now very small numbers, only 12, but they found 4 of these patients actually had at least a 1-stage improvement compared to none of the patients in the placebo arm. Again, very small numbers, but again, larger studies will need to be done to confirm whether this works. Now, this shows the cartoon of sort of how sugars and fats combine to add to the fatty acid pool in the liver and then lead to triglyceride. Just about every step of this has been tested in one form of clinical trial or the other. I'll go through some of the high-level ones. One is the fatty acid bile acid conjugate, which blocks the last, after you form fatty acids are very toxic, so steroyl-CoA desaturase basically desaturates the fatty acid, and this blocks it. And this, with the Aramcol, led to it's a modest effect, very well tolerated, but at high dose does produce improvement in NASH resolution and a small trend towards fibrosis improvement. It is currently sort of, the development has been held up, but hopefully it'll get back on track. Probably the most exciting other drug in the NASH space we have not talked about today are thyroxine beta receptors, which are liver specific, and in the liver it makes the liver oxidize the fat and burn it off. It improves mitochondrial turnover, reduces oxidative stress. And so resmetirom is the first thyroxine beta receptor, and it reduces liver fat, resolves NASH, lowers LDL, lowers triglyceride, all of which are things you want in a NASH drug. So here are the data from their phase 3 study. So these are large numbers, and you can see over here highly significant improvement, both at 80 and 100 milligrams for NASH resolution, and again, similarly, improvement in fibrosis stage. So this is likely to get approved as well. So I think we are getting close to actually having drugs that will both resolve the NASH and improve fibrosis. This is very liver-targeted therapies. This is not changing the systemic milieu and does not have the systemic effects of thyroxine. And then, of course, the future is combination therapies. And this is the Gilead trial where you have semaglutide along with a ACC inhibitor, which is Fircostat, and a FXR agonist, which is Salofexor. And they are acting at different aspects of the pathophysiological cascade of the disease. And the early data show an improvement in liver enzymes and ELF, and we have to see more data coming out. But I think this is sort of where the field is heading towards. Eventually there will be combination therapies. And once we know what OCA 10 milligram does, once we know what saroglitazar does in large numbers of patients in fibrosis, a combination of something like saroglitazar plus a low-dose OCA, other type of things are going to come in the future. So I think we are really at a transformative point in NASH therapeutics. We have a number of drugs. You saw the OCA data for fibrosis, which is the first generation molecule. Then you saw lanifibranor, which had both NASH and fibrosis benefit. GLP-1s, which have very high NASH benefit. Fibrosis, maybe we have to see how it comes out. Then we saw FGF21, which has very significant effects on both NASH and fibrosis, and maybe even possibly something in cirrhosis. And then we're seeing the combination GLPs that look incredibly effective and producing almost 70-80% of the patients are getting massive defatting of the liver with improvement in ALT. And now you're seeing some combination therapies come through. So I think I am very, very hopeful that as we go through this meeting year after year, I remember 3 or 4 years ago, we had the meeting and somebody said, so we don't have really any treatment for NASH. And we have a very different situation today. And I think it takes time. Good science takes time. Hepatitis C took 20-something years of drug therapeutics before we started saying we can cure it in 95% of people. This is not an infection. We're not going to cure it. We have to treat root causes in society. We have to root causes of food availability, lifestyle, mental health. All of those things have to come into play. But I think these drugs will buy us time for the patients who are already in trouble while we work on all of those things. So I think that's a good place to stop this lecture, get you guys all back to your airport or home or wherever you have to be. I thank you for coming and thank you for your attention.
Can we say that time is not far off when we will be able to reverse cirrhosis?
Well, that is very difficult to predict the future, right? But I think, I don't know, if the FGF21 data, holds up, that'll be really, really exciting. But there's a small number of people with after bariatric. If you catch them when they have compensated cirrhosis, there's a small number of people where you might actually be able to induce. And with these drugs that produce bariatric level weight loss, maybe there might be an option down the road. But it's very hard without data to be absolutely certain of that.
Sanyal, this hypogonadism was studied in adult population? Or
adults. This is all in adults. Adults.
They are not studied in the children?
Sorry?
There's not study in the children. How do they behave?
No. This has only been studied in adults.
Is it reversible?
Yes, exactly. Well, if you lose weight, your hypogonadism improves. But on the other hand, if you improve the hypogonadism, the weight gets better too. So we found, this study was originally being done for obesity. And I met these guys somewhere and I started talking. I told them, how about you look at the liver, So then the liver study's been done. And actually, the histology, the fat gets better, not a big signal on fibrosis, but certainly just what it's also telling us is that the entire metabolic machinery in the body is out of whack. When you start gaining weight, one of the first things that happens is that you have clock genes in your hypothalamus that control the pituitary axis. And the clock genes evolved in plants and in cellular systems that when the metabolic machinery requires energy and all life has to be sustained by energy. So the metabolic machinery, if it is turned on when there is no light, because they all made light, ATP through photosynthesis, was a waste of time. So it would turn off. So these genes evolved that would turn on only when there was sunshine. And so that's the root of our clock genes. And the clock genes regulate our entire body's machinery of when the genes get turned on, when they get turned off. And that's the first thing that gets wacky. And downstream of that is the pituitary. So everything that the pituitary does gets wacky, and pituitary is the master controller of the endocrine system. So then everything falls apart.
Thank you.
Sir, such a wonderful lecture. I have a doubt, sir. So nowadays, there is a gut microbiota being taken on a separate marker being considered in the management of NAFLD. So there are more than gut microbiome alterations around Provitella and Bacteroides, so many things being considered. So what is your opinion in the newer spectrum when you're going to manage a patient with NAFLD with gut microbiome alterations?
I personally think that, I'm not talking about probiotics and all that kind of stuff, but I think the microbiome plays a very important role in NASH. I also think that our understanding of how the microbiome affects the disease is in its very, very early stages. So we have a lot to learn. And thinking that we can just do some fecal microbial transplant, this is like, bringing a hammer to something that needs a chisel. You create a huge perturbation. We have to have a much more refined understanding of the microbiome. I think it's going to be very important, but we need better understanding of the microbiome to properly leverage it for therapeutics.
Dr. Sanyal, I just have one question. One of the pathways of disordered metabolism is with relation to uric acid, which also, part of the whole dysregulation. But I don't see much of interest in looking at trying to target changes in uric acid metabolism.
Yeah, actually it was done. We did it, and there was drug-induced liver injury, so we had to stop. So
conventional drugs like febuxostat and all are not going to be effective in...
Yeah, so the uric acid is part of the inflammasome pathway, and there have been a number of inflammasome inhibitors that have been tried. And there was an oral inflammasome inhibitor that was studied for NASH, but it produced DILI, so that development was stopped.
Anything related to personalized medicine which you foresee in NAFLD? Like phenotypes in...
I think the future will be precision medicine, and I think NASH is the poster child for where it would be quite beneficial, because you can bring in the genetics, and we need to learn more about people who have specific genetic background. What are the drivers of the disease in those patients? And similarly, there's genetics, there's alcohol, there's diet, there's socioeconomic status. I think in the future, once you have data on thousands and thousands of patients, they can be put into these AI-based algorithm development models, which might be able to tell us that if you fit certain criteria, you're most likely to respond to something or the other. Or alternately, when we do a liver biopsy, instead of just getting all this fatty steatosis score and all this other stuff, you get a molecular readout which says, here are the pathways that are driving your disease. For you, not
recent clinical gastroenterohepatology has a review on mathematical models not that I understood much of it.
Yeah, so we also published these, but I think they're still in very early stages, and these are also relatively smaller studies. Because the disease is so heterogeneous, I think we're going to eventually need much larger populations to be able to have robust enough models to be able to say something, to give clinical guidance.
Thank you, Arun, for excellent presentation.
Thank you for having me.
And with that, I would like to thank all the moderators.
Special thanks to Arun. After all, he's the one for whom all these NAFL conclaves have been a big success, and thanks that he comes every year and spends his time. Thank you so much. I have to put something to vote. We are actually more or less on time. So we had a 10-minute panel discussion just to put in perspective what we have learned over the last 1.5 days, 1 day. Are you in the mood for it? 10 minutes? Okay, so this is, how to actually apply it on the bedside. So may I request Manav, and Manav speaks better than me, so that's why I've actually passed on the job to Manav. And may I request a few people to join us on the panel. So Dr. Sehgal, PK, are you there? If you can join us. Akash, would you like to join us? And Dr. Ramesh Ruprai. This is, this is a bit retrogressive. We are going back into trying to see how to use what in which scenario in practice. Kaushal, I think you're also up there. Yeah. So it promised that it won't take more than 10 minutes, and after that we'll conclude with our vote of thanks.
So I guess my credentials are now Fortis Memorial Hospital. That's what the board says, but it's okay, it doesn't matter. No, my credentials said Fortis Memorial Hospital. It's okay.
This is a musical chair in the private sector here in Delhi.
So might as well be joining very soon. Thank you, sir. Thank you for the kind words you said. Now, the idea of this panel is not to give you heavy data. You've already gone through most of the data throughout the day. We have 5 cases. The question is same in all 5 cases. The choices are same. Many of these choices may be correct. The idea is just to put in perspective, when you see 1 or 2 points in a patient, then you might like to choose one over the other. It's not comparison. It is just to get our mind straight over such a data-heavy day which we had today. So let's straight away go to cases. 30-year-old man, grade 1 fatty liver on ultrasound. He's got family history of NASH cirrhosis. BMI is 32. Waist circumference 105. Comes with pain in right upper quadrant abdomen. Cardiac work is found to be normal. Enzymes are mildly raised, 46 SGOT, 50 SGPT. HbA1c is borderline 6.1. Fasting blood sugar again borderline 106. Platelets are normal, BP is fine, cholesterols are more or less okay with the LDL of 126, TG is slightly high, LSM is only 6, and CAP shows 278. Now that's the audience poll. All of us who are here, I would urge you to vote. So just lifestyle management, lifestyle plus vitamin E. Lifestyle will form the backbone everywhere. Lifestyle saroglitazar, lifestyle OCA, or GLP-1 agonist. Which one of these? So as I said, many of these options can be exercised. What do you think is the most appropriate in this case? Voting, please. So most of us think lifestyle management. Akash, what is your thought on this? This is a guy who doesn't have any fibrosis, but enzymes are raised, and there's a family history. Would you like to treat or not?
Yeah, I would actually treat this patient. So I think semaglutide will be a good option for this patient. 100 plus kg weight.
So we have not tried lifestyle modification yet.
So with, I mean,
so it's actually a touch and go.
Like I said, the textbook answer is lifestyle modification. But in real life, I will probably put lifestyle modification with semaglutide.
I think that's where we stand today. If you offer only lifestyle modification, you're absolutely right. Because whatever data we have shows that NAFL, without fibrosis, without significant inflammation, has same survival as compared to general population. It is only fibrosis which predicts poor survival or significant inflammation. This patient probably does not have NASH. We don't have a biopsy to confirm that, but only lifestyle modification may be good enough, but most of us will choose to use one of the drugs just for the, I would say...
weight loss, yeah.
Weight loss, you can prescribe weight loss with exercise also. We have not tried that, but yes, for weight loss you can do that. Okay, case number 2, 50-year-old woman. Diabetic, metformin for 5 years, reasonably controlled sugars, fasting 117, HbA1c 6.3. BMI is 25, overweight category according to Indian criteria. LDL cholesterol is 150, TG is normal, hypertension on RX. So all metabolic syndrome components are there. AST, ALT similar to the previous case, 45, 65. Platelet counts are normal, but this is a difference. LSM is 7.5 now. We know 7.58 is round about the cutoff for a F2 fibrosis. So we are looking at some fibrosis. And ASCVD risk is moderate. What would you do here? Same question, same choices. Audience poll, please. So most of us will use saroglitazar here. Why not vitamin E? Vitamin E is a good drug to use. It's a licensed drug. It has been shown to improve inflammation in these patients. Data on fibrosis is not there, but even on sero, data on fibrosis is not there. 2 points I wanted to make. We are aware about the PIVANS trial. Dr. Sanyal did that in 2010, and we have seen the follow-up data also on that. I just wanted to make 2 points here. 1, diabetic NASH, vitamin E is safe. So we used to believe that all data is on non-diabetic NASH, but that now we have enough data. We have randomized controlled trials using vitamin E in diabetic NASH, and results are similar. 1/3 of these patients do respond. Secondly, long-term use of vitamin E. Again, there is validated data that you can use vitamin E for longer than 2 years without any significant side effects, setting aside all your problems of prostate cancer and other things. So, Kaushal, are you happy with only vitamin E, or you want to go to something else? This is a almost normal BMI person with normal lipid profile.
I think in both the cases, I would have used lifestyle plus vitamin E, or maybe in the first case, lifestyle plus saroglitazar. But in this case, definitely lifestyle plus vitamin E, because she's heading towards F2 fibrosis, not reached there, but maybe in real life practice, I would give vitamin
Probably.
E.
So whenever we are looking at fibrosis, we would be treating them with NASH therapeutic medications. Of course, we'll do lifestyle management. Of course, we'll want to control the blood sugars. We want to control other risk factors. LDL is 150. You'll give statins also. But NASH therapeutic drugs come into picture once you start seeing a fibrosis developing in these patients. This is the other point which I wanted to clarify here. Okay, third case. We have only 10 minutes, mind you, so 2 minutes per case. I'm not taking longer than that. 62-year-old male diplomat, diabetic for 25 years, detected raised ALT, AST around 100. That is around 3 times of upper limit of normal nowadays, the ALT limit which we have. He had a recent out-of-country posting and stopped statins and part of anti-diabetic therapy because it was not available in the African country where he was posted. So gliclazide was stopped and he continued insulin. His weight is 85, BMI is again overweight category. He is a smoker. All components of metabolic syndrome are there. On treatment for diabetes, on treatment of hypertension. He has a BMI of 28 and dyslipidemia, which was controlled on statins, but now the LDL is 150, TG is normal. Has schizophrenia, on clozapine, aripiprazole. Ultrasound shows severe steatosis and LSM of 10.6. Now we are looking at F2 fibrosis definitely, maybe F3 fibrosis. And he has severe steatosis, CAP score is 344. Same audience poll. What would you use here? Only lifestyle vitamin E or other options? Can we have the audience poll, please? I can't see the, okay. So, C, Saro. We are all sold out on Saro. The only drug which has been shown to reverse fibrosis, Dr. Sanyal pointed out, is OCA. You have F2, F3 fibrosis. If your patient can tolerate the medication, as of now we have more evidence for reversal of fibrosis for obeticholic acid compared to either Saro or vitamin E. GLP-1 agonist, we need more data. Again, the NEJM trial which we talked about, the fibrosis reversal did not reach significant this thing. So if I have to choose out one drug for a significant fibrosis patient and there are no other contraindications, patient is not, it's not an obese patient. Dyslipidemia, you use statins for that. So I'll probably use OCA. But as I told you, all these options are correct. You are good using any one of these, but we have to remember what makes you choose one medicine over other. That's the whole idea of this 5 cases which we are discussing. So advanced fibrosis, not cirrhosis, OCA. Please also remember that the trial which was carried out in compensated cirrhosis using obeticholic acid, there has been no improvement in primary endpoint. It did not meet the primary endpoint. So for as of now, in cirrhosis, OCA is contraindicated. Yes, Ashish, please. I understand that. So we're just trying to place each one drug according to the benefits which is offering over the other drug. It is not approved, but we know how approvals are. You can always take a consent and use it, but I'm not asking you to use OCA. I'm trying to place the drug according to the benefits of that drug. So if you have cirrhosis, absolutely no question of using obeticholic acid as of now today. We may have evidence further later, but today F2, F3 fibrosis, the reversal is seen in other, with OCA. 4th case, 55-year-old male, fatigue and right upper quadrant pain, the usual presenting complaint, has recently gained 12 kg over last 6 months, borderline hypertensive, 33 is a BMI, 108 is a waist circumference, no alcohol, not a known diabetic. Undergoes evaluation and we find that he has possibly signs of cirrhosis here. So 105 by 80, HbA1c, so this is a recently detected diabetes. He was not a known diabetic, now he is detected to have diabetes. Higher uric acid, low platelets. So most likely we are dealing with a compensated cirrhosis with a high BMI. Audience poll, please. Drug of choice. Audience. So the house is divided between Saro and GLP-1 agonist. Dr. Rai, what would you do, sir? BMI 33, cirrhosis, diabetic. OCA or, GLP-1 or Saro? The audience is confused.
I think recent weight gain brings him closer to the GLP-1 agonist to be used in this patient because he needs to control his blood pressure, weight. That is
absolutely. So whatever discussions we had throughout the day, the best weight loss with all the medications available is with GLP-1. We have standalone, we have data that it can be used even in a non-diabetic patient. This patient has diabetes in addition to being overweight, has cirrhosis. We have data on liraglutide and semaglutide that they are safe in cirrhotics. So why not GLP-1? I would say GLP-1 over a Saro here. Since Saro, we currently have no data in cirrhosis. So we are talking about cirrhosis. OCA is contraindicated. Saro has no data. OCA, GLP-1 agonist has been shown to have significant weight loss as well as control of diabetes as well as reversal of NASH. So my choice of drug here would be GLP-1 agonist.
But Manav, I'm surprised nobody's opting for vitamin E.
See, vitamin E goes in every prescription.
No,
so
maybe your choices are wrong, but...
No, see, I said all choices are correct. You are not wrong in choosing any one of these 5. This was a disclaimer I gave you that each one of these choices can be correct. I'm just trying to place each drug according to...
Which one is good? Which
one is good? Vitamin E.
Yeah, with or without vitamin E. Each of these choices can have vitamin E.
I think among these only vitamin E has a data, although in a retrospective trial, over long-term use and with good liver-related outcomes.
So GLP-1 has data in a prospective trial, in a randomized control trial, in cirrhotics and a long-term outcome. So that's the reason better. So vitamin E can still be used, but GLP-1 would be a good option here.
Do you have experience with the semaglutide oral?
Sir, not me. Because IV drug is difficult to procure. I've used oral, but I have not found very good results, although the number of patients are only a few. So I'm not in a position, but the data which is available, and Dr. Sanyal telling us his own experience, it seems to be the wonder drug.
I have used on 10 patients by now. In last 6 months, it has been giving a wonderful result, except for the nausea which comes a lot in a few of them. But one problem is that, the whole thing boils down to the cost. Because from 3 to 7 to 14, once you increase, there is a significant weight loss, but again, we do not know the end point. If you stop it, as Dr. Sanyal was also telling, you again start getting the
weight. So that actually goes for every drug we are talking about, as of now in non-alcoholic steatohepatitis, or should I call it MAFLD? I don't know. Last case, last 2 minutes. 48-year-old gentleman referred for raised ALT detected during workup for dyspepsia. Diabetic for 7 years, on OHAs. BMI, again, overweight category, no hypertension. AST ALT 150-150. Albumin normal, platelets normal, viral markers negative, cholesterol TG 248, 215 cholesterol, and a LSM of 8.5. Again, you're looking at fibrosis here with significant dyslipidemia, hypertriglyceridemia. All choices are correct. What would you give? Audience poll, please.
No, people will go for 3. Okay.
All right, so I thought we should honor the sponsors by giving their drug at the last. so saroglitazole is what I would use. Panel is open for any comments.
I think Manav, I have just one thing. Excellent, point, very clear. But what Kaushal was telling earlier, like in the case, which said severe fibrosis and severe fatty liver, there will be scope of polypharmacy. There will be more than one drug to have. Like OCA is not very good for steatosis. It's good for fibrosis. So you maybe combine vitamin A and OCA together. Maybe that's something we'll have.
So combinations are something which we are looking forward to more data, and I think there are exciting days ahead for management of non-alcoholic steatohepatitis in days to come. Thank you all for very patient listening. Thank you.
Thank you.
I think the most important underlined term that Manav used was that all the 5 prescriptions are right. And 2 things you have to keep in mind. One is the cost of the medicines, their availability, and your familiarity with the use of the drug. So just because it's a new drug, you may not be very confident using it, but if you are comfortable with a drug which you have more experience with, no problem. If you get the patient to work a little harder on the weight. Thanks a lot, Manav, for chipping in. And now I think it's the time to say goodbye. May I request Dr. Rinkesh Bansal, the organizing secretary of this conference, to propose a vote of thanks. May I also request all the other organizing committee members, Ashish and Manav and Kaushal, to kindly join on the dais with Rinkesh. Anybody else who's here from the organizing committee? Neeraj, yeah, Neeraj is there. And the young boys who worked so hard, if they're around. Please.
Dr. Ajay.
Yeah, go ahead.
डॉक्टर अजय दुसेजा निकल गए ठीक So this is official thanks to all the faculty all the speakers who delivered their lectures beautifully, all the chairpersons and moderators who conducted sessions very well and make us to complete the 2 days Evangine time. I also want to thank all the delegates who took out the important time from their tight schedule and they attended this conference. I also want to thank all the organizing team who worked very well in last 3 months. And at the end, I want to thank our sponsor, Zydus, who did great support to us. Thank you all. And Miss, our partner, Miss Healthcare also.
No, I think the organizers, Maisha, they need to be thanked. The hotel staff here needs to be thanked. And of course, our sponsors have been the main people. Yeah, they need a picture. Please take a minute to fill up the feedback form. That will be very useful for us for next year.